Good morning.
Good morning, everyone. Welcome to our Public Health Committee hearing this morning. We are now live on YouTube, and we are also recording. We're all set. This morning's public hearing, we have a number of bills on the agenda. Before we get started, I see our good co-chair, Senator Anwar. Good morning. Welcome.
Thank you, Madam Co-Chair. Good morning. I'm remote for a little bit, and I look forward to listening to every conversation we're going to have. Thank you.
Thank you, Senator Anwar. And as is often the case, our members are juggling multiple committees and work in district, as well as other obligations. And so I know that Senator Summers and Representative Clara DeStitria will be joining later. I will offer Rep. Carpino if you want to make any opening remarks. I know you've spoken with Rep. Clara DeStitria as well.
Thank you, Madam Chair. Yes, folks are all over in the building today, so I just don't want the public to feel disrespected in any way. We'll all be juggling. But I just want to take a moment and acknowledge that this has been a busy week in this committee, and I really just want to thank the staff for the time and the dedication that they have given both the committee members and the public. It has been a long and busy week here, and I appreciate all the work that goes on behind the scenes. Thank you, ma'am.
Thank you, Representative Carpino, for those remarks, and I could not echo them any more loudly. We are incredibly grateful and fortunate, and could certainly not do the work that we do without the folks who are supporting us behind the scenes. So with that, we are going to begin our public hearing. And first up, we have Commissioner Nancy Navarrete, who is here with us. It's wonderful to see you, Commissioner. And as you come forward, I will also just remind folks listening and watching that many members will listen to the hearings after the fact and also read that written testimony as well. Commissioner, welcome. It's great to see you.
Thank you so much. Good morning, honorable members of the Public Health Committee. I am Nancy Navarrete, Commissioner of the Department of Mental Health and Addiction Services. Thank you so much for raising two bills at the request of the department, House Bill 5515 and House Bill 5517. You have my written testimony, and I'll briefly highlight the purpose of each bill, and certainly happy to answer any questions that you may have. First, House Bill 5515 focuses on expanding access to life-saving opioid overdose reversal medication. Just for a little context, in Connecticut, overdose deaths have declined for 4 consecutive years. Last year, DEMAS distributed nearly 80,000 naloxone kits, exceeding our saturation goal. We note this progress to hold ourselves accountable and to continue benchmarking our efforts. This does not suggest that any level of opioid-involved death is acceptable. We remain far from pre-crisis levels, and we will continue with this committee's continued commitment and focus to endeavor to further reduce preventable deaths. In 2023, the FDA approved the first over-the-counter, or OTC, nasal spray capable of reversing an opioid overdose. Prior to that, if you remember, prescriptions were required to access this life-saving medication, and many statutes still reflect that earlier framework. As a result, outdated language and perceived regulatory barriers can still complicate our distribution. The bill addresses those issues in 2 ways. Section 1 updates education statutes to ensure students, teachers, and other school personnel have the same immunity protections provided under Connecticut's Good Samaritan Law, and removes unnecessary training requirements and restrictive language regarding who may administer opioid antagonists on school grounds. As remember, it's now an over-the-counter medication. Section 2 clarifies that state agencies and community organizations may distribute, like DEMAS does, over-the-counter opioid antagonists, and exempts free distribution. Again, that's what we do. We do not charge from the non-legend drug permit requirement. Together, these changes help expand access to opioid antagonists in schools and underserved communities and support continued efforts to prevent overdose deaths. While expanding access to life-saving medication is critical, addressing the overdose crisis also requires reducing stigma and supporting recovery. That brings me to House Bill 5517. This bill promotes recovery-friendly, person-centered language throughout Connecticut statutes. One important part of DEMAS's mission is reducing stigma, and language plays a significant role in how individuals experiencing substance use challenges are perceived and treated. Most of the bill updates outdated terminology and statute to align with modern clinical standards and the terminology used in the DSM-5, Diagnostic Statistical Manual of Mental Illnesses, the principal authority for behavioral health diagnoses in the United States. For example, the bill replaces terms such as detoxification and with withdrawal management, opioid or opiate addiction with opioid use disorder, and substance abuse with substance use. DEMAS collaborated with 18 state agencies to ensure these updates are consistent across statutes. The goal is to reinforce a respectful, recovery-oriented framework that supports dignity, inclusion, and access to care. DEMAS is committed to working with the committee and stakeholders to review any specific concerns to ensure clarity and address any concerns regarding any unintended impacts. The proposed updates largely reflect modern clinical terminology and establish best practices designed to reduce stigma and support recovery.
Excuse me, Commissioner, but you've reached your 3 minutes. Thank you.
Thank you so much. And
Thanks.
there are some technical changes that we proposed as well. Happy to review that if you like.
Thank you, Commissioner, for your testimony. I think it would be helpful, actually, if you would review the technical changes
Sure.
also. I appreciate the testimony on the 2 items so far, but if you could go through those technical issues, that would be great.
Sure. In HB 5515, we were asked to take a look at defining the word person, so we're happy to discuss that more with LCO to come up with that definition or to land on the fact that perhaps it is well-defined enough in the statute. When working with SDE, one line in the bill, training is limited to only being required if staff will be using the non-FDA approved version. So if somebody's getting IM, for example, that's not over the counter. And in these instances, SDE would like to preserve the 2 vehicles for being able to get training. One of the vehicles was inadvertently left out, and so we put that back in. My staff went over and made changes in over 100 instances, and there were 2 instances where we missed abuse, and so we're requesting in those 2 instances that we strike abuse and insert substance use disorder. In one case, it's a matter of wording where there's, it says substance use disorder issues, and you wouldn't say both of those. You would say substance use disorder or substance use issues, and so we're asking to be able to choose one of those. And in Section 112, one sentence that we had taken out was left in, and we're happy to discuss this. It's a confusing part of the statute that puts very rigid parameters around who can serve on advisory boards, and so we would request permission to take that sentence out as originally proposed. And that was it.
Thank you, Commissioner, for your testimony.
Sure.
And as always, we will be working closely with you, the chairs and ranking members, to address some of those issues as we go forward on this. I'd like to start just by saying thank you. Thank you to one of my Fairfield Board of Ed reps, Jennifer Jacobson, who first flagged this issue for me And I know your team, along with others from SDE and others, I believe, worked together in the off-season to bring forward this proposal to again, continue to do more to spread the availability of Narcan and to be sure that everyone was clear. And I think this bill is just a wonderful example of how people at home see issues and our local leaders see issues, and working in concert with you as the department, as also the folks who have been leading the effort on the opioid settlement funds as well. It all comes together really well. So I appreciate that. And I appreciate the technical notes on some of the changes in language. Are there questions for the commissioner? We're a lot quieter than we were earlier this week. But I know, as I said, we will, I know, be meeting with you and your team following the hearings and as we go into JF so that we can work together on getting that language right. But thank you so much again.
Thank you for your support.
With that, we will turn to Commissioner Manisha Jutani on the other side of the room. Welcome. And Commissioner, as you come forward, we do the 3 minutes so you can introduce, but I will just warn you that I think we're going to have a few more questions for you than for our previous commissioner testifying. Welcome. It's nice to see you.
Nice to see you all. Thank you for having me here today, and good morning to the distinguished members of the Public Health Committee. I'm here specifically to talk about 6 different bills, and I will do just a brief high-level summary so that we can delve into each a bit more with questions. The first is House Bill 5513, which is DPH's various revisions. We have a series of technical adjustments to be able to help execute on a number of our public health functions that we can go into later. The second is House Bill 5510, which is an act concerning unlicensed institutions and practice. Currently, if someone is operating a healthcare facility without a license, they are only subject to a $100 per day fine. This would give us the ability to fine facilities and unlicensed practitioners at the same rate that we fine licensed practitioners and facilities. I want to give you a few examples of the types of situations we've had in the past year. The first was the unlicensed operation of an elder care home that resulted in the death of a resident who was trapped under their bed. We had limited authority to do anything in that situation because they were unlicensed. An unlicensed person performing laser hair removal that caused burns. An unlicensed person performing Botox injections that caused MRSA and other staff-associated infections. I will let you know that this week, I received another complaint around a facility that was operating unlicensed regarding elder care. We have to work with the Attorney General when we don't have this type of authority, so we are looking for a bit more to be able to put some regulatory authority over those that are doing unlicensed practice. The third is House Bill 5512, an act concerning real property change of ownership. Currently, a facility goes through a change of ownership with DPH, and we have regulatory review of the history of the licensee and the management company, but we lack the authority to look at the real property owners. That's the owners of the actual building. Sometimes they're involved, sometimes they're not. Currently, we don't have the ability to look into who is actually involved in that transaction as it relates to the real property. The fourth is House Bill 5511, an act concerning consent orders. This is asking for the opportunity to forego a hearing when a consent order has already been agreed to by a licensee and the department. We have read some of the feedback that has already been submitted with testimony and are open to clarifying language. We are only hoping to forego a hearing when the licensee has already agreed to the terms of the consent order. The fifth is House Bill 5518, an act concerning various revisions of environmental health and drinking water. These are a number of technical revisions that we'd like to put in place. And the last is House Bill 5519, an act concerning on-site wastewater specialists and water operator apprentices. Similarly, happy to go through those details. Thank you.
Thank you very much. That That's helpful, and I wonder if we could dive in a little bit more to each of those, and I'll just go through, if you want to go back, through the order on the agenda, either way, just to, if you could, maybe flesh out within each of the bills a little bit more detail, and you did in the first example, I think, did a good job giving us an understanding of that specific circumstance is a terrible and tragic example of why this authority is needed. But in some of the others, maybe give us a little bit more of the background and the thought process behind it. Thank you.
Thank you. So in 5513, which is DPH's various revisions, the first provision is to give DPH the authority to appoint a licensed embalmer to take possession of remains abandoned by a funeral home director, or embalmer. This is in response to a situation we had this year where a funeral director abandoned a home and there were remains in the home dating back to the 1960s. We had no authority to put in place somebody to manage the situation in that home. We were fortunate that many people in the industry came forward and dealt with that situation. We are not looking to impose anything or impose the cost of anything on anybody. All we are looking to do is be able to appoint somebody who would be responsible in that type of situation. The second is to allow DPH to issue pre-July 1st, 1997 death record data in an electronic format. Currently, we need to provide it in a print format. We are seeking the authority to be able to do that electronically. The third is a technical correction to reflect the change in name of Hospital for Mental Illness to Hospital for Psychiatric Disabilities Hospital. This name change occurred in 2009, but has not been consistent throughout the statutes, so we are looking to have a consistent name so that all references can be the same throughout various statutes and regulations. The fourth is clarifying terminology in the food code statutes by extending the use of the definitions that appear in the model food code to additional statutes. Again, it's trying to standardize language across the various different areas where the model food code is referenced. Similarly, we want to update the term qualified food operator to certified food protection manager. This is again consistent with the model food code language that has already been adopted through regs review. The next is to make changes to the statute for medical orders for life-sustaining treatment, or MOLST, to allow those to be in electronic format. Currently, they are not allowed to be electronic. And the last is allowing us to use aid services funding for PEP, or post-exposure prophylaxis, and PrEP, pre-exposure prophylaxis, to be used to cover pre-treatment and monitoring lab testing. Currently, the way the statutory language is written would suggest that we can only use it for medications. We are looking to also be able to use it for lab testing that people would need to undergo should they be on those medications. I can take questions on that, or would you like me to continue on to the other bills?
Actually, Commissioner, thank you for pausing, because as you all know, and for those who are watching and listening, the various revisions bill does contain a number of various revisions, so it has quite a few items in it. Just a question about the MOLST orders. The electronic format, that is allowed but not required, is that correct?
My understanding is that right now we do not allow the use of that, but I can clarify to confirm, that we don't allow the use of electronic, that it is a paper order that is required right now.
I should have put this a little more clearly. Will the paper still be allowed?
Yes, paper would still be allowed. It's just that we would also allow electronic.
Okay, I think that's important, and thank you. Are there other questions on the various revisions bill for the Commissioner before we move on? Representative Dauphiné.
Thank you, Madam Chair, and through you. I was just curious for the technical or electronic versus the paper version. I know a lot of other institutions do that, and what they have morphed into is charging people for the paper form because now they offer it electronically. Do you foresee that?
That is not something we have contemplated at this point. This is really not, I believe, though, at the level of the state, because the MOLST has been put forward as a paper document by the state, and the state would allow electronic use. Now, what individual institutions, how they operationalize that, I can't speak to that. So I don't actually know of a circumstance that you're describing, but I can't speak to what individual institutions will do.
Yeah, thank you. I just know that's kind of what's happened. But thank you.
I
Appreciate it.
appreciate it.
Thank you, Commissioner. Before you go on, if I may, just take a moment of personal privilege, and since it's a little quieter today, welcome Dr. Kiki Kennedy and the residents who are here with her visiting today. So I know as a fellow Yale doctor and leader, you might like that to hear that as well. So back to you, Commissioner, if we could keep going through the rest of the bills. Thank you.
Thank you, and it's always a pleasure to have trainees in the audience and look forward to how policy is actually put in place and come to fruition. So thank you for all joining us today. Okay, so going on to the next bill, I did go in more detail on this bill on 5510 already. This was on the unlicensed practice of either facilities or of practitioners. I do want to be clear right now that a licensed practitioner or facility can be charged up to $25,000 a day currently. And unlicensed provider or facility can be charged $100 a day. So all we are looking to do is bring unlicensed practice in line with licensed practice. Any other clarifying questions on that one?
No, Commissioner, thank you. You see me nodding my head. That's just makes a lot of sense. So thank you for that clarification. I think that's an important issue to underscore for the members of the committee.
Thank you. The next is around 5512, which is regarding the real property change of ownership. I also did go into some detail, but just to explain a little bit further, what we have found in our last several years of undergoing change of ownership reviews of facilities is that because we now are able to look at the history of the licensee and the management company, the next level up in the way that many of these institutions are structured is the real property owner. And there are times when the real property owner, in fact, is somebody who we know has had troubling interactions with the state as it relates to being either a management company or the licensee. Without being able to look at who the real property owner is and get more detail on whether they are in fact going to be involved in day-to-day operations or other financials of the given institution, it does not allow us eyes on the full spectrum of what a given institution that may have difficulty down the road would be dealing with. So this would give us the ability to look at the real property owner. We would also be amenable to the idea of a waiver if there's something in the lease agreements or other things where the real property owner can demonstrate that they are not going to be involved in the day-to-day operations or financials of the institution, but in fact are just really a building owner. So that is what this bill is proposing.
Commissioner, just a clarifying question on that. What I understand this to do is to really be clear about the people who are involved at that level of decision-making. And when you said troubling interactions, can you give us an example of what that might look like and kind of perhaps the circumstances that are leading to this?
There have been situations where it becomes clear that a real property owner is giving money to the management company or to the licensee for certain operations and then expecting some payback potentially. And that type of interaction that may occur between a property owner and those who are actually managing the facility, if we know what the circumstances are in terms of that type of arrangement ahead of time, then we would be able to set certain parameters around the involvement of that person in the day-to-day operations of what the facility may have to undergo.
And just to be clear, that person or entity, and when you say payback, sometimes that has a negative connotation. You mean the terms of the agreement that is the arrangement? Is that what you
I'm
mean
giving
by
an
that?
example of situations in which we may be called in for a troubled facility. And when we are trying to ascertain, do you have enough supplies to take care of the patients for the time period that you have going forward? Do you have enough staff on hand? And then we start examining a bit more their day-to-day operations, and we see flow of funds and impacts from entities other than those known to us. The payback word was whatever their internal arrangement might be between the owner and the management company and the licensee. But again, if we never knew that that owner was involved to begin with, then that's not something we would have even entertained as something that could have been problematic down the road.
Thank you for that. And I would say that for us here, maybe similar to the idea of the situation with Prospect that occurred, and just making sure that we have the full understanding of the scope of the issues, particularly when there are issues that will involve you, and that implies some level of trouble or concern.
And I would just like to add that DPH does not really have eyes and authority over the financials of the facilities. That usually is more in the realm of DSS, because they are the Medicaid agency and they're the agency that is actually dealing with the financials. However, what we do have to do is ensure healthcare quality and safety for patients that are in a home. So the example I gave is in the context of ensuring financial viability to provide healthcare quality and safety. We have come across instances when there have been actors involved that we weren't expecting at the table in a given home, because we didn't have the full view of the levels of participation and ownership in a given facility.
Thank you for that. I think it helps to understand. I've lost track of how many more we have.
I've got 3 more.
Okay, go ahead.
So 5512, this is an act concerning consent orders. So I want to clarify here that there's certainly nothing we are trying to do to remove anybody's rights to a hearing. In the current situation for licensees, we need to issue formal charges, and the licensee is entitled to a hearing should we bring charges. There are circumstances in which, as an example I will give, if a provider has a license and it so happened that in an audit it was identified that the licensee did not complete the continuing education credits that they're supposed to do in a given year. If the licensee agrees, you're right, I didn't complete those, and I'm willing to engage in a consent order to make sure I get up to speed and do the things I'm supposed to do to renew my license. As opposed to the department having to file formal charges for the licensee to have the right to a hearing and go through that process, this would allow us to engage in a consent order right from the beginning. This is trying to remove some additional layers of bureaucracy and administrative red tape only when the licensee agrees to it. That's just an example of a type of situation where somebody may agree to a consent order without having to go through the process of formal charges.
Thank you, Commissioner. Just a question, and wanted to give you an opportunity. There was some testimony online. I don't know if you had the opportunity to review in terms of assisted living opposition. Would you want to address that or be able to address that?
I will need to take a second look at the specific feedback from assisted living because I thought their concerns were elsewhere, but I thought that was on a different bill because the consent orders is really one for licensees and permit holders.
Your Commissioner, you are right. Thank
Okay.
you. This was I think, testimony that was the change of ownership, real property change of ownership piece. I missed
That's
that.
correct.
Just filed a little differently. I think names and numbers got mixed up on that one.
And
Thank you
I
for
think we
clarifying.
can take a look at their feedback a little bit more closely to be able to address what their concerns are around change of ownership.
Okay, I think we have 2 more.
Yes. Okay, the last 2, the first is 5518, an act concerning various revisions for environmental health and drinking water. So the first is, this would allow us to improve our monitoring of bottled water, source water. So bottled water, as it is coming from the source, is regulated by DPH. The minute it ends up in the bottle, the authority goes to DCP. So what we are trying to do is codify our regulatory authority on the water before it ends up in a bottle. And this would be to be able to have as best authority to ensure that substances like PFAS or others are not in that bottled water. But in order to do that, we need some clarification, and that's part of what that is. The second is our ability to clarify some of our laws on environmental health laboratories and allow DPH to monitor our state laboratories that are operating centers in Connecticut. These are specifically environmental health laboratories. We want to be able to just have some oversight on them, just the way we do in other facilities, to make sure that we can, in fact, ensure some of the environmental testing that we actually do for things like bottled water can, in fact, be held accountable for that. The third is just some technical corrections and clarifications around our asbestos statutes. And the last is a fix and a conflict in statute by clarifying the limit on crematoriums within 500 feet of a residential area only applies to cremation by incineration and not alkaline hydrolysis. So there is a separate statute that indicates that alkaline hydrolysis can only occur on the grounds of a funeral home, many of which are located within residential areas. So essentially, this perimeter clarification is intended to clarify what can be done around a crematorium and not for alkaline hydrolysis.
Thank you. Thank you for that and for going through. Did I miss?
Last
We have
one.
One more. I was just going
Sorry.
to say.
One more, and then you'll be free of me. 5519 is around on-site wastewater specialists and water operator apprentices. So this proposal would codify our current process for the certification of on-site wastewater specialists that work in local health departments to review plans and installation of subsurface sewage disposal systems. This proposal would also create an apprenticeship program so that certified water operators can work and get apprenticeship opportunities before getting full-time employment. This will also help us address the workforce shortage in this area. And the last is that the local health departments would like a change in title from on-site wastewater specialist to either subsurface sewage enforcement officer or subsurface wastewater disposal inspector. So that is the last piece of this bill, which proposes that change in language.
Thank you very much. All of these very important public health issues that are often invisible to most of us, including even us here around the circle. I think there are a lot of technical but important changes. Are there other questions for the commissioner here today? Commissioner, as I said to Commissioner Navarrete, we will be, our chairs and ranking members, meeting together with you and your team to go through these and many other bills, and before and during the JF process, as well as afterwards, those conversations always continue through. So we appreciate you being here with us today and look forward to working together going forward. Have a wonderful weekend.
Thank you so much. Always look forward to the collaboration and open to any other conversations with any members of the committee. Thank you.
Thank you. Thank you, Commissioner. Next up, we have Samantha Kazabinski. Samantha, are you here?
I'm
Or
virtual.
You're online. There you are. You're right there. Welcome, and please proceed.
Thank you. Good morning, distinguished members of the Public Health Committee. Again, my name is Dr. Savannah Kazabinski. I currently reside in West Hartford. I'm an OBGYN who serves patients in both Farmington and Hartford. Thank you for allowing me to testify in support of HB 5516, an act concerning reproductive rights. This bill would protect healthcare providers who offer the standard of care and medically accurate information to their patients about reproductive and gender-affirming healthcare. Again, I'm an OBGYN who offers full spectrum abortion and contraceptive services to my patients. I prioritize this in my career, but not everyone who becomes an OBGYN opts to do the same. Religious or moral objection to abortion does not limit people from pursuing a career as an OBGYN. However, every single OBGYN who graduates from an accredited residency program has to meet a set standard of competencies established by the Accreditation Council for Graduate Medical Education. In relation to abortion, I will read the following competencies that are required. So residents must be involved in educating patients on the surgical and medical therapeutic methods related to the provision of abortions, and residents must participate in the management of complications of abortions. So these competencies are regardless of the religious affiliation of either the resident or the institution they're trained at. And these standards are required to be taught to all OBGYN residents to become board certified. So in summary, the OBGYN should be protected regardless of their institution of providing care that they are required to be competent in. I see patients in my clinic who are referred from religious affiliated institutions. They may seek care from these institutions due to ease of access, and this can be especially prevalent for patients in rural communities with limited options. They are often not made aware of the restrictions of the institution and are not apprised of what medically accurate information they are not receiving. I included in my written testimony some literature that reviews this, where some patients are not able to identify that a hospital is religiously affiliated and what breadth of services that they do not provide. All patients have the right to accurate information about their reproductive health and to be counseled on the full spectrum of options available. HB 5516 would ensure that all of our state's providers, regardless of their employer or hospital affiliation, are able to provide evidence-based, safe, and medically accurate information without fear of disciplinary action. Denying patients information about their health care can cause delay in treatment and endanger their lives. This bill is not proposing the government mandate institutions and providers how to counsel patients or dictate what services they provide. Rather, it frees providers to give the information to patients they are ethically obligated to do. I respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably for HB 5516. Thank you so much for your time and consideration.
Thank you for your testimony here today, Doctor, and forgive me for calling you Samantha when your name is Savannah. So
no worries.
So my apologies for that. Are there questions or comments? Representative Dauphiné.
Thank you, Madam Chair, and through you, and thank you for being here today. My question is very specific. So if what you're saying is that a doctor must offer a therapy or surgery or option, even if it's against their religion, just so I can clarify.
So no, that is not true. So doctors can choose if they want to offer the services of an abortion, either medication or surgery. And so they do have to be able to counsel patients on those options, but they do not have to provide the options themselves. They do have to, they are morally obligated to relay or give patients another provider that can do that for them. So it is not forcing providers to provide care they're not comfortable with.
Through you, Madam Chair. So what you're saying is if a hospital is a religious hospital and they practice certain beliefs, that they must be allowed to offer something that would go completely against the hospital's spiritual beliefs and what they don't advocate for. Is that what you're saying?
No, so they do not have to offer the services themselves. This is protecting providers who want to provide medically accurate care to patients, but does not enforce the institution to offering the care and providing the services themselves. So if it is against their institutional policy, it does not force them to go against that.
Through you, Madam Chair, but it would allow you to if it went against their policy.
So this bill specifically would allow providers protection if they're giving counseling to patients about the options that are available to them and then referring patients to providers who can give them the care.
Through you, Madam Chair. So they were hired under the knowledge that this hospital would not advocate for that. You were hired under those conditions, and so what you're saying is you want protection if you decide to do it anyway.
So not the actual provision of the care, but allowing for providers who are counseling patients on the full spectrum of options to be able to do that without fear of any litigation or action against them. So it is not forcing providers to provide the care, more that allowing providers who are counseling patients and allowing them to be referred to other providers who are giving them the care that they need.
So through you, Madam Chair, so what you're saying is they were hired under the conditions that they did not want their staff counseling patients on such therapies, but you're saying you want protection if you decide to do it anyway.
And so again, with the what, as an OBGYN, accredited OBGYN, what we are competent in, regardless of religious institution or affiliation, is that you are educating patients on options and can manage complications of abortions. And so that is a standard for every institution.
Through you, Madam Chair, so you want it to be a standard of every institution?
So that is a standard for what OBGYN physicians, when they are board certified, that is the care that they are able to provide and should provide. And so that is from the accreditation of OBGYN physicians.
So I think what you're saying is even though the hospital, be it religious beliefs, does not advocate for a certain therapy or surgery or counseling, you want the ability to offer it anyway and counsel anyway, even though you were hired knowing that they don't want you to do that.
And so I think the sticking point here is the counseling versus the provision of care. So the provision of care we are not forcing institutions or hospitals to provide care that they are not, is not in their like institutional policy. And so the provision of care would go somewhere else. It is protecting providers who are wanting to refer patients to other institutions to be able to get the care that they need.
Thank you, Madam Chair, and through you, so I think I understand you right. You want to be able to do it, to offer this counseling even if the institution does not want you to. Thank you so much.
Thank you, Representative. Representative Carpino.
Thank you, Madam Chair. Doctor, thank you for being here. I'm reading the bill and listening to your testimony, and I just want to make sure that I understand, so I apologize if this is a little redundant. Am I correct that you are simply advocating for the ability to give options and explain medically viable choices to your patients? Is that accurate, ma'am?
That is correct.
Okay. And to follow up, you are not asking on behalf of other physicians, and I realize it's not for yourself, but you are not, am I correct that you are not advocating, at least today before us, for the right of physicians at these religious institutions to be actually able to perform them? Is that accurate?
That is accurate.
Okay. So you're merely advocating for the right to give information to your patients. Is that correct, ma'am?
That is correct.
Thank you. Thank you for your patience with me. I just wanted to make sure I understood. Thank you, Doctor, and thank you, Madam Chair.
Thank you very much, Representative Carpino. Seeing and hearing no other, Representative Reddington Hughes.
Oh, thank you. Through you, Madam Chair. I just wanted to ask, in this bill, this is basically offering protection to folks that want to give information out to a patient that may go against the beliefs of the hospital that they are working in, correct?
Correct.
And in as much, if this doctor, whatever they are, whatever field they're in, if that is not something that they offer at the hospital. The hospital doesn't really believe in the methodology, or it doesn't believe that this is a practice that they would want to stand behind. Is this bill then saying that they must offer these other options, or is this something that is a individual one-on-one type of thing?
And so again, this bill is not dictating the provision of care that is offered at these institutions. It is merely protecting providers for offering information that is medically accurate and safe to patients and allowing them to refer patients to institutions where they can get care. So it is by no means dictating how providers at each institution practice or the care that they need to provide.
Thank you. Thank you.
Thank you, Representative Reddington-Hughes. Representative Clara DeStitria, to be followed by Representative Mara.
Thank you, Madam Chair, and thank you for being here today. I know we're all kind of in our own way asking you the same question, but we appreciate the clarification, and I think it's very important for us to protect women's rights in Connecticut. The fact that we're saying that a hospital that doesn't support or offer an abortion, all you want to have the ability to do is give a woman what her options are. You're not saying we're going to give you an abortion in this hospital. It's just, here are your options. I want you to be informed. Go on your way. Is that correct?
I appreciate your comment. That's exactly correct. So it is giving women who are in these scenarios options, but it is by no means dictating the care that each institution needs to provide.
Okay, thank you much. I appreciate the clarification for all of us asking you the same question. Thank you, Madam Chair.
Thank you.
Thank you, Representative. Representative Mara.
Thank you so much, Madam Chair. I guess I'm looking at this a little bit differently, and honestly, I had to read this several times, this particular section, to see if I kind of understand it. It seems like there's a lot of if this person, then not that person, and who fails to do what to provide, and then so I'm looking particularly at the last section of this bill, and I wonder if you can kind of help me out here. You know, at one point we're looking at, you know, it's the healthcare entity versus the provider. And I'm curious, I'm trying to find examples in my head of how I think this might work and would not work. So if a provider is seeing a patient that's coming in, and as far as their diagnosis of the patient, they don't necessarily believe they should go through X, Y, and Z type of care, will they be held accountable by the hospital for not providing that information, even though in their professional opinion they don't believe a person should have that type of care?
So the bill is more allowing for people that are providing the medically accurate information, no fear of litigation amongst their hospital or any fear of like in their career having some sort of like either fired or disciplinary action for providing the care. So it's protecting providers. Again, it's giving them the freedom, again, to act as a provider counsel in the way that they want, but it is not allowing institutions to penalize providers for the information that they are giving. That again is medically accurate and safe.
Okay, so
it's more of a negative. Oh, sorry, go ahead.
No, my apologies. So this one seems to be a carve out, is where that this provision of this section does not apply to healthcare providers who fail to comply with instruction of healthy care entity to provide patients with a full range of information about available legal options for care. So let's put into an example, maybe gender dysphoria. So if someone comes in with gender dysphoria, for example, and the provider believes that this particular patient should seek maybe some therapy sessions or something like that, will this particular provider, this doesn't seem to apply to them, if the healthcare entity, for example, maybe supports a full breadth of maybe transgender surgeries, which we don't believe that that's necessarily happening at this point, or hormones or something like that. Do you feel that this provider might get dinged in this instance?
So in terms of the answer to this, my specialty is more abortion and contraceptive care. So I'm less of an expert in gender affirming care. Again, I'm not a lawyer, I am a physician, so I am the nuances of that language. I am not necessarily an expert in. And so unfortunately, I'm not able to give you like the best answer to that.
Well, we could take this into your area of expertise. If you have someone that you believe this is whatever it is, that this is the best route for them and you're recommending this, if you don't, let's say that you don't believe abortive services are right for this particular person, and therefore you don't give them the full range of abortive services information, do you think that you'll get dinged?
So as a provider, my goal is to give everyone the full spectrum of options. And again, I don't know the nuances at each institution and their specific policies, but as a provider, my goal is to give everyone full, accurate medical information in terms for their care.
Okay, I'm not sure that answers my question, but I don't have any more questions. Thank you.
Thank you, Representative. I appreciate your comments that you wear the physician hat as opposed to the legal hat. We joke about that here at the circle, and that what I'm hearing you say is that what you're here to advocate for, which is what I think my good ranking member actually succinctly summarized in her question to you. And that legal language, you're not going to comment on the nuances of it, but the intent and the hope for you is that as a provider, that you know that if you or your colleagues are actually furnishing information and referral information, that you will not be penalized by the institution, and that the language of the bill, and as often happens, we continue through conversations to have conversation with the stakeholders on this language. But I do believe Representative Dauphiné for the second time.
Thank you, Madam Chair, and through you. So just for a little further clarification, are you saying that right now you would be penalized for offering and sharing medical information and resources to a patient with regard to perhaps abortion or adoption or any other thing, but you kept using the word counseling, so I'm a little confused. Counseling and providing medical information is a little bit different. Can you clarify?
So counseling and means of, in my field of work, it's giving the patient full spectrum of options, including the risks, benefits of all of the options. So that's what I mean by counseling.
So I guess I would see that as sharing medical information. So, I mean, if you're going to share medical information with regard to a particular procedure, risks and benefits of that, I'm just trying to clarify, but I think you did just clarify. Are you saying right now you're not allowed to share that medical information without being penalized?
Do you mean me as a physician in my current job?
Are you seeing that as an issue? Are you aware of that as an issue in Connecticut where someone would share medical information?
So I myself don't work at a religiously affiliated institution, so I can't speak to the policies that they have. So where I work, that is currently not the case. But again, I have not worked at a religiously affiliated institution to be able to comment on their policies specifically.
Well, I guess I'm assuming I'm sorry, through you, Madam Chair, I'm assuming there's a problem because It says here, sharing legal options for care specifically, and it also said, but not limited to vaccinations. I wasn't sure if you were familiar with where that was coming from, but I'm just trying to clarify that, is there a problem, or are we trying to find a solution and there is no problem that exists? I guess I'm just trying to understand that. Thank you for your testimony today.
Thank you. Thank you, Representative. Seeing no other questions, I want to thank you, Dr. Kazabinski. Did I say it right this time?
That was perfect. Thank you.
Thank you for being here with us today and answering our questions, for your time
Thank
and
you.
testimony. Next online, we have Jason Privilege. Welcome. It's nice to see you, Jason.
Hi, good
Please
morning.
proceed.
Thank you. Can you hear me okay? I'm in a parking lot in Maine right now.
Yes, we can hear you and see you. It's great.
Perfect. Thank you. So for those on the committee that do not know me, my name is Jason Privilege. I am the legislative chair for the Connecticut Academy of Physician Associates. So thank you, Senator Anwar, Representative McCarthy-Vahey, and the esteemed members of the Public Health Committee for hearing me today. I'm going to testify this morning on HB 5513, the technical revision bill we just heard about a short time ago. Specifically on starting at line 192 that speaks to the changes of the MOLST statutes. The MOLST statute, since it was enacted in 2017, has been reported to be an underutilized tool in assisting patients with their end-of-life comfort. The MOLST Council is an engaged group that continually seeks to improve the process and utilization of the MOLST orders. While PAs have been generally well integrated into the MOLST language, there's one area that has been lacking and is inhibiting access and utilization. Section 19A 580H, which defines what a MOLST is, excludes PAs from determining that a patient is at the end of stage of life, although the PA can then write the order. I do have my written testimony, the specific language and the proposed inclusion there, so I won't read that to you. But PAs are having end-of-life conversations every day in Connecticut across a variety of practice settings. This exclusion of PAs in determining that someone is approaching their end of life is limiting access to the MOLST for our patients in Connecticut, and are asking that this section be amended. The proposed change has the support of the DPH-appointed MOLST Council, the Connecticut Hospital Association, as well as written testimony that has been or will be submitted by physician and APRN colleagues. Related, while reviewing the MOLST language, CONAPA respectfully requests that the committee consider bringing into alignment the other end-of-life statutes within the same chapter, beginning at section 19A 570 and onward. Throughout those sections, PAs are not included at all alongside physicians and advanced practice registered nurses in the ability to navigate much of the end-of-life care. That creates a significant barrier to care at a time of critical importance and emotion for the patient. Such exclusions are also at odds with the MOLST process, where PAs are engaged in end-of-life planning. As well, the language is at odds with itself, whereas one of the sections allows use of advanced directives from other jurisdictions, which could have been enacted by a PA. So with that, I'll conclude, but CONAPA thanks you, and I thank you for all of your work serving this legislative body and for our patients in Connecticut.
Mr. Privilege, thank you so much for your testimony. The commissioner had a number of bills to talk about here today, and we didn't talk a lot about MOLST. Can you just briefly review for us what is a MOLST and in what circumstances that gets put into effect?
Sure. Admittedly, I'm not the expert in this area because it's not something that I really deal with. One of my colleagues is speaking a bit later on, Nicholas Patino, and he can go into more detail. But in short, it's an order that addresses the various end-of-life needs, ranging from how to treat someone at the end of their life regarding medications, intubations, resuscitation, et cetera. So those different things that we may do to prolong someone's life, how should they be handled? Think of it like an advanced directive, but more comprehensive.
Thank you for that, and thank you for the reference to your colleague who we can speak with more later. Seeing and hearing no other questions, thank you for being with us safely from your car. We appreciate that as well, and have a great weekend.
Thank you. You as well.
Next on our list is David Reynolds. I believe, Mr. Reynolds, yes, you're here with us. Welcome.
Co-chairs, ranking members, my name's Deacon David Reynolds. I'm Associate Policy Director at the Connecticut Catholic Public Affairs Conference, which represents the Catholic bishops in Connecticut. I'm here today to speak in strong opposition to House Bill 5516, an act concerning reproductive rights. This bill, like other similar legislation around the country, is aimed at the ethical and religious directives for Catholic health services, commonly called the ERDs, that Catholic hospitals operate under. The word Catholic isn't in this legislation, but let's be clear. This is an attack on Catholic hospitals and and the morals and ethics that they follow. But I'd also like to, I have submitted a written testimony. I'm not sure it's been posted yet, but I want to summarize besides saying this is a direct religious attack on religious healthcare institutions, I want to address some comments that were made by the previous speaker. And I'm going to read for that just for my testimony. The ERDs focus on prohibiting the procedure and referral for abortions. They do not explicitly prohibit physicians from providing comprehensive medical information to a patient, though they strongly limit discussions that would promote or facilitate a non-approved direct abortion. This is not to provide, I think, well, I would like to say it's inconceivable that an OBGYN or other professional working at one of our hospitals would give inaccurate medical or incomplete medical information. That's an insult to the medical community working in those hospitals. What is a violation, again, is providing counseling, making referrals, or providing medication to a patient that would resort in an abortion. And when I refer to counseling, in this one, yes, there's a question about counseling. Medical information providing that is not necessarily counseling. In the terms of the ERDs, counseling would be considered after you provide the options to the patient, sitting down and saying, well, you know, maybe because of your economic status, you may want to consider an abortion. That, in those type of areas, are what counseling is about. Our hospitals and current physicians are not restricted from going over options with the patient. They're restricted from enabling those options so that patient could go out and go find another provider where these are not emergency situations, okay? And it's easy within the state of Connecticut to find other providers. We've been talking a lot about abortion. This bill also talks about gender identifying care. I think they're totally two different aspects, and I think in terms of gender dysphoria, what is the standard of care? This bill references at the beginning 2 documents about standard of care. However, right now, worldwide and within our own country, the medical community is deeply questioning that standard of care. Internationally, Sweden, Finland, Norway, Great United Kingdom have all massively changed their approach to gender-affirming care for minors.
Excuse me, Mr. Reynolds, but you've reached your 3 minutes. Thank you.
Thank you.
Okay.
If you would just continue and finish that thought, that would be great.
Appreciate that, Madam Chair. And with this great change going along, what now constitutes acceptable transgender affirming care for minors? And one last thing in relation to that, if a hospital, which is kind of ironic, if a hospital has a physician that gets involved in that business and the hospital cannot do anything about it, will they be subject to legal liability should someone later sue the physicians that maybe transitioned that person? That happened in New York. A teen at 16 had double mastectomy. At 21, she sued the providers, and last month or so, she won a $2 million settlement. So there's legal liabilities when you deal with that issue that aren't addressed in this bill.
Thank you for your testimony today. I see a question from Representative Dauphiné.
Thank you, Madam Chair, and through you. Thank you for being here today.
Sure.
I just want to bring clarity. I know I was the first up to ask questions regarding the issue, and I was still trying to understand the bill, but it seems to me that there is a very clear distinction between sharing medical information, as you described, and counseling somebody on something like we would counsel whether we were a social worker or mental health care or the like, right? We would counsel them and work through the issue. And I think I wasn't clear of what she was asking for, because I guess the question would be, are you aware of any penalty for a doctor sharing medical information to any of the patients in, let's say, any of the religious hospitals?
I am not. I
Okay.
am not, because they're allowed to do that. So I would be surprised if one did encounter any discipline. In reality, if that is the purpose of the bill, that provision in this bill is not necessary. It's just
Okay.
an unnecessary piece of legislation, followed by a lot of misinformation that goes around with what's allowed and is not allowed by the ERDs.
So there's a clear distinction to
Yeah,
you. It doesn't say counseling in the bill. It says information sharing, as I read it. I'd have
Right,
to
and
reread it.
Right, there's no restriction on information sharing. Counseling, usually when you're talking about counseling, has to do with helping guide somebody through a situation, making a choice, a decision. That would be not allowed under the ERDs. In other words, if that person would have to go out and talk to somebody else. The physician would violate the ERDs if they counsel the woman to have an abortion. Like I said, okay, you have economic concerns, it might be a good idea that you get an abortion.
Correct. Through you, Madam Chair,
and
I would agree. The other thing we were talking about was gender affirming care. So if I understand you right, there's a lot of dispute right now whether there is even a standard of care with regard to gender confusion or whatever label we're giving it. So I think what you were suggesting is that, maybe you could clarify exactly what you're suggesting and your concerns about this bill and how that would impact
Well,
that.
I think the bill's taking it out of the control of hospital management and allowing the individual physician to decide, okay, with all this disputes going on and this person comes in, I'm going to go down this track of care instead of that track of care. What will be the impact? So this bill tries to make it sound like, oh, there's already a well-established national standard. And there's some organizations that do that. But quickly in our own country, we just, in the last few weeks, the American Society for Plastic Surgeons said no more surgeries on minors. This is a new standard. And within days of that, the American Medical Association came out and endorsed that. So no more double mastectomies on 16-year-old girls, which was part of the lawsuit out of New York. So they're two separate issues, probably shouldn't even be in the same bill because of the complexity, especially of that. So if the hospital, as a religious hospital, under the directives, they are not allowed to discuss that. I guess in abortion they could discuss stuff, but in the ERDs, which was just reaffirmed by the Catholic bishops last year, is that transitioning care is not part of Catholic health care. So if somebody comes looking to a Catholic health institution for transitioning care, they need to find another institution. It's not that the doctor's giving them out misinformation and lying. It's just they need to go out and make a choice, maybe talk to several doctors about the different routes they're taking. And a lot of the studies for transitioning care for minors was not based on long-term vital, long-term care studies, longitudinal studies. And now that the studies out of Finland, England, some other studies which are truly longitudinal, they're showing that this care has failed because most of the time the underlying mental health issues were missed. So they're starting to switch over away from hormones, away from that therapy, into more mental health. And so you're trying to set up a standard here and then go and tell a Catholic hospital that their doctor could decide which standard, which roadway they want to go on and pick and choose, and the hospital can't do anything about it. And then maybe end up being in a lawsuit. Nothing more ironic than a Catholic hospital being sued for participation in an abortion or participation in transgender affirming care.
Thank you for that. And one more follow-up. Would you want to weigh in on why they added vaccinations in here? I guess I was trying to put together the relationship between reproductive rights and vaccinations.
To be honestly with you, I have not looked at that.
Thank you for your testimony today. Thank you, Madam Chair.
Thank you very much. Representative Reddington Hughes, to be followed by Representative Jenga, to be followed by Representative Mara.
Through you, Madam Chair. So if I'm understanding this, it seems, as things are right now, that if someone came into the hospital, even a Catholic hospital, that no one is going to get fired, okay, if when that person enters and they are pregnant and they are looking for, they're in crisis, okay,
Right.
and they're looking for options, that the hospital certainly is going to, within their belief system, give them some prioritized options, okay, because they are going to a Catholic hospital, but that if that person, you know, had a full plate of options, okay, that the doctor who is then saying, well, this is another option, but not counseling that person to run in that direction, that that doctor is not going to get fired as it is.
That's correct.
So this seems to be a solution looking for a problem. That this is not the way that things are unraveling as it is right now. So there really seems to be no reason for this to be placed into law.
Right. I agree with what you just said, and I think as you were saying that, we also remember that as we look at this and accept, okay, the doctor can't, and right now it has only to do with not providing the care. If this law is passed, how many, a year or two from now, or how about forcing them to, once you breach
Right.
the religious boundaries, the ethical, and you're able to make inroads onto that, you could then be facing a bill before this committee a couple of years from now saying physicians should be allowed to give out the abortion pill from Catholic hospitals, which they're not allowed to do right now. So,
No, and through you, Madam Chair, in the event that this was to go forward, in your opinion, would this go from, is there that possibility, as many see, that it would go from a decision-making of somebody and their best interest to that they must provide all of this?
I think eventually in time, but I think it also opens the door to providers that even though they signed a contract to follow the religious directives in their employment contract, they may say, okay, I have a little leeway now because, the administrators can't fire me, so I might even go beyond what the ERDs allow. I may give out an abortion pill. I may, and it's gonna cause total confusion for enforcement of that.
And through you, Madam Chair, so I think that what the biggest drawback is right now, correct me if I'm wrong, that the counseling, okay, per se, is something that if that is done by a doctor that has agreed to work for a Catholic hospital, that is not in their purview, in their contract. So it is not something that they were hired to do. And in effect, the hospital cannot take ownership of that because that was something that specifically they were hired not to do.
Yeah, they can't. This is a unique situation where, and I don't think you'd find it in any other business that's proposed here, that you're saying you're hired to work for me. In that contract, employment paper, he says you follow the religious directives of the Catholic faith. And when you break them on these two particular areas that are in this bill, there's nothing we can do about it. So the employee can basically do anything we want. So it raises severe management questions, too, of oversight of what's going on in that hospital.
Absolutely understood. Thank you.
Thank you, Representative. Representative Jenga, to be followed by Representative Mara.
Thank you, Madam Chair. Thank you for your testimony this morning. And one of the reasons for this particular bill, the proponents are saying that providers are increasingly seeing threats to their ability to provide reproductive health care services. Are you aware or have any kind of information regarding any situations where healthcare providers were reprimanded or action taken against in the general area of the hospitals here in Connecticut?
I think the statement you quoted goes beyond that, but in terms of, and I've been representing the Catholic Conference up here for many years, and I'm unaware of any actions taken against providers within our state. So, but also I think what's happening is it's getting confusion and probably some steam from the national debates where on abortion, where the feds are doing certain things, and so I think that's the threat that is mentioned, or you mentioned there. That's the threat viewed by certain advocacy groups and politicians, public officials against abortion. But this really bill doesn't address any of that. Abortion's still legal in Connecticut with almost no limitations. So, in terms of the abortion thing, so no, I don't see that passing this bill is going to reduce any threat to the provision of abortion in Connecticut. And I think we have to be careful too that really, in terms of the transgender treatment, which I already mentioned, that's become a very red-blue state type issue now. But now that these new medical findings are coming out, it's going to be a real challenge in the several years to come about what exactly is good health care in that area.
I think we have protections already that cover healthcare providers in these situations, and our laws, and I think it's pretty clear what we've done over the years with the Catholic hospitals to provide appropriate services within their realm and their responsibilities to provide advice to any of their patients for anything that service that they cannot provide, but somebody else can provide. We've been through that.
Correct.
Is that fairly accurate?
Yes. The Catholic hospitals have been in the state for, I'm going to stretch it maybe of 100 years. I mean, with St. Francis, founding of St. Francis. And these types of issues have not really, I can't remember reading an article like this, about something happening like this in our state in terms of abortion or transgender care. So, I think to reflect the statement made by the representative that this is really a solution looking for a problem in terms of the first section of this bill. And my big concern is probably even more so with the second section of the bill, and what could begin happening within Catholic hospitals in terms of transitioning care for minors.
Okay. In terms of medical providers who are hired by Catholic hospitals and sign contracts, how would this go against what's already been agreed to between the hospital and the health provider?
This bill really interferes with the hospital's ability to enforce its policy. And that policy is the religious directives for Catholic hospitals. So there becomes a layer of interference. The government is now saying, except you have that policy, you could have the policy on your books, but in these two areas, you can't really enforce it. We're removing the enforcement and oversight option from you, which to me is just bad management and opening the door for abuse in these two areas.
Okay, thank you.
Thank you, Representative Jenga. Representative Mara.
Thank you so much, Madam Chair, and through you. I just want to talk a little bit, not necessarily about reproductive care, because I agree that providers should not be docked for providing information anywhere. They should be able to provide appropriate information, and I feel like we have that covered. I look forward to, that's why we have public hearing. I look forward to someone coming forward and saying that they got in trouble for providing appropriate medical information. But until I see that, I don't think that this is needed. But my concern is when we add sections in that may open up a can of worms to something else. And I will continue to focus on that last section of the bill that seems to caveat a certain area of if someone comes in and the provider doesn't provide the information that the healthcare entity has in their practice, will they get docked? And so we can look at the vaccines, which maybe someone comes in and the provider looks at this person and says, this is a male who's had COVID in the past, is young. I don't think that they're right for the COVID vaccine or something like that. So they don't counsel them on that. or this is a person that comes in and they're on puberty blockers for gender affirming care, and they present maybe to the emergency room and they get counseled at the emergency room to come off of them and to go a different route. So are you concerned, as maybe I am concerned, I'd like someone to alleviate my concerns here, that we are putting a provider, actually with this bill, we're putting, putting providers out there to get in trouble by hospitals by this bill. That's what I'm seeing. Do you have an opinion on that?
What I'm seeing is more so the hospital saying these are our standards, and this bill prevents us from enforcing that for the care of the patient. In terms, you bring up an interesting situation. It came up last year before in a similar bill like this, is about emergency rooms. We have to remember emergency rooms are a totally different environment. And so if somebody's coming in and transitioning, the doctors need to know that. The emergency room would not be the place to give counseling to that patient if they thought they should, because maybe the hormones or puberty were causing physical harm. It's legitimate to raise a concern about that and say you might consider it or talk to your main provider about doing that. In the emergency rooms, if we handle all emergencies basically according to federal standards in terms of abortion, and so there's no issues there that are in reality in our emergency rooms. We don't transport patients out of an emergency room if the woman's pregnant and for some reason somebody says she needs an abortion to live. I really find it difficult to find a situation in that. When I've have done extensive research on that, it's very difficult to say that woman needs to have an abortion immediately or she'll die. But they will follow standard practices in the emergency rooms. But that's kind of outside of this bill, but I think it's important to know that our emergency rooms provide the best care that they can do that. In terms of what's going on around the country, in terms of, again, I have not read anything that has put a provider in trouble. Where providers have gotten in trouble in other parts of the country, some of them were with Catholic hospitals, and more recently with the confusion caused about the abortion changes in the southern states and that type of thing. But when they were looked into, it had nothing to do with the religious directives of the Catholic hospitals. They were basically malpractice claims. One woman got very ill. I think she may have passed away in a Catholic hospital. She was pregnant or having an ectopic pregnancy. They just forgot what room they put her in, and they left her there. So that's not an ERD, that's not a directives issue, that's a medical issue. But you hear a lot of these stories to build up the scenario that Catholic hospitals are not treating women the way they need to be treated if they're pregnant or considering an abortion.
Okay, so you think that that's the reason why this bill was brought forward?
This is a national trend, yes.
All right, well, no, I appreciate that, and I don't think it's necessary, but my concern, and maybe I'll talk to some people later today on understanding maybe what we're actually opening up and putting our providers actually at risk instead of protecting them in this bill, and I kind of want to, that'll be a discussion throughout the rest of the day, but thank you so much, I appreciate it. Thank you, Madam Chair.
Thank you, Representative Mara. So I have a couple questions as well,
Okay.
Deacon Reynolds, and I appreciate you being here with us today.
Sure.
So is it fair to say that you would agree that abortion is a medical procedure?
An abortion is a medical procedure, yes.
Yes, thank you. And I've heard the conversation today, and I just want to kind of walk through a scenario in terms of my understanding. And I will share, I won't ask you to opine, but my sense is that yes, there are people, we have heard from people who have had concerns. And as we know, impact of national events does certainly come here to Connecticut, right? It impacts us on every issue, whether it's related to gas prices or, issues around reproductive care and everything in between. So if I am a provider or if I'm seeking care in a hospital and I come to you as a provider, and by the way, I want to preface my remarks with saying that I am so grateful for our Catholic hospitals. I am thrilled to partner and work often with the people at St. Vincent's, who are my closest hospital to my home, and they provide excellent care. We have so many amazing providers, and it really is wonderful. So we have lots of great Catholic hospitals. I say that now, just walking through, if there's a situation where I was coming to the hospital seeking care, I'm pregnant and I have a pregnancy and I'm having some kind of issues, whatever that may be. I'm not going to pretend to be a provider here or a healthcare professional. And you as the OBGYN, who I am now seeing, who's part of the Catholic hospital system, you say to me that here are the options for treatment. Say, for example, I have endometriosis, or I have whatever the condition may be, and you tell me that the option, as you continue this pregnancy, these are some of the procedures you may need to go through, these are the things you will face, that if I were to say, or if you were to say to me that without assuming intent, because I think your earlier comment assumed that a provider might give that option because of an economic situation. So I think you and I certainly have fundamentally different ideas about, what those choices may be for people, or should they choose to have that full range for whatever the reason. And if that provider, without assuming intent or in any way, in answer to a question that I'm the patient and I've asked you, what are all of my medical options? So what are all of my medical options? And if you as the provider tell me that abortion is a medical option for me in this case, is that, and you work at the Catholic hospital, are you protected if you tell me, the patient, that abortion is one of the medical options that you have in this pregnancy?
According to the ERDs, yes, you are protected, because you're not promoting an abortion, you're not facilitating it, you're not pushing it along, you're basically giving the woman her options. And I agree with my prior testimony, I mentioned the economic thing. Healthcare is different based on the individual walking through the door. So that's why it's important to give the woman their options. Okay.
So at this point, so taking it a step further, now I'm the patient, you're the provider. I've asked for my full range of medical options. And I say to you, the provider, in conversation, I really think that an abortion is probably going to be the best way for me to go. Right. And you as the provider say, okay, if that's the best way to go, you can go reach out to A, B, or C provider, and this is a referral and information about that. That is not currently covered, am I correct?
I guess it's how you handle the term referral in the medical world. There's referrals, some healthcare require a referral to another doctor. The provider could say, we don't give that service, we don't have that service at this hospital, so you'll have to seek it at, another hospital, Hartford Healthcare, Planned Parenthood, whatever, but we don't provide it here. So you could have that conversation, because the referral is really saying, I'm going to contact Hartford Hospital and arrange with the OBGYN over there for you to go there and explain. So it's a level of involvement.
And by the way, I'm not trying to ask this as a gotcha. This is a sincere line of questioning so that I fully understand, and I want to try and fully understand. So in the past, when my son was a child, he needed a referral for a specialist. And rather than making the call to the specialist and making those arrangements, our pediatrician just wrote the name and phone number of that provider on the script pad, which I know
Yeah.
those don't exist anymore because everything's electronic, and gave it to us. So I understand what you're saying. There's a distinction between a formal referral where there's, work done. But if I'm going to you as the provider at that Catholic hospital, and you say, you can go and I'll use again my example, you can go across town or across the city to Bridgeport Hospital and receive care there, or you can go to this office, like you gave Planned Parenthood as an example. Would they be covered under that directive? Are they allowed to make that recommendation? I won't use the word referral because I understand what you're saying.
Right.
But are they allowed to make that recommendation, and would they be covered under the directive at this point?
They would be allowed to make that. And I think even doing that, sometimes I think doctors are a little limited on saying, well, I'm going to recommend this one over that one, or go here. Some doctors may not want to make that referral just because they don't want to say that the patient coming back and say, well, you recommended them to me and I had a problem with them or something like that. But there's right now no prohibition, and I know in prior years when we heard similar legislation, in my conversations with Catholic Healthcare, is that those referrals, those type of, I'm going to loosely use the word referral, those conversations take place.
But earlier in your comments, you talked about, I think you were talking about basically taking the control out of hospital management and putting it in the hands of the provider. The provider has a patient before them who is trying to figure out what to do and what steps to go forward. So I would actually like to continue the conversation with you probably after today. But I think there are a couple things happening just in terms of people's experience and perception. There certainly is concern on the part of many providers. And I know that nationally we've seen impacts in matching to different states with the availability of OBGYN, or I understand and have been told that is occurring. So what I hear you saying is that any provider who would provide information about abortion, and I'm going to stick with abortion for the purposes of this conversation, to a patient, whatever the medical condition of that patient. Again, I'm not talking about emergencies because that is different. EMTALA is different. I understand that. We've had that conversation here. But if you were to provide me that information with the specifics of, here's the place you can go, here is what you can do, that there is no prohibition to that referral or to that providing of information, that this is one of the medical options before you. That's what you're saying here today.
That's what I'm saying here today.
Okay. Our Representative Dauphiné has another question.
Thank you, Madam Chair, and through you. So we're getting deep here, but I did look back through the bill, and I stand to be corrected. It uses the word counseling many times through this bill. So I think we need to make the distinction here.
Yes.
So when you're giving a patient their options, it's very different than providing counseling.
Yes.
You would say, well, and I think to our good woman who was just conversing with you, I would say that if the patient were in the ER, so for the example she was using, and there was something going on, the doctor could say, options are A, B, C, and D. Where the line gets drawn in the sand is the counseling. And that's where we get into an advisement thing. This is what I think you should do. This is what I recommend you should do, versus saying your medical options are X, Y, and Z. Is that a distinction
That's a good distinction, because I think that's what we're talking about, providing the accurate medical facts. And I said earlier, I find it hard that a licensed OBGYN in this state, just because they work for a Catholic hospital, will not give accurate medical facts. So the accurate medical facts of your medical options. Not say which option you should use, or that enters into the realm of counseling.
Right. So a Catholic hospital doesn't perform abortions, but they could say medically accurate and appropriate information regarding this situation, or X, Y, and Z. It's very different, and it mentions counseling in here many times. So I think that would be the concern, because that would be the retribution to you with regard to a physician starting to counsel a person on seeking that care. And then I just wanted to add one more thing, if I may, through you. Financing and contributions to a Catholic hospital, I'm assuming that a lot of those contributors have deeply withheld spiritual beliefs that abortion is wrong, and they contribute to you because you are a resource that does not provide abortion. And would that put you at risk for those contributions?
That's a question I cannot answer.
Okay.
And I think there's a lot of reasons people make contributions to the Catholic hospitals. So, but yeah, so I couldn't answer that one.
Well, that would be concerning to me, especially given that we have such a shortage of healthcare across the state and across the country, that we would be putting these facilities at risk. But I do want to make sure that we, for the record, are talking about the problem with this bill is the word counseling, because it says in line 16 to 23, it starts off medically accurate and appropriate information and counseling. We were talking about medically appropriate information. I believe the good chairwoman was as well. She distinguished a medical procedure and put that in the bucket of medical information. Now we're going beyond here to counseling.
Right.
Thank you for your testimony today.
Thank you, Deacon Reynolds. My experience of going to my providers when I'm having a problem is I'm seeking their advice and counsel. I'm seeking a diagnosis sometimes. I am seeking an understanding of what my options are. So over the years, many times, my medical providers have counseled me. If I am to understand the conversation today, your concern with the bill, and help me understand, the concern with the bill is that it would provide protection to those medical providers who do provide information and resource referral to people, including abortion, which is a medical procedure, which is an option for any pregnant person.
I kind of disagree. I think our concern with the bill, one, is that what section part 1 of this bill is addressing isn't needed, that it's already that there's a misinterpretation of the directives of what happens. The second, also, and I think this was shared, I quickly looked at the Connecticut Hospital Association testimony. Their main concern was about interfering in management oversight of the physicians in the billing. Because once you give this type of leeway to a physician under your watch, where does your control end and their free will to go out and do whatever they want to do begin? So it goes beyond that, but it's based on I think a wrong assumption that medically inaccurate information or incomplete medical information is being given out to patients, and that if a doctor even talks about the abortion option, they'll be reprimanded. To me, that's just totally misrepresentation of the facts. It's the it's where do we're having trouble defining what counseling is today. So how do we have that word in the legislation and then say, well, will counseling helping a person reach a decision? Yes, that's it. I think in a Catholic hospital, the doctor's going to give their options and maybe say, you have time, go home, think about them. So.
Thank you for your testimony here today. Okay. Representative Martinez.
Hello, I just wanted to clarify. So if a patient came in hemorrhaging or with an ectopic pregnancy or septic, do you believe the physician should have the right to provide the medical care they feel is necessary to take care of that patient.
So the situations you are talking about would be emergency room situations. So we would follow national standards. And just for clarification, ectopic pregnancy, I always struggle with that word, are not considered abortions within Catholic healthcare, because the woman's life is at risk, and there's questions about the viability, the fetus viability and stuff. So those are not prohibited by Catholic directives. So the doctors can, basically there's a standard where if the woman comes in and she's pregnant, they'll evaluate that on an individual basis and see, what can they do to, assist the woman and keep the child alive. If it's ectopic, it's more than likely a very serious situation for the woman. So they will do procedures to address that, surgical procedures to address that situation.
Another question? And under equally emergent situations, such as hemorrhaging, or if a patient were to come in with sepsis, you talked about evaluating that situation. Would the priority be to do what was medically necessary to discuss the woman's care with the woman, with the patient, right, with that patient, and make decisions based on her health outcomes?
I would assume that would be correct. They should be doing that, because if they adhere to the federal emergency room law, federal laws for the emergency room standards, they don't skip around. And if that's not happening, then that physician, we got to remember we're talking about individuals. But it's not a policy not to do that. But if an individual doctor does something wrong, then that's on that individual doctor. It's not religious directives that you do not assist in those emergency situations. So I think we should separate emergency room from the day-to-day, visits to a doctor's office in terms of we discuss these situations.
Thank you. I do believe those are some of the concerns that people are having, seeing what's going on and what has happened in national situations. Thank you so much for your testimony today.
Thank you so much, and thank you for drawing the distinction between the emergency procedures and what this bill is addressing. Representative Kitt.
Yes, I mean, we've been talking primarily about abortion here today, but more generally, say you go to a hospital with a severe cardiac condition, and that hospital doesn't provide some high-level surgery or some very complicated surgery. Would the clinician have an ethical obligation to inform the patient, we can't do that surgery here, but I believe this is in your best interest, so maybe you should go to this hospital or that hospital that does provide this? Would you say the clinician has an ethical obligation to advise the patient to seek care at a different facility, even though that hospital doesn't provide that service?
Right. But again, you're talking about, this bill isn't talking about emergency medicine. You are talking about emergency medicine.
No, not necessarily emergency. You have a chronic condition that could be improved or helped or treated by some new procedure that your hospital has yet to adopt.
Okay.
As a clinician, do you think the clinician would have an ethical obligation to provide counseling, like, I believe this procedure is best for you, we don't offer it, here are some providers or hospitals that do?
Well, sometimes these hypotheticals are difficult to answer and stay on track, but in most situations, if a hospital doesn't provide a certain heart procedure, say, as you mentioned, there's nothing wrong with referring them to another facility that may do a different one. Or some facilities offer robotic treatments versus regular old-fashioned surgical treatments, so that information can be shared. I think putting the word moral or ethical word on it is I just think it's would be a standard of care.
Okay, but standards of care are wrapped up in medical ethics.
Right.
So by the same token, if a woman presents at a Catholic hospital, and part of my concern is that not everyone has access to a non-Catholic facility or might not know that the hospital is affiliated with the Catholic Church, looking for family planning options. And is seeking maybe a tubal ligation or some such procedure, Catholic Church may not provide that at that hospital. If in the clinician's opinion, a tubal ligation is the best option for that woman for any number of reasons, does that provider have an obligation to say, we don't provide this, I think medically it's the best option for you. Here is some facilities and other providers that can provide that procedure. Would that be covered under what we've been talking about, the current standards for Catholic hospitals?
For, yes, tubal ligations are banned by the religious ethical directives. So that's just to clarify that. They are banned in Catholic facilities and some other procedures. So in terms of, would they give a recommendation as to where to go? They may possibly do that. They're not facilitating it. They may give them a list like we talked with abortion providers. Here's a list if they want to. Or the doctor could simply say, I'm not sure who does a better job or who has more facilities, but you could Google it. I'd say that.
If the provider said, I believe this is the best option for you, is a tubal ligation, would they be at risk for being penalized by the hospital for making that recommendation?
Would they be penalized for saying that a woman? I don't know if they'd be penalized for making a recommendation. I really can't answer that one. So,
but you don't know?
I do not know.
Okay. That sort of gets at where I'm going with this, because there are times in medical situations where a provider needs to feel like they can offer their best advice for a patient. And sometimes that is going to be in direct conflict with the Catholic Church. And so my view is that clinician should be able to offer that advice, not necessarily the services, but that advice. So my concern is just, will they be protected or will they not be protected? So, thank you, Madam Chair.
Thank you, Representative Kitt. I'm going to go to Representative Kennedy and then Representative Dauphiné briefly for the third time. Representative Kennedy.
Thank you, Madam Chair. And thank you, Mr. Reynolds, for your testimony today, which we've gotten onto so many, actually too many hypothetical questions that I've displaced some of your testimony in my head a little bit. I'm looking at the testimony. Did you submit your testimony in
I
writing?
did submit it late last night, so I'm not sure it's out there yet.
It is not out there, but I do look forward to looking at it again. And I really appreciate your being here and answering a barrage of questions that kind of took a spin of its own way. But I do thank you again for being here, and I look forward to reading your testimony again. Thank you, Madam Chair.
Thank you, Representative. And I will add, I think the idea is to try and illustrate what the impact is with the providers. And I will understood that some of the conversation has been about issues not on this bill specifically, but I do think some of this has been about trying to understand what does happen in the Catholic hospital setting. Representative Dauphiné for the third time.
Thank you, Madam Chair, and thank you for obliging me again. And I just want to bring some clarity. I am a nurse, so I am very familiar with procedures and such. And medical professionals, when they can't, and it's not in their expertise or they're not sure about things, patients are moved out all the time. They're sent to other facilities. If it was a heart problem, which came up, that doctor would say, you need to go somewhere else because we can't treat you here for that. You know, these are your options. We can't treat you for this and this, so we would have to have you go somewhere else without necessarily advising somebody. You're giving them their options and saying, we are limited in what we can do, and we can't treat you for that, but there are other facilities in the area that you can go to for that treatment. Is that, does that help clarify that?
That clarifies it.
Yeah, and I want to just say for the record, over the years, and I've been a nurse for a long time, and over the decades, the word abortion has morphed into what there's a procedure called dilate and evacuate, which is done in the second and third trimester, and a DNC, which is performed in the first trimester. all of those, the intent is never to take the life of the child. But if they are done in emergencies because someone is hemorrhaging, someone has an ectopic pregnancy, and all kinds of emergency situations, but the intent is very different with the word abortion. And I think that has gotten lost here. And I just wanted to add clarity to that. And thank you for obliging me for the third time. And thank you so much for putting up with our grueling questions.
Could I respond to her?
Sure, yeah.
Your comment? Interesting, I haven't brought that up, but those situations, and ethically they're called double effect situations, where intent is key. So if a woman, and they have to do a DNC or whatever they have to do, but the intent is to save the life of the woman, the church views that the death of the child as an unintended consequence. It wasn't a direct intent to take a life. So that's called double effect.
Thank you, Representative Dauphiné. Deacon, thank you for your time here
Thank
with
you.
us today and your testimony. We appreciate it. Next on the list is actually Ben Shaken, who is going to move to the end of the list. So he will be our last testifier today. He's not able to be here right now. Oh my goodness, no, not next on the list. Next on the list is actually Damian Carroll. And Ben is still going to be moving to the end of the list, so now I don't have to say that. Well, I'll be skipping. So Damian Carroll is going to be testifying with Julie Walters, who's number 22. The two of you will have 3 minutes together. This is so that we can talk to them together on the same issue. We are happy to have you here today.
Good evening. Good morning, committee members. My name is Damian Carroll, and I'm the National Director of the nonprofit charity Vision to Learn. Vision to Learn provides no-cost vision screenings, eye exams, and eye glasses to students attending Title I schools in Connecticut's Alliance school districts. Every student at participating schools receives a vision screening, and every student who fails the screening is provided with a comprehensive eye exam on board Vision to Learn's mobile vision clinic, which is an optometric office on wheels that goes to the school. The program then returns to the school with each student's new prescription eyeglasses, and a Connecticut licensed optician individually dispenses and fits those eyeglasses to each student. Since 2022, the program has provided more than 8,300 students with eye exams and 7,400 with glasses at 50 schools in 9 Connecticut school districts. In addition to its Connecticut program, Vision to Learn helps students in 15 other states. So here is our challenge. While Vision to Learn dispenses the vast majority of our glasses in person at school sites, in some circumstances the program is unable to dispense glasses in person. The most common of these is when a student is absent on the day of the glasses dispensing. And this is increasingly an issue with chronic absenteeism. When this happens in other states, Vision to Learn either entrusts the glasses to the school nurse to dispense to the student when they return to school, or mails the glasses to the student's family directly. In these cases, if a student's glasses need adjustment, they may receive adjustment at no charge from any nearby optician, such as at a Costco or a LensCrafters. However, in Connecticut, the Board of Examiners for Opticians has told Vision to Learn our opticians may not use these alternate dispensing methods. As a result, despite repeated attempts to dispense glasses in person, Vision to Learn has dozens of completed glasses that we are unable to provide to the students in need. In addition, this rule has prevented Vision to Learn from providing services in the final weeks of the school year and in settings like health fairs, where in-person dispensing would not be possible, depriving hundreds more students in need from getting eye exams and glasses. House Bill 5514 would allow nonprofit organizations like VTL to deliver glasses to an authorized representative of the wearer if they are unable to receive the glasses in person. VTL will continue to make every effort to dispense our glasses in person to students, but we are seeking the option to leave glasses with a school nurse or mail them to parents if an in-person dispensing is not available. And I'd like to introduce Julie Walters from Vernon School District. She is the nursing supervisor in a district that Vision to Learn has done significant and extensive work with.
Thank you very much. Thank you, committee. I appreciate the opportunity to speak on behalf of Vernon Public Schools and speak about Vision to Learn. It is an amazing program. Most of you are wearing glasses, so you can imagine what it feels like to not be able to see. So if you're a child, you know, it's difficult. You can't read the board clearly, you can't focus on the classroom materials. You know, you have difficulty learning if you can't wear your glasses or if you don't have access to glasses. So Vision to Learn has been critical for many of our students. We do have a chronic absentee problem across the state. We address it to the best of our ability, but if a student isn't absent, that should not preclude them from getting their glasses so that they may attend classes and be able to see as appropriate. When students do receive their glasses, studies have shown that classroom engagement increases, reading ability improves, headaches and eye strain decrease, decreasing the amount of time spent in the nurse's office, and confidence and participation grows. I think some of the best information that I can give you comes specifically from the students themselves. We received this email from one of our kindergarten teachers at Maple Street School, and I just wanted to pass on what the children had to say. I just wanted to thank you for providing many of my students with glasses. 2 students in particular entered my classroom and brought tears to my eyes. D had the biggest smile as he shouted how everyone looked and how no one had fuzzies around them anymore. J could not stop saying wow the entire day. She even asked if she could sleep with her new glasses because she loved how clear the world was. So what we have to say doesn't even come close to what these students have to say. Thank you for your time.
Thank you both so much. And wow, we tell the kids all the time that their testimony is the most powerful and that we legislators tend to listen to students more. But thank you for such a tremendous program and just coming forward with this. I took my glasses off as you were testifying, and I'm looking at you now. You're very fuzzy.
As are you.
And I also will share, I remember the first day I wore glasses to school. I can still remember going into Mrs. Trunzolito's classroom and, you know, having my classmates comment, oh, you got glasses, but being able to see differently, it really does. I don't have the type of vision where it was that difficult. I was fortunate, but I know exactly what you're talking about. Also, this pair of glasses was sent to me in the mail. So I really appreciate the points that you're making about this as it relates to how we do things in other ways here in the state. But I know that our good Senator Kushner has questions and comments for you as well.
Thank you. I was very excited to learn about this program because I started relating to it when I was 10 years old. Up until age 10, I was living in a rural community in Iowa. Now, this was a long time ago, and people have a lot more access, I think, today. But at that time, we had no optometrist or optician. I never had my eyes checked. And when we moved to the city, I found out that my eyesight was terrible. And I love what the students said about seeing, because I know, like many other people, the first time I put on a pair of glasses, I still remember that drive home and that I could see leaves on trees and didn't realize that other people could see that. This program is so critical, and I want to underscore that your emphasis in the Alliance districts really is about going to places where children may not have access to those screenings or have benefits from their parents' insurance that would make it possible for them to afford glasses. So I really appreciate the program. When I heard that there were these challenges based on the way the optician board was handling it, it struck me as something that was maybe a mistake or an oversight on our part. The point that I want to ask about is our good chairman mentioned that she's wearing glasses that were mailed to her, and I know my grandson just got glasses in Vernon, by the way, not through your program, but he got them mailed to him because my daughter found a cheaper option online. And I wondered if the way this is written, I wondered if we need to be specific about, in some cases, those glasses might have to be mailed as well as provided to an authorized person in the school.
Thank you, Senator Kushner. And I'll mention briefly that Vision to Learn does now have a program in Iowa, so it may be that we are visiting schools or in or near the area where you grew up. And it is a very important program for rural communities where access to optometry may not just be limited by institutional poverty, but also just the distance that families need to travel to receive an eye exam. Yes, Vision to Learn would be quite supportive of adding explicit language to this legislation, allowing nonprofits to mail glasses to the parents of the students. That would come in particularly handy for events like health fairs that we participate in over summer months in most states and are currently unable to accommodate in Connecticut because we would not be able to dispense the glasses in person to the student. We would typically mail those to the student. So we would be very supportive of adding that explicitly to this legislation.
Thank you for that answer. And I know I've also, in speaking to you, I've learned that you have a collaboration here in Connecticut with Boys and Girls Clubs. And that situation could come up too, where you were visiting a Boys and Girls Club at the end of a program and the students wouldn't be coming back to that program to receive the glasses. So I really appreciate everything you're doing. I got very excited when I learned about it, and I'm hoping that we'll see more. You know, I would love to see this happen in the Danbury Public Schools. I have talked to you about the fact that we are an Alliance district, and so many kids in our schools probably don't have access to optometry care. So I hope that you'll be expanding your services and your foundation's work here in Connecticut. Thank you. Thank you for coming too.
Thank you.
Thank you. Yes, I understand you traveled a long way to be here with us, which is really wonderful. And just in terms of written testimony, have you already submitted that testimony?
I have not, but I will go submit it through the website.
That would be wonderful. We'd love to have that in writing as well. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for being here today. So I just want to, for clarification, in Section 4 of this bill, who would be considered an authorized representative of such wear?
With Vision to Learn's experience, and it's not defined in the bill, but the representatives who we would leave it with would be a school nurse at the school or the parent through mailing to this parent or providing to the parent.
Were you finding problems if they were going to the parents or a home situation, or is going directly to the school?
No, we don't have any trouble with providing to parents, but our first choice in a school setting would be to provide them to the school nurse, right. Who would be a little better equipped to explain to the student, check to make sure that the glasses were fitting properly, and explain to the student how they could seek out help to get the glasses fit. Also talk to them about wear and care of the glasses and so forth.
Yes, thank you very much for the explanation. Thank you again for being here. Thank you, Madam Chair.
Thank you for the question, Representative. Senator Kushner.
I'm sorry for the second time, Madam Chairman. I do have a question about the fitting, because I know one of the things that I know can be done is you can go to pretty much any optician or optometrist outlet like we see at the mall, Cohen's, or any of those will fit your glasses even if they didn't dispense the glasses. And I think that's one of the things that you provide information about through the schools. And if you can confirm that, but in addition, I neglected to say something important, which is how much I love the Vernon Public Schools. So I want to thank you. Please take that message back. I have 4 grandkids that are in or have been in the Vernon Public Schools, and you do a tremendous job there, so I really appreciate you.
Thank you, Senator Kushner.
Thank you. Thank you, Madam Chair.
Thank you, Senator. And I think Representative Brown would echo that as well, that love for the Vernon Public Schools, and we're fortunate to have him here with us in the General Assembly. We are very grateful that you've brought this to our attention, and I look forward to working together with you and our fellow leaders, our ranking members and co-chair, to assure that the language is just right. I think there's a lot of support for being able to make sure that we're getting those glasses not in people's hands but on people's faces. So thank you so much.
Thank you.
Have a wonderful weekend. with that, we are going to, as I mentioned, and I apologize, I had skipped Damien before, but Ben Shaken is going to move to the end of our agenda. So I'll repeat that again for anyone who wasn't in the room. Next then is number 8, Salvatore Diaz, who I believe is online with us. Welcome, sir. Please proceed.
Yes, thank you, Senator, representatives, and committees for allowing me to testify today. My name is Salvatore Diaz, and I'm a current registered nurse in the state of Connecticut. I hold my doctorate degree in nurse practice, and I'm a certified nurse educator. For transparency, I also want you to know I'm a volunteer in the Connecticut State Board of Nursing, but I'm here speaking as a nurse in my own personal capacity. I support the intent of the raised Bill 5514 and have submitted written testimony with additional details. I will briefly summarize my comments and respectfully offer a few recommendations that focus on 3 priorities. First, for accurate data. NCLEX pass rates are already collected and given to Connecticut Public Health by NCSBN. Once they're collected, they are then given to the school. So it doesn't make sense in this bill where the school will then twice a year have to report back to Connecticut Public Health their rates when they get their rates originally from them. On top of it, they only get it once a year. So I would like, ideally, for the programs to get these reports more frequently, such as quarterly, because when they can identify a drop in their rates, they can intervene early and still put out safe nurses. Second, reasonable oversight. The annual program performance reviews provide appropriate oversight while avoiding unnecessary administration burdens on the schools. If concerns arise, the Board of Examiners of Nursing should retain their authority to require corrective action plans. And third, protecting patient safety. Connecticut should maintain the long-standing benchmark of an 80% first-time NCLEX pass rate, which has historically served as an indicator of graduates possessing the minimum capacity required for safety entering nursing practice. I will also encourage the review of the Connecticut nursing education regulations more broadly, as some of these sections have not been comprehensively updated or reviewed in many, many years. Establishing a regular review cycle will help ensure regulations are current and supportive of current practice and evidence-based practice in nursing. Finally, while accreditation organizations such as ACN and CCNE play an important role in academia quality, their focus exactly is on that, the school, where the state regulation exists to foremost protect the public and ensure patient safety. Ultimately, the goal is simple: ensuring Connecticut outcomes of graduates who are fully prepared to provide safe, competent care to our community. Thank you for this opportunity to testify, and I would be happy to answer any questions.
Thank you. Thank you, Mr. Diaz. We are having some echoing. Let's try that again. How's that? Okay. Thank you very much, Mr. Diaz. So thank you for this very helpful testimony, and I love how you outlined that. And I want to go back to that first point that you made related to accurate data, and wondered if you could just talk a little bit more about that process that you are describing. And also thank you for your service on the Board of Nursing, both, as well as your practice.
Thank you.
So the pass rates, the NCLEX, first of all, just remind everyone what the NCLEX is, just because we love alphabet soup here, and just so that we're all on the same page. I often say at this committee, what grade level, everyone? 4th grade level is what I ask folks to remind us about. But the NCLEX pass rate is already given to DPH. So if you could just walk through just what the NCLEX is, and then to how that process works.
Okay, so the NCLEX is a test that all nurses, regardless if they're LPNs or RNs, take a national test, and they pass, proving competency. And so what happens is NCSBN are the ones who maintain that database. And once they get the pass rates, they send them on to Department of Public Health. Department of Health then sorts them out and then sends them to the appropriate school. And then the school has to address if their pass rates fall below 80%. They will have to address and come before the board. Where what's happening is now they only get it once a year. So a whole bunch of time goes by where the school could potentially be sliding and could identify, oh, we're sliding, what's going on, and then make changes. And so right now, we're one of the only states who don't get our reports more often. And I really think quarterly would help educators to remain focused on keeping the standards high and what they can do to change, to intervene if one of their quarters they fell below the standard. And so I think it's important to really give that information to the schools so they can make educated changes to put out safe nurses.
Thank you. That's actually helpful clarification. So you're saying quarterly as opposed to yearly, but not necessarily a change in the process or timing. Is that the right way to say that?
Correct. Yeah,
Okay.
correct.
So thank you. And then back to the second point that you were talking about related to the reasonable oversight. The Board of Nursing should retain its right to provide that oversight. Can you just speak a little bit more to that? Again, how the process works currently and why you think it should stay as it is?
So currently what happens if a school the Board of Nursing gets all the schools' pass rates. And once they get their pass rates, any school that falls below 80% puts together a corrective action plan and comes before the Board of Nursing. And so one of the things I think some educators were concerned with is if we did go to quarterly reporting, are they going to have to go before the board every quarter, which would be administrative burdensome to them. So that's why I do believe that the board should still look at it yearly and then look at it to say, yes, this school is at 79%, but they maintained, over 80% for the last 5 years. Do they have to write a whole corrective action plan, or can we watch them for a quarter or till the next year? Because it sometimes puts this burdensome on the schools to write a whole corrective action plan, and they slipped only by 1%, which is important, but they've had many years of success. Where in other schools that we've seen, the board kind of hands were tied and still had to keep letting the school, perform or prove for over 3 years. And then we see what happened to one of our schools in Connecticut. And if the board had more authority to do more in that situation, I think the outcomes might have been a little different.
So just to clarify, what you are saying is you would like to have the Board of Nursing have additional authority, not necessarily with more frequent meetings. So the reporting would be quarterly, but there would only be a requirement if they fall below that 80% for them to go before the board yearly to provide that data information and plan. But what additional changes would you want to see in the authority of the nursing board in such a case?
So I would like to see, sometimes our regulations hold us back on what we can do. So one of the things I would like to see is that we can have the school go through, if it's, falling for many years, go through, a visit by DPH and insist on them doing surveys of their students and submitting those results. Sometimes because of the way the regulations are written, it really ties our hands with certain things that we can do.
Thank you. Thank you for those answers. They were very helpful. Seeing and hearing no other questions, we appreciate your time and testimony today. Have a wonderful weekend.
Thank you so much.
Next is Matthew Barrett, who's here with us in person today. It's nice to see you and welcome, sir.
Thank you very much, Representative McCarthy-Vahey, and to the distinguished members of the Public Health Committee. My name is Matthew Barrett, and I'm the President and CEO of the Connecticut Association of Healthcare Facilities, a trade association of 150 skilled nursing facilities in Connecticut. And I'm here to testify concerning House Bill number 5512, an act concerning the Department of Public Health's recommendations regarding real property change of ownership. We support the intent of this bill and agree that state regulators should have sufficient authorities and tools to evaluate the fitness and suitability of real property owners where a facility will be located in our state's change of ownership approval process. The bill provides this new authority over real property owners where the real estate owner has a history of having previously operated or managed the facility in a manner that can be construed as substandard here in Connecticut or in other jurisdictions, and where the real property owner will have involvement in the operations of the facility here in Connecticut. And we recommend, and my testimony sort of assumes that my online testimony is before you, but I'm not really sure that it is at this point. I submitted it around 7 o'clock last night. But I will characterize the substitute language that is in our written testimony for your consideration as a straightforward approach to achieving the objectives of the bill. And our recommended revisions establish a clear standard at the outset of the bill as to the targeted real property owners with negative histories and with anticipated operation involvement, rather than applying the full range of requirements to all real property owners across the entire spectrum, which is proposed in the original bill or the underlying bill, and then establishing an agency administrative waiver process after the change of ownership application is made where the real property owner could be found exempt from the bill's authorities. And so specifically, we recommend the following substitute language in subsection 1, and in summary, that recommendation revises subdivision 5 in the bill, beginning on line 156, and the substitute language clearly expands the Commissioner of Public Health's change of ownership review authority to include real property owners who have a prior history in the operations or management of a facility and have anticipated involvement in the operation or management of the facility under review. Second, conforming changes are required in subdivision 10 of the bill, beginning on line 211, linking the provisions to subdivision 3 and subdivision 5 and specifying a real property owner's substantial performance prior as an operator or manager of a facility, and specifying the real property owner will also be involved in the operation of the management of the facility. And I would like to read the technical change, or strike that, the substantive change that I'm recommending there under 10. So it would start as replacement for the subdivision 10 that's currently in the bill. A real property owner shall be required to submit information in accordance with subdivision 3 of this subsection and shall be evaluated in accordance with subdivision 5 of this section.
Excuse me, Mr. Barrett, but you've reached your 3 minutes.
Thank you from the voice to all of us. But Mr. Barrett, please do read, and if you don't mind just starting over, because I would like to hear it. And I know we will have your testimony online, but since we don't, if you could read that again in its entirety, that would be wonderful.
Okay, in subdivision 10, a real property owner shall be required to submit information in accordance with subdivision 3 of this subsection and shall be evaluated in accordance with subdivision 5 of this subsection if the real property owner has a prior history in the operation or management of a facility in the past 5 years, and the real property owner in that capacity was found within that period to have provided care constituting a serious risk to the life, safety, or quality of care of patients or residents within the meaning of subsection C of sections 19A 493. And incidentally, that's the section that is being amended in this bill, so I'm really just cross-referencing the existing standard there of the general statutes, and the real property owner will be involved in the operation or management of the nursing home. And I do want to emphasize that is the standard that was recommended in the agency bill, and the substantive difference between our recommendation is that we'd like to see the waiver process foregone in favor of a very clear upfront standard as to who the bill applies to. And thank you for the opportunity and the ability to extend my 3 minutes, Representative
No,
McCarthy.
thank you. Well, I do have further questions. So just to make sure that I'm understanding you clearly and that all of us are understanding clearly, essentially you want to narrow the bill to include the bad actors only. Is that a fair understanding? And in other words, you have someone with a history would really be the only person who would then be caught up in this or, subject to this new language. Am I hearing you correctly?
I think that's mostly correct, Representative McCarthy, because I believe the agency actually wants to narrow this incremental but very significant new authority that the agency will have. They will have the authority to evaluate this narrower group of property owners under the same authority that they now can evaluate the fitness and suitability of the licensed operator or the management entity. And so it's really how do you get to the targeted group? And in the agency's proposal, everyone would have to be subject to the disclosure requirements, and then the agency would have the discretion to narrowly define who was exempt from that process. We believe the vast majority of property owners actually will be exempt from this process. So we came to the conclusion that in making a new law that significantly expands the agency's authority, we should say very clearly up front who it applies to. And when those entities are making application, they'll know right up front that if they are a property owner that has a prior history that is negative in terms of the standards under the existing law, and they will be involved in the management or operation of this facility where the facility where the property is located, they are subject in a clear way to the provisions of this bill, and it's not a waiver process left to the discretion of the agency.
I understand it's a little bit the opt-in, opt-out kind of idea in a sense. But I understand what you're getting at, which is when there's clear history and a pattern of behavior and there's already a concern. The question I have for you is new owner, new real property owner who we have no history with in the state comes in, and they then enter into some kind of agreement and situation. We don't know that they're intending to be a bad actor, so to speak. How would you address kind of the preventive side or the preventive aspect of that?
No,
if you see it that way.
No, I appreciate your question very much, and I would start by saying that the agency's bill doesn't reach that real property owner as well. And so the bill, in the underlying bill, doesn't really get to that issue. And I guess I would start with the assumption that that property owner with no prior involvement as being a licensed operator or management company is probably very likely to be a landlord, a property owner that is simply the landlord that is not in any way connected to the nursing home industry. And so perhaps it's proper that the bill doesn't actually reach into that situation.
Thank you for that. I appreciate it. And I also just want to say that we started out our year talking about how much we miss Representative Ryan. And I know that you do as well, and just share my condolences with you. We've missed him a lot this year.
Thank you very much for that. In the audience here with me is Representative Ryan's dear friends Ken Prisby and also Maureen Magnan, and it wasn't lost on us then when we came in here that we would look over there, and today he is not with us, so we miss him as well. Thank you so much for that.
Yes, thank you, and thank you for acknowledging them as well. Seeing and hearing no other questions, let me just check online. You're all set. Have a wonderful weekend. Thank you for your time and testimony.
Thank you.
And we'll be talking further, I'm sure. Next, online, we have Mag Morelli. Mag, welcome. Please proceed.
Thank you, Representative McCarthy-Vahey and members of the committee. My name is Mag Morelli, and I'm the president of Leading Age Connecticut and Rhode Island. Leading Age Connecticut Rhode Island is a membership association representing not-for-profit and mission-driven providers serving older adults across the continuum of aging services, including nursing homes, assisted living communities, residential care homes, home health and hospice agencies, and other senior living communities. Thank you for the opportunity to offer comments on several bills before you today. And to summarize our comments, I'd like to begin with House Bill 5514 and to thank the committee for including sections 6, 7, and 8 in the bill. As of this year, the Connecticut and Rhode Island Leading Age Associations merged into one organization, now called Leading Age Connecticut and Rhode Island, and these sections update the statutory references to reflect that change. So thank you for that. We also appreciate the proposal in Section 3 of the bill to establish a working group to review whether managed residential communities where assisted living services are provided should be licensed. Connecticut's current model licenses the assisted living service agency rather than the housing setting itself, and that approach has allowed for a great deal of flexibility. It's helped create affordable assisted living options, and it has allowed older adults to age in place in a variety of residential settings. We like the model and think it's wise to review it first through a working group before proposing any changes. We would simply ask that the working group include representation from the provider associations that represent assisted living communities, including Leading Age Connecticut and Rhode Island. On House Bill 5510 concerning unlicensed institutions and practices, we do not object to the intent of the bill. Ensuring that healthcare services are properly licensed and regulated is important. However, we do ask for a clarification in one area that's impacted by these changes. The bill proposes a very significant penalty for managing a nursing home without a management certificate. Our concern is that the current statute defining nursing home management services is fairly vague, and providers often struggle to determine when a service provider crosses that line into management. So if the penalty is going to be increased substantially, we respectfully ask that the definition be clarified so organizations clearly understand when a certificate is required. Regarding House Bill 5511 on consent orders, we support the concept of allowing the department to resolve enforcement actions through agreed settlements or consent orders without the need for a formal hearing. That can be an efficient and practical approach. However, we are concerned about the language that would allow the commissioner to impose any condition deemed necessary when issuing or renewing a license. We believe that language is overly broad, and for that reason, we respectfully oppose that specific portion of the proposal. And finally, on House Bill 5512, concerning the change of ownership reviews, we do not oppose including real property owners in the child character and competency review. We would simply note that the child statute applies to several different types of healthcare providers, not just nursing homes, and the proposed changes may not apply equally to all of them. We would also suggest that any provider subject to the requirement be allowed the same opportunity to seek a waiver that the bill proposes to be provided to nursing homes. Thank you again for the opportunity to provide comments. I'd be happy to answer any questions.
Well done, as always. You got a lot in there, and I'd like to circle back to a few because I'll confess I was trading notes with my good ranking member for a minute there, so I missed a couple, and I want to circle back just to the consent and to the consent order portion to start with. So with that, your concern, you have a specific concern. Can you go back and just repeat that for us?
Sure. The bill adds two sentences to the current statute. One would allow the department to negotiate and enter into a consent order or settlement without having the need for a formal hearing, and that makes sense to us. But there's another sentence that would allow the commissioner to impose any condition deemed necessary when issuing or renewing a license, and doesn't necessarily require that condition they're placing be a regulation or a law. So it could be outside of the current requirements that the nursing home needs to meet. So we think that's a little too broad. We think this is a statute. It's going to impact us not just this year, but in decades to go. And so we think there needs to be some checks and balances in that system before giving that broad authority to the commissioner.
So to clarify that, you're saying you want any conditions to be tied to regulations and statute, not to be
or to have due process, right? Exactly. So either they have to be if you're breaking a regulation or you're outside of the requirements. Absolutely, you should need to be told. You need to be brought into that. Any licensed facility would be, but we just don't believe that it could just be arbitrarily imposed upon you upon your license renewal. That something would need to be done.
Okay, and yeah, that's related to the license renewal piece too. Thank you for clarifying that. There was an earlier, you were talking about the certificate requirement earlier. In my notes, I got just part of that, just before that conversation. If you can go back through that again as well, that would be great.
Sure, and it's not necessarily in this in this current bill, but the bill increases to $25,000 the penalty for managing a nursing home without a nursing home management certificate. So we're not objecting to that, but we do know that the current statute that defines who needs a nursing home management services certificate is somewhat vague. So we've known in the past, people have said, do I need one? Do I not need one? Where am I, am I going into the area where I need the certificate? So we're just saying we would like to work on maybe clarifying that statute so that people really have a clear guideline and understanding of when they need to obtain that certificate.
Okay, make it more clear. That's what
Yes.
you're asking. Okay.
Exactly.
I'm more clear now myself. Thank you for that. Seeing and hearing no other questions, we thank you for your time and testimony and wish you a wonderful weekend.
Thank you. You too.
Next online, we have Kim Sandor from the Nurses Association. Welcome, Kim. Please proceed.
Thank you, and good afternoon, Representative McCarthy-Vahey, Senator Anwar, Senator Summers, Representative Claris Dietra, and all the distinguished members of the Public Health Committee. I'm sorry I'm not there with you in person today, but I'm happy to be joining virtually and have the opportunity to speak with you in regards to House Bill 5511 and House Bill 5514. My name is Kimberly Sandor. I am a nurse and the Executive Director of the Connecticut Nurses Association. Our organization represents nurses across all specialty areas and practice settings. Both of these bills we're talking about today intersect with the work of the Board of Examiners of Nursing, or we call it the board. And I just want to highlight some important work that the board does. The board protects the public by approving and monitoring nursing education programs. They set and enforce standards of practice. They review cases and take disciplinary action when those standards are violated. And they ensure nurses practice within the profession met established standards for competent safety and professional conduct. Our nursing board is a robust and diverse group of volunteer nurses. It's an amazing group. I know you got to hear from Sal earlier, but they really represent all different licensure levels, LPNs, RNs, advanced practice registered nurses, and even include members of the public. The board works in partnership with the Department of Public Health, including investigators and legal counsels, and other folks. In HB 5511, this would authorize the Commissioner of the Connecticut Department of Public Health to manage and finalize consent orders for nurses without review by the profession's licensing board. And while I appreciate the thought about doing this, we do have some concerns that this may circumvent it will, the nurses being, their cases being brought in front of the Board of Nursing. And it's really important to note that a consent order is not just a minor administrative action, it's a formal disciplinary resolution that can really permanently affect a licensee's career. And a nurse, just because they agree to a consent order, we believe it does not replace the value of independent professional license review. A licensee could accept it for many different reasons. And just this past month, the board there were two consent orders that they actually modified. And a nurse is never going to know unless they have that opportunity to be in front of their peers whether or not that's happening. On 5514, I just want to address section 9 and 10. The first part about increasing NCLEX score reporting and posting, again, that's a licensure piece from the National Council of State Boards of Nursing. Increasing it is great. It gives the board more data that they need. Part 2 of section 9 requires that to be posted. And we might think about just making the posting happen on a website once a year while the data is still being collected. There is some testimony that talks about the concern about the shorter periods of time, not reflecting, the complete cohort and things like that. And that may be difficult for the public to understand. The posting of the graduate employment, we just want to note that there's a federal Department of Education requirement around this, and that if we are going to require this for the nursing programs to post, we just ask for consistent language alignment so it's not duplicative. We can gather the information and it can be posted and shared.
Excuse me, Miss Sandor, but you've reached your 3 minutes.
Thank you, Kathleen.
You're welcome, Kim. Sorry.
I try to talk fast.
Thank you, Kathleen. Kim, if you could finish that and just share that other thought. You were talking about section 9. You talked about posting on the website 1 time per year, and then you were talking about federal requirements by the federal education folks, if you can share the rest of that with us.
Yeah, you bet. So there's a requirement that they have to post post-graduation employment. And so that's what this second part of Section 9 talks about that. So just making sure that that language is consistent, so it's being done once and not being done a number of different ways. And I think a lot of the testimony you're going to hear and look at online once it's all posted and up there is that we are sitting with regulations that are 20 years old. And unfortunately, the regulatory process, I know it's a process. I call it the candy land. It goes through many different steps, but it takes time. And in the fast changing world of education and healthcare, training, simulation and other things like that, it's really a challenge. And all the schools have to be accredited nationally. The accreditation doesn't all look the same, but there is an opportunity to find some consistency in the language and the evaluation of program. I mean, everyone's talking about the 80% and how do you get the 80%? And these are all things in those regulations that really need to be looked at again. So the third part of my testimony was just proposing that we get a work group together to really try and hammer this out. So I think it will help the Board of Nursing as well as help the schools of nursing in meeting that need. So that was the last part. Thank you.
Thank you, Kim. I appreciate that. And we joke sometimes here in public health that work group is a trigger word, but but it's also really important. And we've had so many amazing groups who have helped us work our way through some of the issues in the off session so that we can come back ready to do the bills. But just specifically, when you talk about get a work group together, can you be as specific as you can? What would you see such a group doing?
I would love to see a group that includes the board members, Department of Public Health, the different deans and directors that represent the different types of nursing programs who are accredited by different bodies, to then review the regulations and look for some of the commonalities and the definitions where there are some inconsistencies between so they do like first time test taker and a retester, right? Like, what is that? How is that being used? Are we using just one NCLEX score to say 80%? Or are we using a rolling average of the past 3 years or 3 years putting together? So the work group would really have the job of looking through the regulations and trying to consistently define the state piece with how it's defined in the accreditation standards. Now, I say that really appreciating the role of the Board of Nursing, because nobody can be accredited if they're not first licensed and in good standing with the Board of Nursing. So they play an incredibly important role, the state and that regulatory component as it intersects with the accreditation. The accreditation is that high quality piece, right? But there's an expectation that the board is holding schools of nursing to minimal standards. And those standards are really important. And our board is amazing in looking at that quality, but there's just inconsistency of language that I think trips people up, and maybe we can come to some proposed agreement on how we can maybe incorporate some of those those accreditation, that language in a different way. Does that make sense?
It does.
Okay.
Thank you. Actually, this is really helpful. You're always really helpful, Kim, and we are so grateful for that. Just also curious, I know I'm kind of getting into the details here, but just logistically, as you look at this issue on a work group standpoint, do you think that that's something that could be accomplished in a handful or a series of meetings as opposed to an ongoing work group?
I do. I think everyone has the expertise and they're really anxious to work this out.
Okay, thank you. That's really helpful. Representative Dauphinay, no? Okay. Well, thank you so much for this. And as always, we will be talking with you again, and we look forward to it. We're fortunate to have you as a resource and guide for us.
Well, thank you very much, and I welcome it.
Thanks for your time and testimony, and have a wonderful weekend.
You too.
Next up, we have online with us Claire Circus. Claire, welcome. You look like you're in transit.
I am in transit. I was going to give that warning to everybody. So Yeah, Senator Anwar, Representative McCarthy, Fahey, and distinguished members of the Public Health Committee. I want to first of all thank you for the opportunity to testify before you today. I am on an Amtrak right now, so I want to apologize in advance for any connectivity issues, but this is an important thing that I wanted to be able to do, so I'm happy for any time that I'm able to get. So my name's Claire Circus. I'm from Farmington, and I'm currently a fourth-year medical student and aspiring OBGYN. I'm here in strong support of HB 5516, which ultimately promotes patients' access to care, ensures safe referrals, and protects providers who simply are trying to do the best for their patients. At its core, this bill protects a fundamental part of medicine, honest communication between the patient and their provider. It protects providers who discuss medically accurate options and refer patients elsewhere when a service is not available at the institution where they work without fear of retribution. In Connecticut, 1 in 6 hospital beds are in religiously affiliated hospitals that restrict certain reproductive health services. Many patients do not know these restrictions exist. National studies show that more than 1/3 of women who name a Catholic hospital as their primary hospital do not even know that it's Catholic, and about 2/3 do not anticipate any difference in the care that they will receive. Yet, more than 80% of patients say it's important to know if a hospital has religious restrictions on care. Many of these hospitals in Connecticut also serve communities that are already extremely underserved, like North Hartford, Waterbury, Bridgeport, which makes transparency and safe referrals even more important. Before medical school, I spent 2 years working at a sexual and reproductive health clinic that provided the full spectrum of reproductive health options. It happened to be down the road from one of these institutions that does not provide the full spectrum of reproductive health care. Many patients found their way to us weeks, months, sometimes years after first seeking care. I'd like to give you some patient examples. So, of course, replacing names to protect patient confidentiality. One patient named Kiara had recently given birth. She told us she had no idea that the hospital where she delivered would not offer birth control in the postpartum period. With a 1-month-old, keeping her up at all hours of the night while she was still recovering from childbirth, she also had to find an entirely new clinic, register as a patient, and attend yet another appointment. If her provider felt safe discussing her options and providing a referral ahead of time, Kiara would not have had nearly as a difficult time obtaining the care she needed. Another patient was Annie. She came with her mom. Annie was 14 years old and had devastatingly painful periods that kept her home from school many days each year. Her mom first brought her to her own OBGYN office searching for treatment, but that office was religiously affiliated and could not provide the care that Annie needed. A month and another patient later,
Claire?
they found their way to us. Yeah.
I'm not sure if you can hear us, Claire, but having ridden the rails down the Northeast Corridor many times, I know that the service is in and out. So we lost you there for a minute. Do you want to try and sum up?
Sure. So this, I guess, to summarize, this bill does not require any religiously affiliated institutions to provide services that conflict with its beliefs. It simply ensures that patients receive medically accurate information and it can be connected to the care that they need or choose. And I just want to highlight the emphasis on this is transparency for patients. They deserve the wide variety of options that are available to them. And as many patients do not know that the hospital or clinics that they're going to do not provide their access to that information and referrals. Thank you so much.
Thank you.
I'm sorry about the connectivity.
No, I'm wondering if you're nearing Penn Station. I might want to ask you some questions. We may. I'm betting that we're going to have some trouble if you're in that zone and spot. So, did you have a question, Representative Dauphiné? We'll try, but I'm not sure that we'll be able to stay connected. Representative Dauphiné.
Thank you, Madam Chair, and through you. Thank you for your testimony today. Were you able to hear earlier the testimony given by the Catholic Church with regard to this issue?
Yes.
Thank you for that. So I just wanted to offer clarity. So according to them, they do provide the medical options to all of their patients. There's a very different thing in this bill, which it talks about counseling, and counseling would include advisement. And that is the part that they have a problem with. It's not providing the patient with optional treatment. It's with regard to counseling and advisement. I just wanted to be sure that you understood that. Thank you for your testimony today.
Sure. Is there an opportunity to respond to that, or is that just a comment?
Yes, you may.
Yeah, this was a point that was brought up a couple of times earlier, and I'm glad to have the opportunity to respond to it. A really pivotal part of my medical education when talking to patients who first learn that they have a pregnancy test is a concept called options counseling. And what this means is you provide you to understand what's important to a patient, and then provide the options that are available to them based on their desires and their goals. And so the concept of counseling being so different from providing the different options available, it just conflicts with my understanding of how medical practice happens, and feels like a focus on verbiage that doesn't really play out in practice, if that makes sense, at least based off of my understanding and education thus far. And so when I have a patient who comes to, a clinic and has a positive pregnancy test, like the thing that I've learned to do is called options counseling, which is, how does this make you feel? What's important to you? How can I connect you with the things that you need? And so I just wanted to point that out, that providing options and counseling to me are not two separate entities. And in my understanding and my practice that I've been working in this field and learning in this field for 6 years now, is very, very interconnected.
Thank you. If I might respond. Thank you for that answer. So I too am a nurse, and I've practiced for, I don't know, almost 40 years. I am not practicing now, but I do think there's a big difference, and I would probably beg to differ with you. Providing medical options is very different than providing advisement on what to do. So I just wanted to offer clarity to that. Thank you so much.
Thank you. Happy to answer any further questions.
Thank you very much for being here with us today. Representative Jenga.
Thank you, Madam Chair. Thank you for your testimony. One of the arguments for this particular proposal has been that the providers are increasingly seeing threats in their ability to provide care. Do you know of any providers who've been reprimanded, or those who were not allowed to do what this bill is telling them to do?
So I just want to be clear, I'm a fourth-year medical student, and I haven't personally worked at a Catholic or religiously affiliated health institution. My testimony today is based off of my own lived experiences and also interpreting the data that's been published on this specific issue nationally. What I can say is that there is a plethora of data pointing to concern among providers at certain religiously affiliated institutions, and lack of clarity when it comes to what they are and are not allowed to do. I included some citations in my written submitted testimony, but in terms of my own personal experience, I have not worked in this area, and I don't have lived experience with that particular issue. But I would feel comfortable referencing some of the data that talks directly to providers who've experienced certain confusions or conflict or challenges when providing care to patients. And ultimately, what I think this bill does is it protects patients, and it protects their right to expect transparency from providers when seeking care. As I mentioned, 1 in 6 hospital beds in Connecticut are affiliated with one of these institutions, and 2/3 of patients don't understand that there's any difference when seeking reproductive healthcare at these places. And so what this bill would do is it would set a standard and a protection for patients to expect providers to provide, all the options that are available to them, as anyone would expect when going to the doctor.
Do you know of any data regarding any of problems here in Connecticut dealing with any of the hospitals or providers?
Yeah, so the data that I'm referencing was more from national studies. State level data I didn't specifically come across in my review of different studies. But I want to bring home that this is relevant to Connecticut because, nearly 20% of people will be seeking care at one of these institutions, and 2/3 of them aren't aware that this may be different than another institution. And so this is about patients' right to transparency and accurate information. But specifically with regards to that question, the data that I'm referencing is from a national level study and isn't based on individual states.
Thank you.
Thank you, Representative Jenga. Representative D'Amico.
Thank you, Madam Chair. Thank you, Claire, for coming and testifying as you have several times in the past. I appreciate your testimony. I'm going to be studying it along with the other testimony that's been submitted. Just wondering, since you made a distinction between options counseling and counseling, I'm not sure if I got the complete distinction, but would you feel more comfortable if this bill referred to options counseling as opposed to some kind of vague reference to counseling that might be misconstrued?
So what I would say to that is I would defer to like the governing medical body's recommendations in terms of how patients are presented with different options. Options counseling is a very common methodology that I learned and is taught to people who are, working with patients seeking this care. But in terms of like the legal language, I wouldn't feel comfortable commenting on that as a medical student. But I do appreciate bringing that concept up again, that it is intrinsically intertwined as a concept and it's taught to students in that way right now in medical schools. And so I appreciate you bringing it back to that, but I wouldn't say that I feel comfortable commenting on that in terms of the language.
Fair enough. Fair enough. So my final comment, Madam Chair, if I could, I just wanted to congratulate you, Claire, on your upcoming graduation from med school. And I know that you're going to be finding out, I believe in the next week or two, the next step on your journey. So I wish you good luck and the best of fortune.
Thank you so much, Representative D'Amico. I couldn't ask for a better rep. I really appreciate that.
Aww. That was really nice. I think we all appreciated that. And Rep. D'Amico certainly is a wonderful voice for you here at the Capitol. Claire, would also like to thank you. And so you're waiting for your match, is that?
That's right.
Yes, that is a really stressful time, and we definitely wish you luck. And my question is to something that I referenced earlier. A friend of mine, her daughter, was hoping to be an OBGYN, but she did not want to practice in the states that had much more restrictive laws for fear of being liable or not able to provide patients with the full range of care in line with her training and the training as an OBGYN. Are you anecdotally, and I know this is not data, I'm just asking anecdotally, among others who are seeking to match as an OBGYN resident, are you hearing or seeing anything about that?
Yeah, I really and but absolutely a reality. I myself didn't apply to places where I felt like I couldn't provide the full spectrum of reproductive health care to my patients. I felt like it was very important for me in my training to get those skills so that no matter where I went on to practice, I would have the ability to, I would have the experience.
Claire, I think we are having that technical difficulty. We made it longer than I thought we would, but I think what I heard you saying was that, yes, that's happened, which means, could impact our ability to have OBGYNs who are trained in the future if that continues to occur, because in this case, in the case of my friend, she did not match anywhere for OBGYN that she had applied, and she's going to be an amazing doctor in a different way, but thank you.
If you can hear me, there is data that has shown a decrease in applications to states with restrictive abortion policies. And I'd be happy to forward that as well. So this is a very real concern. Thanks for bringing this up.
Thank you very much for that. I will just note in terms of testimony, we've heard a number of people say today that they have submitted testimony. We've received a lot of written testimony this week, and I think it might take a little bit of time, but that testimony will be available online, and we appreciate that. Claire, thank you for being with us today. Thanks for your time and testimony, and have a great weekend and safe travels. Enjoy the rails. Next, I believe in person, is Alicia North. Alicia, are you here with us in person today? No, Alicia is not here today. Next online is Anuj Shah here online with us? I don't believe so, which means we go next to Nicholas Patino. Welcome.
Hi, thank you. Can you hear me?
Yes, we can. Please proceed.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Clarice Ditria, and members of the committee. My name is Nicholas Patino. I'm a physician assistant, the president-elect of the Connecticut Academy of PAs, and a member of the Connecticut MOLST Advisory Council. Excuse me. Thank you for the opportunity to testify today. I'd like to offer comments on House Bill 5513, an act concerning the Department of Public Health's recommendations regarding various provisions to the public health statutes. The bill before you today does not currently address full physician assistant inclusion in this statute. I'm here to respectfully request a friendly amendment to ensure that PAs are appropriately included in Connecticut's MOLST and do not resuscitate statutes. Medical orders for life-sustaining treatment, or MOLST, is a portable medical order that documents a patient's wishes regarding treatment when they're approaching the end stage of a serious illness or experiencing advanced frailty. PAs across Connecticut are already deeply involved in discussions for end of life with patients and families. These are some of the most sensitive conversations we have in medicine, helping patients understand their prognosis, clarify their goals of care, and document their wishes. However, under current law, PAs may execute MOLST forms with patients as part of this process, but are not able to determine that a patient qualifies for MOLST, creating a disconnect between the care being delivered and the statutory language that governs it. I'd also like to raise a related issue. In Connecticut, PAs are not permitted to complete the DNR forms used in the state's DNR bracelet system, even though these decisions stem from the same goals of care conversations PAs are already leading. 14% of Connecticut's over 4,600 PAs work in primary care, serving as patients' longitudinal provider and guiding them through serious illness over time. Yet when those same patients reach the stage where end-of-life care plans must be documented, like with MOLST or DNR, PAs are unable to fully implement their patients' wishes. This not only creates barriers for patients, but also adds administrative burden by requiring another clinician to step in. In my role as a hospitalist PA, I guide patients and families through complex goals of care discussions every day. Yet under current statute, I cannot determine that these same patients qualify for MOLST, and I cannot complete a DNR form for them, despite being trained and capable of doing so. This disconnect creates confusion and unnecessary delays during critical moments for patients and should be rectified. It's important to note that in many healthcare settings, PAs and APRNs work side by side with identical responsibility. Current law allows APRNs to perform these functions while PAs cannot. Aligning these statutes would simply ensure that patients can have their wishes documented by the clinician who is already caring for them. I've shared these concerns with the MOLST Advisory Council on which I sit and received broad support from members present to address this issue here today, and we've also submitted written testimony from several physicians and PAs in support of this issue. Ultimately, this is about updating Connecticut's end-of-life statutes to match current healthcare practices. Doing so will remove barriers and ensure patients receive timely and compassionate care when it matters most. For these reasons, we respectfully ask the committee to support a friendly amendment to fully include PAs in the MOLST statute at hand and to consider the inclusion of PAs in DNR statute as well. We've submitted our suggested statutory language. Thank you for your time and consideration, and I welcome any questions or clarifications, as I heard there were some clarifying questions from this committee at hand. Thank you.
Thank you very much, Mr. Patino. And oh, there we go. We lost you on the screen here for a minute. So
Am I back?
Make sure, yep.
Okay,
I
good.
can see you on my computer, but our screen, yep. So I was the one who asked the question earlier. If you could just speak to MOLST versus DNR,
Happily.
just give us an example of when a MOLST might be used and how that process works?
Absolutely. So MOLST and DNRs are both different forms of advance directive, which is a documented, document that basically clarifies a patient's wishes for, end of life care. Broadly speaking, a MOLST is more involved actually than a DNR. And as I said, PAs are able to write MOLSTs. I sit on the committee there as a PA member on the committee. DNR form with the bracelet system is just that. Right now, a physician or APRN has a conversation with a patient who decides that in the event of cardiopulmonary arrest, they would not want CPR or intubation or resuscitation. It's very important for the nursing home community and the EMS community. Those patients wear orange bracelets so that if they are found down in their home or in the nursing home, they do not have an attempted cardiopulmonary resuscitation. MOLST is a little more involved. It is a advanced care directive, and the special thing about MOLST is it's actually a standing medical order. So as it stands now, the provider, which PAs are included in filling out these with patients right now, has a detailed discussion with their patients about what they would want, and the patient has to meet a standard of being a life-limiting serious illness in the end stages or having a state of chronic progressive frailty. So it's for a select patient population that is really nearing the end of their life. As I said, the biggest difference between the two, a MOLST is a portable medical order. So that is a doctor's order, a PA's order, an APRN's order that goes with the patient across institutions. The purpose of the DNR bracelet is really in the public, in the field, for EMS, in nursing homes, things like that. Does that help clarify some of those questions?
A bit, and I think we'll probably have a little bit more offline conversation about this as well. A couple administrative things here in the background today, there we go. We're losing the screen again. I can see you where you are, but yes, and I think bottom line, you're asking to be added to both, particularly here in this bill to the MOLST, but you also are asking for the addition to the DNR as well.
Correct. It's really one in the same thing. PAs can write MOLST orders already, and as I stated, it requires training for all practitioners, and it's more complex than the DNR order. It really is a practice barrier. I have a friend that works in primary care in Guilford. He sees patients all the time, and if they have that sensitive discussion at the bedside during a regular visit, I think I would not want to be resuscitated. He's not able to fill out their form for the orange bracelet system for DNRs. So it's a real barrier for care, and the PA provider population in Connecticut is growing. And I'll also just mention their submitted testimony from the Connecticut Hospital Association supporting this measure as well, and our representative at the Capitol will get that to you again.
Thank you for that. And you actually referenced something that was my follow-up question, is how many PAs are there in Connecticut now? And how has that number grown over the last 10 years?
Absolutely. There are over 4,600, according to the NCCPA, which is our certifying agency, 4,600 licensed PAs in Connecticut or practicing PAs in Connecticut. That number has grown exponentially over the past 10 years. I don't have the exact specifics offhand, but I would bet that 10 years ago, the number was around 2,500 or so. And the projections of it's a field with projected like 28% growth in the next 10 years or something like that nationally. So it's certainly a growing field. There's going to be more PAs in 10 years from now caring for patients. And like I said, 14% of them are primary care providers, right? They're the clinician that knows this patient in front of them the best. And they're the ones that should be having these conversations and documenting for them.
Thank you. That's helpful context and important, I believe. Representative Dauphiné.
Thank you, Madam Chair, and through you. Thank you so much for testifying today. You shared something that I knew nothing about. I am a big supporter of the growth of PAs across the state. We're losing family practitioners by the day, and I think that you guys do an excellent job. I should say you guys and ladies, but I appreciate you, and I did not know you were limited with this particular order, and I would be very supportive of adding that to your abilities as a practicing PA. Thank you for your testimony.
Thank you. I really appreciate that, and I really appreciate the kind words. I obviously am the president-elect of the ConAPA. I think PAs are amazing, and I think we're doing a lot to fill in a lot of the shortages in healthcare, specifically in Connecticut. So I really appreciate that.
Thank you so much, Representative, and thank you, Mr. Patino, for being here with us today, for your work and also your time and testimony. Have a great weekend.
Thank you. You too.
Next, I feel like I'm about to have a reunion with my planning and development folks who I used to see testifying there. We have a group who is going to testify together so that we can cover the questions together. We have number 16, John Guskowski, number 30, Jim Paris, and do we also have number 26? Yes, Sonia Brinkworth. And the three of you, I believe, are going to discuss the results and input from a, dare I say, working group that we actually put together as this committee. So I welcome all of you. I will turn it over first, I guess, to Mr. Guskowski. If you could each introduce yourselves, then Mr. Paris, then Ms. Brinkworth, and then we'll go from there. You will collectively have 3 minutes, but we will have questions for you afterwards. So we won't start timing you until after you do your introductions. How's that, Kathleen?
Okay. You can see us and hear us all right?
Yes, we can. So if you can just introduce yourselves first, and then we'll turn it over to you.
Of course. Thank you very much, Chairman McCarthy-Vahey. It's so good to be testifying before you again. My name is John Guskowski. I'm a planner and principal with Tyche Planning and Policy Group, and I was honored to be a co-chair of the Sewage Disposal Working Group, and I'm here with my colleagues Jim and Sonia. Jim.
Hi, Representative and committee members. My name is Jim Paris. I'm the CEO of the Home Builders and Remodelers Association of Connecticut. And as John said, I also had the pleasure of being a co-chair of the Sewage Disposal Working Group.
Thank you.
Hello. Good afternoon, distinguished chair and members of the Public Health Committee. My name is Sonia Brinkworth. I'm a director of health for the town of Guilford, a registered sanitarian for the town of Guilford, and I also work with their Water Pollution Control Authority.
Thank you so much. So now we will begin. We'll turn it over to, it looks like, Mr. Paris. Are you taking the lead?
Yeah, it looks like I'll be taking the lead. Thank you, Representative. And good afternoon, Chairpersons McCarthy-Vahey and Saud, ranking members Clarities, Dietra, and Summers, and distinguished members of the Public Health Committee. Thanks for the opportunity to testify today in support of Section 11 of House Bill 5514, which directs commissioners of the Department of Public Health and the Department of Energy and Environmental Protection to evaluate the recommendations of the Sewage Disposal Working Group established under Public Act 25-97. As mentioned, I'm Jim Paris, and I'm here along today with Sonia Brinkworth and John Guskowski. Together, we had the privilege of serving as co-chairs of that working group, which the General Assembly created to review Connecticut's regulatory framework governing subsurface sewage disposal systems and develop recommendations that balance housing development costs with a risk-based approach to protecting public health and the environment. The working group included a broad range of stakeholders, representatives from DEEP and DPH, municipal planners, local health officials, engineers, septic installers, environmental professionals, and members of the construction industry. Over several months, we engaged in an extensive discussion, technical review, and collaboration to identify ways to modernize Connecticut's wastewater regulatory framework. It's important to know that approximately 40% of Connecticut's residents rely on on-site wastewater systems, making them a critical component of the state's housing infrastructure, particularly in suburban, rural, and coastal communities. At the same time, Connecticut is facing a significant housing shortage that increasingly has both economic and public health implications. The working group approached its charge with the understanding that Connecticut must continue to protect water quality and public health while ensuring that the regulatory policies do not unnecessarily impede housing production or drive up construction costs. The recommendations developed by the group were designed to function as a comprehensive and balanced framework. They address several interconnected issues, including nitrogen management policies, improvements to regulatory oversight, expanding training and certification, enhanced data tracking, and modernization of the regulatory process itself. It's important to emphasize that these recommendations were developed as an integrated package, implementing them only in isolated elements, particularly those focused solely on nitrogen requirements, without corresponding improvements to the regulatory processes and technology approval pathways, could increase housing development costs without delivering the efficiencies and certainty that the working group intended. One of the most significant recommendations involves modernizing the regulatory process governing subsurface wastewater systems by evolving towards a more structured codes and standards style framework similar to the Department of Administrative Services Codes and Standards Committee model used for building codes. Such a
Excuse me,
structure.
Mr. Paris, but you've reached your 3 minutes.
Sure.
Thank you.
So,
Thank you, Mr. Paris. If you could finish that thought about, especially talking about that modernizing the regulatory framework,
Sure.
I'd like to hear more about that. And actually, you may have other thoughts, but more specifics about that in particular.
Sure. No, thank you, and I appreciate that. Such a structure would provide greater transparency, predictable procedures for evaluating new technologies, and ensuring that decisions are guided by sound science and technical expertise. There are several other states, including Wisconsin, Florida, and Vermont, to name a few, that already utilize structured advisory committees that review and vote on technical standards before agencies initiate formal rulemaking. Connecticut can really benefit from adopting a similar model. With that, I can wrap up, Representative, and answer any questions along with John and Sonia that you may have.
I do have a number of questions, and I want to say thank you to you and the rest of the group, and also to the Department of Public Health for engaging in the conversation, to the Majority Leader's Office and his team, actually, for the support of the conversation as well, along with always our team behind the scenes in the Public Health Committee. This is an important working group and an important conversation, and there is a significant amount of complexity to this. How many recommendations did the group end up coming up with, and can you give us a sampling of some of the other recommendations that you had put forward? I want to talk more about the regulatory framework piece, but can you give us a sampling of some of the others? And I'll put that to any of the three of you.
Sure. We can cover this, through the subcommittees that we put together, and each of us were in charge or oversaw one of those subcommittees. For the Nitrogen and Environment Subcommittee, over which I oversaw, there were specific recommendations pertaining to the size of the septic systems, particularly that, and at which point those systems would be subject to nitrogen assessments and potentially require significant nitrogen removal technologies in order to use a system of that size in a particular area. The recommendation of the working group with regard to nitrogen was specifically any system under 7,500 gallons across the state would not require a nitrogen assessment unless those systems were located in what would be deemed nitrogen sensitive areas. And in that case, those nitrogen assessments would take place at 5,000 gallons or larger. And that really is
Before you go on, can I ask a clarifying question about that?
Sure.
So just to say the current standard. So the recommendation was that under 7,500 wouldn't need that nitrogen assessment unless it's in a particularly sensitive area.
Correct.
And if it was in a particularly sensitive area, you would change that threshold. The recommendation was to change that threshold to 5,000.
That is correct. Yep. And really, with regard to the nitrogen group, that was in part or in large part the recommendation. Again, it defined nitrogen sensitive areas to coincide with the coastal area management maps, and also, I believe, within 100 feet of a wetland. And John, if you'd like to go ahead and summarize the findings of the process and funding subgroup.
Okay. And just, yeah, thank you, Jim, and thank you, Madam Chair. So the overall recommendations, we made, I believe, 20 independent recommendations. There was some overlap, and a lot of them dealt with the establishment of a code advisory committee and the function and operation of that. In terms of strengthening the regulatory structure and oversight, which was a lot of what my subcommittee dealt with, we encouraged the continued maintenance of oversight for subsurface water disposal with the Department of Public Health, and encouraged the department to do some organizational adjustments to make sure that there are sufficient staffing for that. So that would basically be a funding recommendation ultimately to the General Assembly. We encouraged the creation of a statewide education and training program for public health staff, as well as local sanitarians, installers, engineers, and those folks, just to make sure that everyone is on the same page in terms of the technology and in terms of the science and the chemistry. We recommend authorizing work sharing among and across health districts through memorandum of understanding, because very frequently you have one area, one region of the state that is a little bit crunched in terms of applications, and we've got certainly qualified sanitarians and other public health officials that might be in other parts of the state less busy that might be able to help out. Similarly, we were encouraging a more unified fee structure and scheduling of reviews to ensure both uniformity and some cost certainty for developers, that they know that they would get through a process in a certain amount of time. And then finally, we recommended the creation of a homeowner loan assistance fund to assist with financing of repair or replacements of failing systems. So there was, again, the number of recommendations here, but those were the highlights from my subcommittee. And if there are no immediate questions, I'll let Sonia detail some of her subcommittee's recommendations.
Thank you, Madam Chair. My subcommittee was the Regulations and Legal Subcommittee. Currently, the regulations only specify for a sanitarian to take a phase 1 and phase 2 once, and that's it. So our suggestions, our recommendations were to—
Sonia, may I interrupt? I apologize for interrupting, but so public health, this is an area that we haven't had a lot of conversation about. So when you say phase 1 and phase 2, 4th grade level for us, please. What does that mean? And what are you referring to when you say that?
It's initial training to be able to inspect septic systems. We learn how to take elevations in the field, and that is only done once. So we take a course as you become a sanitarian. Phase 1 would allow you to do repairs. Phase 2 is a training for actual professional engineer review. So our recommendations was to expand on the training and require continuing education. Part of the expansion would be to do more field training, which means the elevations that we're supposed to take, as well as documenting how the septic system is installed. The other part that is a very critical part for septic system is something called soils training or soils morphology. It is not a requirement, which it should be. And that is one of our recommendations. DPH is wonderful. They put a class on once a year or once every other year, but it is only done usually by sanitarians once. There is no requirement to continue. So our recommendations was to ask for that to be included within the phase 1 and phase 2, as well as continuing education, so that we can continue getting experience, or I shouldn't say experience, The technology is constantly evolving. The regulations and the technical standards are what we use to, inspect systems and to review plans. It can get complex, and there's an ever-changing landscape right now, especially when we're talking about climate change affecting systems. So having continuing education for sanitarians is a very strong recommendation from the group. That would have been the training. Another thing that we had asked about was to put more strong language about, or even recommendation language about, asking for a soil scientist. When we're doing these very large systems, it can be very difficult. The soils are key. And if they are not read correctly, then it can cause a lot of problems like breakout of the system. So the soils, so that was a recommendation to start at kind of train the sanitarians to ask for more assistance with soils training. On the shoreline, we have very difficult soils, so it is something that we are passionate about down here on the shore. And those were really the main things that we focused on, but my other two colleagues mentioned it. We also talked a lot about a codes and standards type of segue. Or, we do a code advisory committee to either look at it or formalize it a little more, or to look at something like a codes and standards. And those were pretty much the topics that we spoke about in our regulations and legal subcommittee.
Representative, if I may, I neglected to mention a couple of other things that the Nitrogen Committee really oversaw as well and made recommendations on. And one of them was the need for more data. And we realized that a data, and not only the data, but really the system in which that data is collected and categorized. The challenge, I think, is that there isn't one consistent, uniformed method by which the DPH, the DEEP, and the local sanitarians gather data, nor is there a singular repository of data. And it really would be important, I believe, in the working group, surmised that this sort of data would be really important for, for coloring the way we proceed moving forward with how we regulate nitrogen in the state of Connecticut, how we determine systems that we should be approving moving forward, and really determining what kind of new technologies we could be utilizing. So we thought that was incredibly important. And I should say, along with Sonia and John, the Nitrogen Committee really did see a somewhat of a code advisory type or codes and standards type of committee as a way in order for the state to move forward to study long-term nitrogen issues and policies, in determining, again, a methodology for approving newer systems and technologies moving forward.
Thank you to all three of you. It's a lot, and there's a lot to tackle here. And I know, the goal is to continue to move forward. I wonder if you can just briefly step back. I don't know how much conversation happened here at the Public Health Committee, because I was over on Planning and Development, about kind of why we are here. Why are we here having this conversation, and what's kind of been the change over time with the DEEP and DPH piece of this, just to give some context and history, again, briefly, if you could.
Sure. I guess I'll take a stab, and John and Sonia, you can fill in the blanks that I'm sure I'm about to leave. This conversation is one that's been happening for well before I became an advocate for the Home Builders and Remodelers Association. In fact, I think it's a conversation that's been going on for 20 plus, maybe close to 30 years now. There is a bifurcation of regulatory responsibility between both the DPH and the DEEP. The DEEP is historically oversaw very large septic systems, and the DPH has overseen smaller, more traditional septic systems, and that the regulatory boundaries of those two state agencies has evolved over the years, with the deep covering systems that were 10,000 gallons or larger. Legislation was changed a few years back that said that those systems would be 7,500 gallons or larger. And so in each time, obviously, the DPH is taking on a larger swath of the regulatory environment, if you will. And at the same time, legislation was put forward over a decade ago that would require DPH to promulgate regulations pertaining to alternative treatment septic systems. And the legislation for a very, very long time said it was to be done within available resources. I think legislation changed a year or two back that says, no, DPH, you really do need to promulgate those regs regardless of the resources. And so, there is a question now about, the very complex and technical requirements that surround, promulgating regulations that are as complex as alternative treatment septic system regulations. And so there is a question as to whether the Code Advisory Committee, which is completely advisory in nature, could be revamped to better assist and be part of those conversations pertaining to technical standards and pertaining to regulations as a whole pertaining to septic systems. And I think that's where we are now is there are, there's the regulatory entities, there are the practitioners, and the local regulators, all who have opinions about how these regs could best move forward. And obviously, we'd like to see it done in a most collaborative and transparent way possible. John and Sonia, please. That was probably a word salad.
Sonia, Ms. Brinkworth, would you like to add to that?
Yes, I would. So I do work in local health. Our jurisdiction is less than 2,000 gallons per day. DPH is 2,000 gallons per day to 7,500 gallons per day. And anything over 7,500 gallons per day, community and AT systems are under DEEP. My town happens to have all of them, all those types of systems. So I do work with both agencies. But the one thing I would like to kind of go on top of what Jim was saying, I work in a town that's sewer avoidance on the shoreline, and many of the towns that are sewer avoidance on the shoreline have something called a wastewater facility plan. And in those plans mentions advanced treatment or alternative technology. Alternative technology would be the word that is used here, alternative technology. So since 2007, these towns have wanted to put these systems into the ground because they do reduce nitrogen substantially before it hits our groundwater in Long Island Sound. So that is my thing with AT. We are right now, it's under DPH, but the regulations have not been, from what I understand, developed. I do go to many conferences about AT. I've been to Suffolk County. It's a lot. It's a lot. So my thought with the codes and standards potentially, or some kind of group like that, would really mostly be focused on AT. There's a lot of states around us that have incredible work done already. So it's not something that you have to reinvent all the time. And I think it's the sanitarians. They did in one of the bill put another training on, which deals with AT. This is from DPH. They put it in one of the bills that there would be a phase 3, and that's for AT. But we can't get there until the program and the regulations have been developed. So I just wanted to make sure that I added the AT part to this conversation and being on the shoreline in sensitive areas.
Thank you. Thank you for that. A couple quick follow-ups. I could talk to you guys all afternoon about this, but I will not do that to my colleagues. It just speaks to the fact that we will need to have ongoing conversations about this, because with 20 recommendations coming from the group, and it's something that is impacting our environment, it's impacting our waterways, it's impacting our ability to create homes and choices for our residents with where and how they live. So it's a huge issue, and it's definitely literally something, beneath the surface that impacts all of us. Quick question in terms of the soil, the continuing ed, adding the required training. You mentioned that DPH has offered that periodically. Is it the expectation or hope of the group that the department would also require that continuing education, or would someone else be able to provide, not require, would be able to provide that?
So we recommended for DPH to develop the training program. I'm not sure how they will handle that. I know that there are some programs out there that actually do teach field standardization, meaning elevations and such. The soils training, it's just very, very good for sanitarians. And our whole point was to ask for the soils training to be part of the initial certification process, because it is so important.
I'm sorry, Sonia. I mistakenly had left my microphone on. Will you just repeat what you had just said, and then I'll share what I was saying to the side.
Sure. So soils training is something that is voluntary, but it really should be done. And what our request was to make sure that we put that in the initial training. When we as sanitarians are starting out, soils training is probably the most important thing. So having that as your initial training would be extremely helpful. And then continuing education. I don't know how exactly that would happen, but there's a range of topics that a lot of the sanitarians could really use going forward, because everything's changing. It's a constant change with proprietary products, with the way the climate change is affecting our land. So yes, it's not an every year thing required now, but it really should be. Not every year, I'm sorry. Initial, it should be required, and the potential of taking it more times would be great, and I would think that would be something in their continuing education.
Thank you for that. And what I was noting is you did submit your report to the committee, and we can make sure that all members of the committee have received that report, because it is extensive. Last question I'm going to ask, and again, if we can just briefly, because I know this is something that could be discussed at length. The codes and standards that you were referring to, Mr. Paris, again, different committee, different purview. So just walking us through as succinctly as you can how that would work, because what I understand you to say is that essentially you're looking for a group of technical experts who could advise the department as they are promulgating the regulations, similar to and parallel to what happens with the building codes with the
Correct.
Department of Administrative Services, and they have a body of experts who advises them as they are promulgating regulations. Is that a correct statement?
That is absolutely a correct statement. With regard to the Department of Administrative Services Codes and Standards Committee, it really is a group of technical experts that really work in a nonpartisan fashion. It's a very wide, not only is it an august group, but it is also they also have varying wide interests and expertise. If you look at the statutory makeup of the Codes and Standards Committee, it includes environmentalists, it includes trades folks, it includes engineers, it includes building officials and fire marshals and more. And all of these guys and gals bring their backgrounds and various expertise to the table to help the department promulgate regs. And in that way, it happens in an incredibly transparent process. Once the codes are drafted, there's a public hearing process, and then obviously everything goes through the traditional regulations and reviews process. But from what I understand and from what I hear from individuals who work and are part of the Codes and Standards Committee, it is a very effective, very open process. And again, not unlike the complexity of, of what would be septic system regulations. Of course, the codes, the building codes have their own, nuances and complexities as well. And so given that the technical aspects of the building codes and the technical aspects of the septic codes, you would see how the system could work well for septic system regulation as well.
Well, again, I want to thank the three of you. It's nice to see you here in public health and not just over in planning and development. And just grateful for the time that you've all put in. And again, thanks to all who participated in that group. And we'll look forward to ongoing conversations with you all here and see what we can get done. I know timing-wise, I think you guys know this already, just in terms of bill process. We certainly aren't going to get to 20 recommendations this year, but it sets us up really well for building on this into the future.
Great.
Thank you all. Oh, I'm sorry, Representative Kennedy has a question. Please, Representative.
Yes, after a long week and 2 o'clock on Friday afternoon, I'm very intrigued by the language in Section 11 of this bill. It seems like there's a lot for us to look over, and I look forward to looking at your recommendations. If I got the report, I apologize. I misplaced it or just overlooked it, so I do look at finally reading through that, your recommendations. To Sonia, you had mentioned training of sanitarians. In this regard, are the sanitarians currently have some training with this, or is this going to be a new training for them through you, Madam Chair?
Please proceed, Sonia.
Madam Chair, sorry. So we currently have some training. Yes, they take it's like 4 or 5 classes over a couple months for the first phase, and that allows you to do certain parts of the training. And then the second part of the training is for engineers, just reviewing the plans. We are trained sanitarians out there inspecting systems. One of the biggest things I would have to say is that we had a huge retirement, and the people that were the best at training, because a lot of trainings were done in local health. A lot of the really good sanitarians that were great at septic retired. We had a lot of people retire throughout the pandemic. So that kind of led us to a point now where training is definitely more training is definitely needed, and we don't have the gurus of septic in these health departments anymore being able to assist with the sanitarian training in the field.
Thank you for that. I appreciate that. Madam Chair, one other question, if I may, please. Thank you. And then also, I think you mentioned earlier in your report, you were talking about the shoreline area having soil that's a little bit different, I'm not sure how you'd say the soil matter. I represent a shoreline community. Can you just elaborate more on that point? What were you talking more about, or how is that? Would the training for those sanitarians in those particular areas be different? Through you, Madam Chair.
Madam Chair.
Yep, please proceed.
Thank you. So yes, I've actually worked for the last 15 years on a shoreline dealing with these very difficult systems. Pure sandy soils are very difficult to read when you're trying to find where that groundwater is. Our septic systems have to be a certain elevation above those restrictive layers. And one of the things that we're seeing in really sandy soils, which are a lot on the coastline, is that they're affected not only by septic systems, but stormwater, as well as intense precipitation and flooding. So we would like more training for the shoreline, but the sanitarians are already there. We work really well together. When I start talking to other sanitarians, they're like, wow, I don't want to deal with that type of stuff. It's definitely something through the years of working with engineers, and I would like to have parts of what we deal with on the shoreline as part of the training program. And yes, it is very different.
Thank you very much. I probably have a bunch of other questions, but I think I'll look forward to reading through your recommendations and save time for anyone else that has questions. So thank you to all three of you for being here today, and thank you, Madam Chair.
Thank you, Representative Kennedy, and I appreciate that curiosity on this issue, very technical. So just to reiterate for everyone on the committee following, that was number 16, John Guskowski, number 26, Sonia Brinkworth, and number 30, Jim Paris. And we thank all of you for being here with us and for your time, your testimony, and we hope you have a wonderful weekend. And with that, I am going to turn it over to Senator Anwar.
Thank you, Madam Chair. Thank you for your help this morning and afternoon. With that, the next person on our list is Ruth Groby, who's here. Welcome. Good to see you, Ruth.
Thank you so much. And Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee, appreciate your listening to a request today to make an addition to HB number 5514, an act concerning various revisions to the public health statutes. I am the Secretary of the Citizens Coalition for Equal Access, or CC=A, a small grassroots disability advocacy group that has been working on healthcare advocacy over the past 7 years. Our biggest victory came in 2024 with the passage of Public Act 24-113 concerning the availability of accessible medical diagnostic equipment that meets the 2017 U.S. Access Board standards. The law requires medical facilities of a certain size to take an inventory of their accessible diagnostic equipment and, if insufficient by the standards of the bill, to purchase accessible medical equipment by January 1st, 2026. However, Public Act 24-113 has no enforcement provisions. Now that the enactment dates for all the law's provisions have gone by, we are getting individual stories that some medical facilities have abided by the law, but we have no comprehensive data, and patients with disabilities are still reporting problems. Because of these problems, disability advocates have been trying to get the Department of Public Health to check on the relevant facilities' compliance with the bill, but we have gotten nowhere. The DPH says that individual patients with disabilities will need to file complaints regarding specific facilities. We are very much opposed to this recommendation for 2 reasons. One, more than 2 years ago, 2 of our CC=A members filed an ADA complaint about the lack of accessible tables at a local radiology facility. There has yet to be a resolution of the complaint, and it is our understanding that the DPH complaint process is equally backed up. Second, we should not be putting the onus on the individual person with a disability to correct a systemic injustice that should be fixed by the large systems that are involved. The Citizens Coalition has been working with a wonderful member of this committee, Mike D'Amico, on changes to the language of the relevant statute that would spell out enforcement provisions, such as a requirement for medical facilities to report their compliance efforts to the Department of Public Health, or a requirement for the DPH to do inspections with fines attached to noncompliance. We were hoping that HB 5514 might include such changes to Section 19A-490DD of the general statutes.
Excuse me, Ms. Grove, but your 3 minutes you've reached your 3 minutes.
We are very
Please complete your sentence.
We are very disappointed this is not the case and would strongly recommend an amendment to HB 5514 to make this happen. Thank you.
Thank you so much for your testimony. I was almost seeing Representative D'Amico. Go ahead.
I'll defer to the chair or the chairs if you have any questions. Otherwise, I'll go now.
We'll have you go now.
Okay, great. Thank you very much, Mr. Chair, Madam Chair. So Ruth, thank you for coming and testifying today. Thank you for your efforts over the years to ensure that persons with disabilities have access, equal access to medical diagnostic equipment and other aspects of our society to which they should have equal access. So I just want to make sure that I understand your testimony correctly. So you are asking that bill number 5514, this Department of Public Health revisions bill, include a couple of things, if I'm not mistaken, correct?
Yes.
And those would be?
Some kind of enforcement provisions, either to require reporting to the Department of Public Health about your purchases of accessible medical, reporting the inventory that the facility took of its accessible medical diagnostic equipment and what needs that indicated and what has been done to purchase equipment to come up to the standard required in the bill. Or else, I guess, the other way around, which is to have the DPH do inspections of facilities. I'm not really an expert in how this should work. I was kind of hoping that the Department of Public Health would, but not without being required to do enforcement provisions, right?
So thank you. So I'm looking at the provisions of Public Act 24-113 right now, and among other things, it notes that healthcare facilities and practice locations are supposed to post information on their internet website or make such information readily available regarding the steps that patients may take to contact the healthcare facility for assistance with patient access needs. To your knowledge, has that taken place?
Not that I know of. One CC=A member had a recent experience of trying to get an MRI at a large facility, and there was no specific line that she could call to explain what her issues were, or at least there didn't appear, it was not readily evident what the line was.
Okay, thank you. And the legislation that was passed 2 years ago further states that healthcare facilities and practice locations need to take and document an inventory of medical diagnostic equipment that meets the standards for accessibility. And also to come up with an action plan to address gaps in their inventory. Do you know if that has taken place?
No, and we haven't been able to get any information from the Connecticut Hospital Association or from the Department of Public Health, or we're not quite sure where we should go or what we should do. So we need the help of this committee.
I would agree. So to go further, the legislation requires documentation be made available to the Department of Public Health regarding the steps that have been taken. Would you know if that documentation has been made available to the Department of Public Health?
I do not know.
Okay. All right. So would it be fair to say that if there were some kind of enforcement mechanism added to the legislation from 2 years ago, that documentation would then be available to the Department of Public Health?
I would certainly hope so.
And would you say that this bill would be the proper venue for that to take place?
Well, it seems to be talking about changing the language of statutes, and so that's why I referenced section 19A-490DD. I would think we could just add that language in there. Okay.
I appreciate that. So I'm just to go further into this bill that you're referencing from 2 years ago. It requires that as of January 1st, 2026, which would be this year, January of this year.
It's already gone by.
It has. So healthcare facilities and practice locations have to make available or have available an examination table or an examination chair that meets standards for accessibility and at least one examination room, and that they also have to have available at least one weight scale that meets standards for accessibility. Do we have any way of knowing whether the healthcare facilities or practice locations have complied with this?
As I said in my testimony, we have individual examples. But then I also have individual examples. Just last week, I helped a C=A advocate write letters to his doctor talking about Public Act 24-113 because the exam table, and it's a practice of more than three exam rooms. And, you know, because the exam table was so old and tiny and he couldn't get on it.
Okay.
So we have examples in both we have examples of compliance, but we also seem to have examples of non-compliance.
And just to make sure that I understand your testimony, you are saying that if there were an addition to this, if there were an amendment or an addition or a revision to the statute from 2 years ago that required some kind of enforcement mechanism, that would be a good step towards solving these problems.
Yes.
Okay. And you said, just to recap, you said that it's been, that there have been a couple of complaints that have been filed about the ADA non-compliance, and it's been a couple of years, at least 2 years,
Yes.
with no resolution.
More than 2 years with
I
no
see.
resolution.
I see. So that's troubling to hear. So I'm just going to read you one quote that you might find, that you might appreciate. One of our colleagues told me a long time ago in this building that legislation without enforcement is not law, it's just words on paper. Would you say that quote adequately reflects what's going on here?
I would definitely say so, and may I offer a quote from our co-chair of the Citizens Coalition? Because I realize what difficult times we're in right now, but he said, "I am 76 years old, and I have been told since childhood that now isn't a good time for taking care of my needs."
Thank you. That sums it up pretty well. So again, just to make sure I understood you correctly, that your concern is that without any kind of enforcement mechanism to require compliance with Public Act 24-113, we're actually putting the burden on the patient rather than on the facility or the entity to make sure that this law is being followed. Is that accurate?
Yes, and people with disabilities already have a hard enough life.
Yeah, thank you. So, Mr. Chair, Madam Chair, I appreciate the time, and I hope we can make some efforts in this session to make those corrections that Ms. Groby has recommended to us. Thank you for your testimony, and thank you for your forbearance, Mr. Chair.
Thank you so much. Thank you, Ms. Groby, for your testimony. Thank you, Representative D'Amico, for your advocacy. We will have to have a conversation with DPH. We'll have to look at what we can do. I cannot promise whether this would be during this session or not, but we have spoken to you a few times before your testimony as well that it's going to need a little bit more coordination, but this is the place where we can have that coordination. The Public Health Committee is the committee that can do this. We have been the ones who were, with your efforts and all the other people who came and spoke, we were able to change the law, but we have to obviously improve further to provide the resources, but also some other way of implementing and making it real. So we hear you loud and clear, and thank you for your advocacy.
Thank you very much.
Thank you. All right. With that, we are going to move to the next person who is online, Carson Ferreira. Mr. Ferreira, you're on.
Hi, everyone. Thank you. Can you hear me okay?
Yes.
Okay, great. Hi, Senator Anwar, Representative McCarthy-Vahey, ranking members Clarice Ditria and Summers, and distinguished members of the Public Health Committee. My name is Carson Ferrara, and I am here today in strong support of HB 5515 and 5517. HB 5515 is a technical bill that expands and clarifies access to naloxone, allowing any qualified school employee to maintain and administer it in the event of an emergency when a school nurse is absent, which is similar to what exists for epinephrine, glucagon, and anti-epileptic meds in the statutes. It also lets them do it even without authorization from a parent or guardian, functioning like stock epinephrine for emergencies. And when you think about how important time is in the event of an opioid overdose, this is a crucial update to existing statutes in our state. Also, if someone administers it due to concerns of an overdose and the person isn't actually overdosing and has no opioids in their system, there are no medical consequences and it doesn't doing anything in those cases. Basically, it's an expansion of Good Samaritan protections. Also, as someone who conducted overdose response trainings across campus in undergrad at Vanderbilt and in grad school at Yale, I appreciate the bill requiring that school nurses and employees complete an overdose response training and learn how to administer naloxone if they haven't already. A training can be done in a very short amount of time, usually less than 15 minutes. And I just think it's a great provision to the bill and a huge proponent of everyone, regardless of their position, knowing how to respond to an overdose event. Regarding 5517, I support cleaning up outdated and stigmatizing language towards people who use drugs and people with an SUD, because it's been shown that stigma is a barrier to care and we want people to feel comfortable and willing to access services. People first language is essential. So terms like drug addicts imply someone is something instead of a person. So using person who uses drugs or person with a substance use disorder shows that they might have a problem or illness rather than being a problem. The term abuse was found to have a high association with negative judgments and punishment. So using use instead is preferred. And then testing positive as opposed to dirty or failing a drug test highlights how we should use medically accurate terminology the same way it would be used for other medical conditions. Behavior change research shows that these terms might decrease a person's sense of hope and self-efficacy for change. Finally, being in remission or recovery, abstinent from drugs, and testing negative are preferred over the term clean, again, because this can help reduce stigma. So thank you so much for the committee's work to help make addiction care stronger for people in our state, for wanting to reduce overdose rates, and I'm happy to answer any further questions. Thank you.
Thank you so much, Carson, for your testimony. Carson, have you heard in your work about some schools restricting Narcan availability? Because we had at least some complaints that the schools were saying that we're not trained and we feel uncomfortable with it. And then I know there's a death in Hartford a few years ago, which again, every death is preventable, but do you have any insight in that aspect?
Yeah, absolutely. I have heard of cases like that specifically in Nashville when I was a student in undergrad. I hadn't heard about them in Connecticut per se, but I think with how widely accessible naloxone is and easy to use, this kind of is a no-brainer bill in my mind. And I think it would just be beneficial for everyone to be prepared in the event of an overdose emergency in the same way that you would be for, like an allergic reaction on a school campus or something like that.
And another part is with respect to the stigma, any other thoughts on how we can try and address the stigma in our society?
Yeah, I mean, I think when it comes to language, I like to try and respectfully point out to people or urge them to use different words when they're speaking. So I would encourage all of you as the Public Health Committee members to strive towards that and, work to not say things like addict and instead use, person who uses drugs or a person with a substance use disorder. I think that goes a long way. And then I know DPH has been working hard on a stigma reduction campaign as well. And so advertising that and really just trying to have more conversations about it, I think would be very helpful.
Good. Thank you so much for your testimony. Seeing no questions or comments, we appreciate you being here. Thank you.
Thank you. Just one quick clarifying question. I submitted written testimony, but I wasn't sure if there might be like a glitch on the portal because what I see for these specific bills, I see a lot of testimony related to the vaccine bills from several days ago. And so I just wanted to flag that and ask if I did something wrong this time or.
No, I think others may have done it inaccurately, but we will check on that and make sure your testimony gets on there. Thank you.
Okay, great. Thank you.
Okay, that brings us to number 19, Karen Griffiths. You're online. Welcome. No, I don't see you there anymore. Sorry, I thought I saw you. With that, we are going to have number 25, Cara Delaney, Dr. Delaney, who is physically here, but she has to go and she's switching spots with Dr. Nancy Stanwood. So, Dr. Delaney, you're on. Welcome. Thank you for being here today.
Yes, thank you so much for having me and for taking me a little early. So thank you, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Dr. Cara Delaney, and I work in Farmington, Connecticut. I am a board-certified obstetrician and gynecologist, and today I'm testifying on behalf of the Connecticut section of the American College of Obstetricians and Gynecologists in support of Bill 5516, an act concerning reproductive rights. This bill provides employment protections for healthcare providers if they choose to provide patients with medically accurate information or referrals. In short, medical discussions and decisions are left where they belong, in the hands of patients and their professional healthcare providers without outside interference. As doctors, we took oaths to respect patient autonomy and provide the best quality patient care with competence, integrity, and compassion. We should ensure that healthcare institutions do not prohibit healthcare providers from delivering medically accurate information, counseling, and referrals that are not in line with institutional policies. This includes full-spectrum reproductive healthcare and gender-affirming care. Restrictions on discussions between patients and healthcare providers hurt patients and lead to moral injury of providers. It also creates delays in accessing timely and life-saving care, exacerbates existing barriers, and further perpetuates stigma and shame for anyone who may be seeking care. I have the privilege of taking care of patients throughout their lives, and this bill is not based on theoretical situations. In my practice in Connecticut, I have seen multiple patients who saw medical providers that would not share information or referral for abortion care, or a patient was too afraid to ask for that information because of the type of institution they were going to. These are examples of patients that had good medical care and access but were left on their own because of the type of medical care they desired. Physicians in our organization, ACOG, have worked or work in faith-based institutions and have shared that they felt limited in providing counseling of full-spectrum reproductive health care due to fear of reprisals. This type of moral crisis between a physician and state law, a physician and state law or institutional regulation is called the chilling effect. These patients bear the burden of self-referral. We have to remember that patients often do not have a choice about the medical providers they are assigned to in clinic or in the emergency room, nor can they easily leave a hospital system because of insurance needs, or this is where their trusted doctor is employed. To practice at the highest level, we want to practice openly without fear of reprisals. Passing this bill is an opportunity to improve health equity in the state as well. Self-referrals will be more difficult for patients who do not speak English, have limited internet access, and less financial means. By protecting providers' free speech to give medically accurate information to patients and provide timely referrals without the specter of employer retribution, we take a step towards progress in the health equity space. So ACOG supports HB 5516. We respectfully urge the Public Health Committee and the Connecticut General Assembly to vote favorably on this bill. Thank you so much.
Thank you for your testimony. We appreciate you being here in person. I want to make sure I heard you correctly. What you're saying is this is not a theoretical issue. This is happening and your members have spoken about this.
That is correct. I have multiple members who, one in particular who worked at a faith-based institution for several years, felt like they could not provide full-spectrum care, full-spectrum counseling without reprisals from their institution, and so they left. And this was them not only leaving like a job, this was them leaving like the patients that they had worked with for many years. So it was a very difficult decision for them.
My co-chair has a question. Representative Kristen McCarthy.
Thank you very much. Thank you for being here with us today and for your testimony. And you, I believe, were here earlier to hear the earlier conversation. Is that correct?
That's correct.
So I only asked that so that to have this in context of that. When you just shared what you did, you heard my conversation with the deacon in terms of asking In this case, the provider you're referring to, again, I'm the patient and I'm seeking care, and the provider was offering the full spectrum and range of choices available to the patient, whatever that may be, you know, and I use the example, including abortion as an example. And what you're saying to us is this provider did not feel that they could offer the information about that full range of choices. You're not talking about the provision of care.
Exactly.
You're talking about
Right. So I'm not talking about any provision of care. So actually like providing an abortion care method, including like medication or a surgical procedure. They felt like they were walking a very thin line between being able to properly counsel patients about what their options were and to be able to give referrals and to do so in a way that would that they would be able to like keep their job or avoid getting reprimanded.
Thank you, and I appreciate we had you also heard the student who was Rep. D'Amico, who's gotten a few shout outs today from his constituent who was on the train, and she was sharing some stories, so we didn't get to hear everything. Mostly we heard what she was able to say. But, you know, oftentimes we talk about abortion here, but we could also be talking about things like birth control or earlier reference to ligation, any of those aspects that are not allowed under the directive at a Catholic hospital. And again, with gratitude for our Catholic hospitals, but that it's the full range of care that we're talking about.
Yes, that is correct. We're not just talking about abortion care. There's lots of different types of care that is included in like the federal statute that includes like the conscious clause. So individual physicians can choose to talk about different types of care, and that includes like giving blood transfusions, it includes vaccinations, it includes sterilization, and so this bill, from what I reread, and I reread the last part as well, it states that physicians and medical providers are allowed to talk openly about all aspects of care and give counseling about that type of care without fear of reprisals. It does not talk about actually providing that care. And it also specifically says, I think there was a question previously about like the very last part of this, that actually it does not apply to healthcare providers who do not provide that full counseling. And so it is just protecting people who choose to provide patients with the full spectrum of care.
Thank you for that and for the conversation here today.
Thank you. Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for being here today and giving us some really important information. My question on process, if you're a provider and you're required to give information on whatever the subject is, you're giving information, but say if it's a hospital, does the hospital decide what information you're required to give on certain subjects? I'm not really sure. I'm not sure with the language in the bill how that is, so I didn't know your interpretation on that.
So my interpretation is that the bill will protect physicians and other medical providers if they choose to give information to patients about referrals and about full spectrum of care.
So information to the best of your ability, what you feel the information should be. That's where I'm a little confused. So you may say A, B, and C, I'm giving you all the information I have on this subject. But my concern is that the hospital or whoever your boss is may have a different definition of information. I just want to make sure that we figure all that out before this goes through.
One of the amazing things about being in medicine is that we're constantly learning. And so we have to go through training courses. And so many times, as a physician, we are in a constant learning process, and we get exposed to different things in different ways that maybe administrators don't. I also wanted to say that because of that, the hospital is, they have hired physicians, not only because they are just there to follow the rules of what the hospital puts forth, but also because of the knowledge that they have and their ability to communicate with patients. And so when we are counseling patients and we're sharing our medical knowledge with them, we do so in a way that also but that also goes with our medical training and the oaths that we took to provide patients with the best type of medical care. And for each provider and each physician is different, but that type of medical care does include full spectrum counseling if they choose to have that on.
Okay, thank you very much for explaining that, and thank you for being here today.
Thank you.
Thank you. I think that question made me think about clarifying one more thing. There's a training that you go through as physicians, an OBGYN training, which is thousands of hours, according to some estimates, some 20,000 hours of training. So you get to understand what is the standard of care with respect to providing care to individuals. So it's not like a personal view of an individual that's being suggested. It is standard of care that is being suggested. Is that my correct understanding?
That is correct. We, as physicians, try to follow the standard of care as much as possible. That standard of care is also a moving target. And so we do have to stay up on all the most recent things. But as someone who is currently representing ACOG, for example, ACOG is an organization that constantly puts forward practice bulletins and committee opinions to help their members stay abreast of the most recent science. And I just wanted to mention, if it's okay with you, that they also have a definition of counseling, because that was brought up previously, and I just wanted to read that. So for ACOG, the definition of counseling is patient-centered, evidence-based education and communication focused on optimizing health, mitigating risks, and supporting autonomous decision-making for reproductive health, including pre-pregnancy, contraception, and overall care. So we cannot disconnect our medical knowledge from counseling patients, because that is just how we communicate. And it's really the best way that we can take care of our patients and also our communities. And so when I talked about the chilling effect before, if in some ways there's any restrictions in the way that we are counseling patients, it really makes it difficult for us to give the highest quality standard of care to patients.
Thank you. And look, every OBGYN physician has the opportunity to become part of ACOG if they choose to.
That's correct. There is there's also a monetary part of that too, but yes.
Right. And yes, but that does not. If let's say there is an OBGYN physician who has strong views about from a religious perspective on this issue, they can still become part of the group, and it's just not based on any political or professional or other ideologic perspective. It is actually an open organization who pays the dues and who are trained to be able to make those decisions.
Yes, that is correct. You can not counsel on, for instance, contraception or abortion, and still be a member of ACOG. ACOG has committee they are guidelines, and so while there is a standard of care, we're each individuals and we're each humans, and so we can take that standard of care and make it something that we think is the best practice for our individual practices.
And let's say there's a member who feels this way. What may usually happen for that individual is that they would say that I understand your needs. I do not provide those services, but I can suggest that you can go to my colleague, Dr. So-and-so, who can provide you those services.
And that's correct. That is part of the standard of care. If you do not feel comfortable for whatever reason to provide counseling on any subject, you, from the standard of care, should refer someone to another provider that may be able to do that.
And I think we're talking about an individual physician at this time, but let's break it down into a healthcare institute. What the healthcare institute should do is that they should respect what they believe in, and we should respect what they believe in. And if they believe in that, but the patient needs some services, that institution can officially say, we are sorry, we don't provide those services, but in that situation, you can go to another facility which may be able to provide you those services. That is the question.
That is correct, and that type of communication and discussion and counseling is what would be protected with this bill.
Good. This is very helpful. I want to thank you for your testimony and for being here.
Thank you.
Thank you. That brings us to next person on the list, Dr. Nancy Stanwood. You'll have to wait for your turn now. You gave yours, and we will go to Quinn Meehan, who's not here. Oh, you are. Welcome. We were looking for you online, so I'm glad you're here in person. Welcome.
Thank you. Yeah, I just happened to be in the area, so thank you. Hello, Senator Anwar, Representative McCarthy-Vahey, and members of the committee. My name is Quinn Meehan, and I am a Bethany resident and a Community Organizing and Policy MSW intern at Universal Healthcare Foundation. I am here in support of HB 5515 and 5516. I am also a recipient of gender-affirming care, and I want to speak to how difficult it can be, even without the threats, even before the threats that are currently happening to these types of care, to find providers who even know how to provide this care or have the expertise to. And so how important it is that those providers are able to share that information without fear of repercussions, or how important it is that other doctors are able to refer to them. I have been the person in my community and in my friend groups who has been the one person who knows that one doctor or who can help someone with the process of finding that, and it's a chore. And it's so important, obviously, because we know that access to gender-affirming care and reproductive care are both tied to mental and physical health outcomes. And so ensuring that our providers can provide the care that they know how to provide, which I've been so lucky to receive excellent care from places that specialize in it, from both in both Connecticut and New York. And so I want to make sure that everyone else is able to receive that too. I'm also in support of expanding access to naloxone. It's crucial that schools and community groups and bystanders are able to access this without having to go through healthcare providers, and are able to easily get it from community groups or from friends or whoever, so that the next time they see someone, both either in the school that they work at or in their community, experience an overdose, they're able to help, because with how immediate the impact is, it's crucial that if someone has it nearby, that could mean life or death. And this type of legislation doesn't cause someone to use drugs or encourage overdose, obviously. I just want to emphasize that. In my research, I've seen people talking about how scary and uncomfortable it is to receive this type of treatment. It's not fun, but it does save lives. And at the end of the day, no one can receive treatment or engage in recovery if they're not alive to experience that. So we urge you to support both of these bills and vote favorably, and thank you so much for your time.
Thank you for your testimony. Thank you for being here in person. We appreciate you being here. Don't go away. My co-chair has a comment.
Just a quick word to say thank you for being here, and very excited to know that you are a social work student and preparing to help serve others as a social worker. Always wonderful to see that. Thank you. Have a great weekend.
Thank you so much.
Thank you. With that, we move to the next person on the list, which is Julie Walters. Oh, sorry. All right. And that brings us to Matthew Gilchrist, online. Welcome.
Thank you. This is my first time testifying in this fashion, so I apologize. I don't have all the proper cordialness, but chair people and ranking members of the committee, thank you for your time and allowing me to be here to testify in support of Section 11 of HB 5514, which directs the Commission and the commissioners of the Department of Public Health and the Department of Energy and Environmental Protection to evaluate the recommendations of the Sewage Disposal Working Group established pursuant to 49 and 50 of the Public Act 2597. I served as one of the co-chairs for the subcommittees on the Sewage Disposal Working Group. I have to commend both the Department of Public Health and the Department of Energy and Environmental Protection as they participated actively and brought constructive and important expertise to the working group. While the final report reflects broad consensus among the members, it is important to clearly acknowledge that DEEP and DPH did not agree with all of the recommendations, particularly those related to the regulatory process with reform and fiscal considerations. Those differences were openly discussed during our working group and reflected in the final report. Even where disagreements existed, both agencies engaged constructively and contributed meaningfully to the deliberations. From my perspective as a subcommittee co-chair, the working group consistently understood its charge as a balancing exercise. We were asked to modernize wastewater regulation in a way that continues to protect public health and water quality while also addressing the real impacts of regulatory uncertainty, delay, and inconsistencies, and how these inconsistencies have on the housing production and affordability in Connecticut. The recommendations were therefore developed deliberately as an integrated package, not as a standalone policy change. For that reason, I would caution against the advancing only selected elements of the report, particularly the nitrogen-related requirements, without also implementing the accompanying regulatory and process reforms. Imposing new technical requirements in isolation without improving the underlying regulatory framework risks increasing housing costs and uncertainty without delivering the efficiencies and predictability that were central to the working group's work. One of the most significant recommendations that emerged from our committee and is well documented within the group's files is the modernization of the Code Advisory Committee. The existing advisory process lacks formal structure, predictability, and clear procedures for evaluating and adopting technical standards and new technologies. The working group recommended that evolving towards a model that would more closely resemble the Code and Standards Committee's processes used for building codes under the Department of Administrative Services, which is supported and relied upon by DPH in other regulatory contexts. That model provides defined membership, transparent procedures, regular review cycles, and formal voting processes on technical standards before agencies initiate rulemaking.
Excuse me, Mr. Gilchrist, but you've reached your 3 minutes.
And
thank you.
You are on perfect timing. Thank you so much, Mr. Gilchrist, for your testimony, and thank you for serving in this important committee and sharing your expertise. We appreciate you being here. My co-chair, Representative Kristen McCarthy-Vahey, has a question.
Thank you very much, Mr. Chair. Mr. Gilchrist, I promise I won't ask you as many questions as I did of the other co-chairs of the subcommittees. I can't say the same for the next person testifying, just to warn her. I'm teasing. But I'm interested in your comment that you wouldn't want to see some of the recommendations adopted without others. And I want to just, this may seem like a minor distinction, but I think it's important. Are you saying you wouldn't want to see any recommendations? I don't think you're saying this, that you're not saying
No.
don't adopt any recommendations unless you can adopt all of them. But instead, what you are saying is there are certain recommendations that are clearly tied to others. And rather than moving forward with just some of those, to understand that they really come as a package related to the nitrogen piece and to be careful. And you're saying to exercise caution with that. Is that what you're saying?
That's exactly what I'm saying. Thank you for clarifying that. The committee actually worked extremely well together. The dialogue that we had as a group actually makes the case for modernizing the code advisory committee. Like a more formal group would probably avoid future issues where we have to have special working groups come into play in order to evaluate regulations. If we were able to have these discussions with local sanitariums, the DPH, DEEP, and members who use the code more frequently, we could probably have much better regulations that will promote better practices, more efficient practices, more affordable practices, and still meet the requirements that DPH so desperately wants to protect.
So in conversation with someone who has much more experience with the regs review process here at the legislative level, the process allows for public review and public hearing as we go through the process. Can you speak to what the committee or the working group talked about? And I would just reference for committee members, our own Public Health Committee members, that all those materials are on the Public Health Committee's website. I think we need to just identify just where the report is. But that the difference or the desire to have something kind of ahead of time and why that is, you're suggesting that versus, going through that regs review process where there's that ability to comment publicly.
So when we're able to comment publicly, we come in with an agenda and we will only speak to our point of view. And there's very little requirement to seek to understand the other's points of view. Whereas, with the code advisory committee and how we want it to be, if it was more like the code and standards committee for the building codes, the people that are on that committee take that job very seriously. They accept that appointment and they accept the responsibility as set forth to them. And they work together with all the different parties, the builders, the fire marshals, the health department, like everybody works together and they form relationships with each other because they're assigned to that committee and it's a formal committee. It's not an ad hoc committee, it is formal. So they have, if you will, a commitment to one another to seek to understand. And when it's just an opportunity to come on and testify, there's no obligation for me to seek to understand somebody else's point of view. There's only an obligation for me to project my point of view. So I think we would come to much better consensus between the departments if we had that structure and that commitment to one another to come up with the best regulation possible, not just a good regulation.
Mr. Gilchrist, in full social work spirit, if I may reframe your comments and tell me if this is a fair reframe. What I'm hearing you say is that when you testify, it's a linear process. You are coming in and you are sharing your perspective, your opinion, and the seat, you're sharing it from the seat where you're sitting. Certainly, you will be asked questions and asked to clarify and engage in a conversation by members of the committee, as you are experiencing right now. But the process of what you're talking about is perhaps a more circular process where you're able to give feedback and receive feedback and perhaps adjust your perspective before then landing on a final, here's what I'd like to offer to you as the body making the regulations. I think that's what I'm hearing you say. Is that a fair representation?
That's very
Your
fair.
intention?
You're better at this than me.
No,
Thank you.
not at all. No, I really appreciate your comments, and I think it gives us something to think about, because it certainly it's not a small thing, as I'm sure you know better than I through the conversation, but it's certainly it's an important issue, and it's certainly something worth further discussion, which I know we will have. So with that, thank you, Mr. Chair.
Thank you, Mr. Gilchrist. Seeing no other questions or comments, we will thank you for your service to the committee, and we will see you soon. That brings us to the next person on our list, which is Betsy Guerra. Welcome.
Thank you, Senator, members of the committee, chairs and ranking members. My name is Betsy Guerra. I'm the executive director of the Connecticut Waterworks Association, which represents private, municipal, and regional water utilities throughout Connecticut. Did submit testimony on 2 bills. I'm just going to summarize. House Bill 5518 includes some language that gives the department broad latitude, the Department of Public Health, I should clarify, broad latitude to develop policies and procedures setting action levels for PFAS and other unregulated contaminants for bottled water. We are concerned that this sets a very difficult precedent by adopting action levels outside the formal rulemaking process or other process that may allow parties to make sure that the action levels are appropriate given the toxicology reports, epidemiology studies, and health risk data. As you know, Connecticut water utilities are now complying with the US EPA's maximum contaminant levels for 6 PFAS chemicals and DPH's action levels for 10 different PFAS substances. And in order to address these issues, we are investing millions of dollars in testing, remediation, exploring treatment technologies, identifying potential new sources to ensure that we continue to have a safe, high quality drinking water supplies in Connecticut. So again, we're very concerned that that establishes a precedent for going outside the formal rulemaking process, given everything that's in stake and the complexity of setting those PFAS action levels. In addition, CWWA supports House Bill 5519. This establishes a process for awarding a certificate as a water system operator to individuals that have completed an apprenticeship training program. Water utilities have to have water treatment and distribution system operators at their facilities 24 hours a day, 7 days a week, in order to ensure the safety of our public water supplies. Unfortunately, like other industries, we're facing a significant number of retirements, which is making it difficult to replace these individuals. And so we are working with the Department of Public Health. We're working with our National Association and our sister organization to promote careers in the water sector. Certainly an apprenticeship program will be beneficial. It's my understanding that they haven't created one yet, but we're certainly willing to work with the department and/or the Department of Labor to do so. There is one issue that is making it difficult for individuals to obtain their certification, is that when an individual actually fails the exam, in order for them to retake it, they have to submit another application to the Department of Public Health indicating their experience and relevant training. And that experience and education and training hasn't changed since the last time, but by submitting that application, then it starts the clock and the process again for reviewing it, leaving that individual without an opportunity to obtain their certification. Unfortunately, the failure rate is fairly high. There are some complex math questions. We are working with agencies to address this issue by providing some remedial training, et cetera. But we were advised by the department that there is a regulation that prohibits them from allowing somebody to just retake the examination within a certain time frame, such as DEEP does for wastewater operators. And we were hoping to correct that. I have.
Excuse me, Ms. Guerra, but you've reached your 3 minutes.
All right. Thank you, Kathleen. And with that, I'm happy to respond to any questions.
Thank you so much, Ms. Guerra, for your testimony and the work that you do. And people in our state are able to get safe water because of some of the efforts that you and our Department of Public Health and Department of DEEP has been doing. So we cannot thank you enough on your perspective. My co-chair has a question for you. Representative Kristen McCarthy.
Thank you very much, Betsy. It's wonderful to see you, and I love that I get to see you here in this committee as well over the past few years. And on many issues, just to clarify the first part of your testimony, you were referring to 5518, correct? That's
yes, I was.
Yes, okay. There are a bunch of DPH bills today and a bunch of different water pieces in different water places. That last part of what you were saying, the end of testimony there, can you just reshare that last?
Sure, and that was with respect to the issue of water system operators in 5519. And so we have been working with the Department of Public Health, and they have advised us that there is a regulation that requires an individual, if they fail an examination, to resubmit the application outlining their experience, training, and qualifications to sit for the exam. And then the department has to review that again to determine whether or not they meet those qualifications and training requirements. And then they can retake the exam. This creates a number of delays for those individuals, and some of those individuals have been hired on a provisional basis, which is permitted under the law, because we are desperate to find these water system operators. And unfortunately, in some cases, the water department may end up having to terminate those individuals because they haven't been able to successfully complete the examination in a certain time frame. So we're hoping to expedite that by ensuring that they don't have to resubmit their education experience again. It doesn't change. If it changes, it improves because they've had more training. And I know that the department has acknowledged that that is an issue. So we're just trying to figure out how to remedy that. And I have had some discussions offline with the legislative liaisons to see whether that can be addressed administratively. If it appears to be just an interpretation issue, which I don't understand. I've read the regulation. I don't see why that would be the case.
Thank you for the clarification, Betsy, and that's partly why I'm asking, is there language that you think we may need to add here in order to be able to address that? Is really part of
yes, I would be happy to provide you with some language on that.
Okay, thank you. That's what I thought you were starting to say when we heard the voice. So I am, that's great. I look forward to the ongoing conversation because yes, lots of workforce issues there with that. So I appreciate what you're flagging for us. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, thank you for your testimony. That brings us to the next person, who is Dr. Nancy Stanwood. Thank you for switching places and waiting with us. You're on.
Thank you so much, and thank you for the switch for my colleague. Senator Anwar, Representative McCarthy-Vahey, and honorable members of the Public Health Committee. I am Dr. Nancy Stanwood. I'm a board-certified OBGYN with over 25 years in practice, and I have the honor of serving as the Chief Medical Officer at Planned Parenthood of Southern New England. I'm here today testifying in support of HB 5516, an act concerning reproductive rights. As the state's largest provider of sexual and reproductive health care to over 52,000 patients last year at 14 health centers across Connecticut, Planned Parenthood believes that all people should have access to high-quality, affordable health care as a human right, regardless of who you are, where you live, your income, or if you have health insurance. I'm here today to seek your support for HB 5516, which aims to increase access to essential health information by specifically preventing healthcare institutions from prohibiting providers from offering medically accurate information regarding a patient's health status, counseling, and referrals specific to reproductive health and gender-affirming care. During a time when other states have created climates of fear and intimidation and uncertainty for providers caring for patients seeking abortion care or gender-affirming care, Connecticut continues to make significant progress to protect patients and our state's healthcare providers who are doing all they can to provide medically accurate and compassionate care to patients. HB 5516 is an essential part of this work. To be clear, this bill would not require any affirmative actions by a healthcare provider who would not, and it would not create any new requirements compelling an institution to offer certain kinds of medical care, treatment, information, or referrals. Rather, this bill is intended to ensure that healthcare providers do not face disciplinary action for providing accurate and appropriate information and referrals. Excuse me. It would also serve to correct an imbalance in how we approach the issue of conscience in medicine. For decades, both federal and state governments have protected negative conscience, that is, protected healthcare providers who opt out of providing care that violates their sense of conscience. This bill would protect positive conscience. What's positive conscience? As an example, I exercise my positive conscience in my medical practice by providing abortion care, which I see as a human right to dignity and bodily autonomy, and which my conscience compels me to provide. If I were forced not to provide abortion care, I would be morally injured. This bill would protect my exercise of positive conscience. And this is not theoretical to me. Many years ago, I was called in emergently to care for a patient hemorrhaging dangerously at 3 months of pregnancy, where the life-saving care the patient needed was abortion care. The patient was at a hospital that forbid abortion care, and I needed special permission to provide her the emergency abortion. It would have been so dangerous for the patient and so morally agonizing for me if the permission had been withheld, or if even the discussion of the option of abortion were stifled. When a patient goes to the hospital, they should be confident that their healthcare provider will be allowed to provide comprehensive and accurate information and counseling regarding abortion care and gender-affirming care. And providers should not be limited or barred from providing such critical information. This bill will support patient-centered, evidence-based standard of care practice that protects the integrity of the provider and patient relationship. I strongly support HB 5516 and respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably. Thank you for your time and consideration of this legislation.
Thank you so much for your testimony. We have a question for you from Representative Carpino.
Thank you, Mr. Chairman. Thank you for being here. Could you just walk me through the example you just gave? I've asked some questions on this a couple of years now going, and I'm just trying to understand. What I thought you said was that there was an emergency and an emergent need to terminate the pregnancy. If that's what I heard, does that not fall under other federal guidelines? Through you, Mr. Chairman.
Thank you for the question. So there are EMTALA guidelines, which have been a part of the ongoing national process of trying to ensure that patients can access abortion in an emergency in states that may have banned that care. I bring that case to this forum because for me it serves as the most important example of making sure that clinicians are unfettered in providing patients with the information, counseling, and care that they need. Let's say it had been a less dramatic situation, but where to protect somebody's health, abortion care might be an important option for the patient to consider. And the provider was at an institution that forbid discussing that or making a referral for that. That would be harmful to the doctor-patient relationship. That would be harmful to the patient in trying to navigate care and understand what their options were.
And thank you for clarifying. So I understand, because fortunately I've not had that experience. So I appreciate your sharing a real life example. That patient, that woman, was guaranteed those services pursuant to EMTALA. Is that what you're saying?
That is my understanding of how EMTALA is considered in this setting. And as I said, sort of stepping away from an emergency situation, I've had the experience over the course of my training and early practice of working in institutions that had limits on care, and it created a very and limits on counseling. It created a very stifling environment in which I felt that there was important information I would want to tell the patient, but I was worried that I would be at risk for censure or disciplinary action if I had shared all of that information. So, as I like to say, this is not theoretical to me. And as Dr. Delaney expressed when she gave her testimony, we have many colleagues within ACOG and across the state who have experienced this similar stifling feeling in our ability to fully explain and support our patients in understanding their diagnoses and in seeking next steps in care.
Please.
And I really appreciate that. I just want to make sure that we don't commingle laws and rules. And I appreciate you giving the care that you do to your patients. I just wanted to distinguish the scenario you brought forth versus what we're addressing here in this legislation. Could you just tell me where you practice so I have some understanding, knowing that the OBGYN practices varies depending on sometimes on your location. Your experiences are no different than any other particular professional. Each of our experiences and locations and patient bases are a little different. So do you mind just telling me generally where you practice, ma'am?
I practice full-time at Planned Parenthood of Southern New England.
Okay, so you have admitting privileges at the hospital you were called into? I'm just trying to understand, and I appreciate what you do. Okay.
Right, thank you. At the time of that story that I was sharing with you, I was not full-time at Planned Parenthood. I was working at a different institution.
Thank you. Thank you very much for your patience walking me through the answers to my question. Thank you to the chairs.
Thank you so much. Thank you for your testimony. I do not see any other questions or comments, so we will appreciate your work that you're doing. That brings us to the next person on our list, which is Vivian Friday. Ms. Friday, you're on. Welcome.
Thank you. Okay, good afternoon to the chair. My name is Vivian Friday, and I serve as the Dean of Nursing and Health Professions at Goodwin University. Thank you for the opportunity to speak on HB 5514, specifically the NCLEX pass rate benchmark used to evaluate nursing programs in Connecticut. As a nursing educator and academic leader, I see every day how accreditation standards and state regulations work together. And when they align, they strengthen both education and quality of workforce and stability. I respectfully recommend that Connecticut aligns its NCLEX benchmark with the national standards that are used by the Accreditation Commission for Education in Nursing, otherwise known as ACEN, and the Commission on Collegiate Nursing Education, otherwise known as CCNE. These accreditors uphold the 80% standards, but allow programs to demonstrate compliance through multiple pathways, such as first-time pass rates, all test takers within 1 year, or a 3-year rolling average. This approach maintains rigor while providing a more stable statistical picture of program performance. A single year of first-time pass rates can fluctuate significantly, especially in small programs. National accreditors recognize this, which is why they rely on multiple years and multiple pathway evaluations to reduce validity without lowering expectations. This issue also must be viewed through the lens of Connecticut's workforce needs. Restricting program admission based solely on short-term fluctuations may unintentionally restrict the pipeline at a time when hospitals need nurses. Repeat testers also play a critical role in stabilizing the workforce. These candidates are already educated, require no additional faculty or clinical placement, resources are limited in Connecticut, and can enter practice more quickly than newly trained cohorts. Importantly, students who pass on repeat attempts often come from first-generation, multilingual, and lower economic backgrounds. Maintaining pathways for continued success it supports equity and helps ensure a workforce that reflects the diversity of our communities. By aligning Connecticut's NCLEX benchmark with national accreditation standards, the state can maintain strong expectations, uphold regulatory consistency, and protect a stable and diverse nursing workforce pipeline. Thank you for your time.
Thank you so much for your testimony, and I was looking at your written testimony as well. I think if there's an opportunity to suggest some language change that would address the issues, I know you have not given the specific language, but you gave the outline of why you think we can improve on what's been written.
Okay, so right now in Connecticut, the Board of Examiners has a matrix of all first-time test takers. The NCLEX benchmark is 80% of persons who have passed the exam the first time it is taken. Our accreditors have a different benchmark. Yes, we are not changing the 80% of first-time testers, but they have extended this to include persons who have passed the exam within a year, even if they are repeat testers. And so extending the language would include not just the 80% first-time testers, but everyone who passes the exam, that 80% within a certain time frame.
Thank you so much. This is very helpful. I appreciate you coming in and speaking to us. Thank you.
Thank
Seeing
you.
No questions or comments? But wait, there is a question. Representative Martinez.
Hello. Yes,
Hello.
I do have just a couple of questions. So before coming to the legislature, I served on the Board of Examiners of Nursing for several years. And from my recollection, when a school would fall under the 80% process, when they would come in front of the board, which my colleagues at the time I served with an MD, APRNs, nurse practitioners, LPNs, RNs, doctorates of nursing, many of whom are clinical instruction or are writing some of the curriculum. So when a school would fall below 80%, when they would come in front of the board, there would be a discussion, there would be questions, it would be discussed any considerations, if there were repeat test takers, changes in staff, and then a correction plan would be developed and evaluated. My concern is by looking at NCLEX rates, especially at a longer time period, would stop the corrections or looking at how it's being taught and the student pass rates. It would prolong the time it took to really dig in and evaluate that. Do you have any concerns, or what would your concerns be with extending those NCLEX to especially multi-year or longer periods of time?
Okay, so the language that we are seeking, so right now in Connecticut, the time period is April of that year to May of the following year. What our accreditors have looked at is a calendar year from January to December. And so we would be capturing more of the students who are taking the boards after that May timeframe. What the accreditors are looking at are not just the persons who passed the exam the first time, but we are including persons who have repeated the exam and have been successful and are ready to be a part of the workforce. And because I believe our accreditors understand that this 20 years ago language is no longer, there are changes that can be made. Our populations have changed. We are looking at the persons who are sometimes not being successful are persons who are in underserved areas, persons who are multi-language individuals, and they're looking at those variables. But we would still be looking at the data every year, but we are just looking at the data in more than one way. So right now, Connecticut has one way of looking at the data. Our accreditors present us with 3 different ways of looking at the data, but it's not lowering the standards, and we are still expected to address any inconsistencies or any underperformance in our programs as well.
Okay, so from my understanding, what would happen is a cohort of students would be looked at, right? So a lot of times in the nursing programs, you can have students finishing the program several times a year. So you would be looking at that cohort of students and looking at the NCLEX pass rate among that cohort. And during the conversations, when a school comes before the board, considerations are definitely deeply discussed, such as how many times a student has passed a test. Is that your understanding as well? Or sorry, how many times a student has taken a test?
Usually when the data comes in, for example, for the DPH data, covers usually more than one cohort. But yes, the cohort would be included, but there are students who have not taken the exam in a timely manner, and so they would also be included in the numbers that we receive from DPH. Usually the DPH, because we are looking at first-time testers, does not take into consideration persons who have repeated their exams. So the DPH data does not take that into consideration. It would be just the first-time testers.
Okay, right. I was talking about definitely with the plans of correction, that is part of the discussion. I did read your written testimony, and I just wanted to clarify that there is not a program that's going in front of the board that fell below that 80% threshold and then would all of a sudden be told that they had to restrict enrollment. That's generally after a few times that they have met that threshold, and it's usually very specific in a program. Like, say for instance, a program has a day program and a night program, it would restrict to the specific program that a school has fell below the 80% threshold on a couple of occasions to prevent students, to make sure that the curriculum was in line to promote student success. Is that correct?
Yes, yes. And usually, to your point, when the data comes in, whether it's because, for example, our creditors, if we miss that benchmark of even repeaters being included, the schools would still need to be required to develop an action plan to demonstrate how the school would prevent that from happening again.
Thank you. And my last question, I know that when I was on the board, I had many students that would come forward with the financial issues. What would happen is they would go into a nursing program and maybe they would fail out right before the exam. They would kind of feel like they were kept in to reach the maximum amount of tuition, or students that were not passing the exam several times. I would worry about NCLEX rates is a really important determining factor. If you're looking for a nursing program, you want to make sure that the program you're enrolling in, that you're able to see the most current data. So I would be really concerned about rolling data information for students. How would a student be able to see the most recent information and be able to make an educated decision on where they want to attend based on NCLEX rates being a primary factor?
Well, the data still comes out every year, and it's given it's identifying multiple ways of assessing the effectiveness of a program. But every year, annually, the data comes out, and that information is public knowledge. But can we look at including students who have repeated and have been successful in passing the boards as part of the matrix for success, bearing in mind that there are variables which prevents some students actually take the exams just to find out what it's like to take the exam, and they are not prepared, and so they would not be successful. And again, as mentioned in my statement, there are variables that prevent students from being successful in the exam at the first time. But if within a year, those students are able to be successful, we believe that that is what the students enter the nursing program for, to be able to pass the boards and to be able to be employed. And so we believe that those are good ways of assessing the effectiveness of a program.
Thank you so much. And a year does mean a lot in a nursing program. Some of the schools will have 5 cohorts in a year based on how their semesters work. So I would think the most recent information for the students would be very beneficial. But thank you.
Yeah, thank you.
Thank you for your testimony. Seeing no other questions, we will move to the next person on our list, who is here in person, Leslie Wolfgang. Welcome. Thank you for being here in person with us.
My name is Leslie Wolfgang, and I am the Director of Public Policy for the Family Institute of Connecticut. I'm testifying in opposition to HB 5516, which would restrict hospitals and other facilities, including pregnancy resource centers, from limiting counseling for abortions or gender-affirming care within their operations. The premise of this bill is that these procedures deserve special legal protection, but that assumption deserves serious scrutiny. What is called gender-affirming care can include prescribing puberty blockers, cross-sex hormones, and complex surgeries, such as vaginoplasty. These are life-altering and often irreversible medical interventions used to treat gender dysphoria. These treatments remain highly controversial. In fact, more than half of U.S. states have restricted these interventions for minors. Punishing hospitals in Connecticut for exercising caution puts institutions in the position of being forced to encourage procedures that many doctors believe carry significant medical risks. Puberty blockers and cross-sex hormones can affect fertility, bone density, cardiovascular health, and long-term psychological outcomes. Blocking puberty during adolescence can permanently affect a child's biological development. These are not minor or easily reversible interventions. Supporters often claim these treatments are necessary to prevent suicide, but that claim deserves careful examination. Children experiencing gender dysphoria often struggle with complex mental health challenges. Telling children that they are likely to commit suicide if others do not medically affirm their identity is not sound medical practice. Suicide prevention must be grounded in evidence, not rhetoric. And the evidence remains uncertain. Major international reviews in the United States, the United Kingdom, Sweden, and Finland have concluded that the scientific evidence supporting puberty blockers and hormone treatments for minors is limited to low certainty. The CAS review in the United Kingdom described the evidence base in this field as remarkably weak. Because of these concerns, several European countries have moved toward psychological support as the first-line treatment, rather than immediate medicalization. In other words, the medical community itself is debating the best way to treat gender dysphoria in young people. Hospitals that restrict these procedures or counseling for these procedures may simply be exercising appropriate medical caution. HB 5516 would inhibit those institutions from doing exactly that. When the science is unsettled and the interventions are irreversible, the responsible course is careful deliberation, not government favor.
Excuse me, Ms. Wolfgang, but you've reached your 3 minutes. Thank you.
Please complete. I want to hear the rest.
I was just going to say, for these reasons, I ask you to oppose the bill, and thank you for your time.
Of course. Thank you for being here with us. And I want to ask you a few questions, if you don't mind.
Sure.
You spend a fair amount of time on gender affirming care, but not on the abortion. So am I to say that that part of the bill it's somewhat acceptable to you, that if the clinician suggests to the patient that we don't provide it in this institution, but perhaps you can go to such and such place, and that may be an option to talk to. Are you open to that part?
I'm in line with the Catholic Conference in that I think that this bill doesn't really restrict those conversations with the patients. And, you know, I struggle too with the term counseling. I think with gender affirming care, I could really see a lot of trouble in the counseling area. With abortion, I don't know, it seems like pretty straightforward. Like, here's a list of, you know, at worst, at most, here's a list of organizations that may provide it. Now, you understand, from the perspective of my organization, this is the taking of a life with abortion. So, of course, like, that is what it is. But yeah, I understand what you're saying. That's how my testimony went.
This is very helpful. Thank you. And I appreciate your answer.
Of course.
So, if just exploring this further on the gender affirming, I think the state of Connecticut requires an individual to go through evaluation, extensive evaluation and counseling before any such thing. To your point, this is irreversible, so they have to go through that process and be assessed.
I'm not aware of that, but I didn't study that part of the law before I came today. Thank you.
Do you think that there would be an opportunity, and I'm just clarifying, if such an institution, would they have a counseling service in-house? You suggest that would be the way to approach this rather than suggest them to go counseling somewhere else? Would that be a way to approach this?
I think that children who are experiencing, or adults experiencing gender dysphoria or anything around that, the front line should be a form of counseling. It's just a matter of, like, I think what people were trying to get at earlier, where is that going and what are the recommendations? But I think I would love to see more hospitals offer counseling as the first line with regard to gender dysphoria and that treatment.
So I hear your concern. I think the standard of care in our state is that they have to go through counseling. They have to be evaluated. They have to recognize the permanency of this. Now, if somebody's not following that, then that's another question that we can look at. If they're not following the standard of care, that can be a different aspect.
Right. I would just say that when it comes to gender affirming care, then even the New York Times had an article this past month about how organizations and took more of a political census instead of a medical consensus of their members. So I'm not aware of the laws that you're speaking to. I would be happy to discuss or lean into that more. But I think that the whole topic deserves a lot of caution and just a lot of caution as we proceed.
Thank you for your testimony. I appreciate you being here in person.
Of course. I'm glad it's not in the middle of the night.
No, and we're still a little sleepy, but we're don't go away. Representative Daphne has a question.
Thank you, Mr. Chair, and through you, I don't know what to ask you other than I just came flying in and I missed your testimony, but I heard you talking about gender care. So I heard the good chair talking about perhaps counseling with regard to gender care. Are we talking about changing things in a place where they wouldn't support gender care and requiring them to give counseling With regard to that, I missed that. So could you maybe?
So the
answer that?
Catholic Conference, I think, really needs to explain, and everybody can dig into better what they mean by counseling. I would not want the churches, the religious organizations to be encouraging or have to remove any restrictions that they might have as far as encouraging children to pursue puberty blockers, cross-sex hormones, surgical interventions, which we know has happened in minors. As far as if the institution has professional counselors to address these matters, which I think that they, I think that would be a good thing. I don't have a problem with that.
Thank you for that answer. So you said children, would that include adults too, that they would have availability to counseling or not?
Well, I'm mostly concerned with the minors who are being pressured, because there's definitely problems with pursuing irreversible changes to their bodies. It gets a lot more complicated when it comes to adults. Everybody can understand that. There are organizations that we work with who say that this is not beneficial for adults either. In fact, yesterday in Washington, D.C., there was a conference for detransitioners, adults who pursued puberty blockers, cross-sex hormones, just the cross-sex hormones and surgeries as adults who have a large amount of regret because because they realized that what they did need actually was just more counseling. So it is a problem. I think, it gets a little off topic from this bill to start trying to parse what minors versus adults. But my point is that sometimes these institutions have the right idea with let's have restrictions on what our doctors are able to encourage their patients to do.
I appreciate that, and I agree there's a big difference between the children and the adults. So I wasn't in here, so I wanted to know who you were talking about.
Yeah.
But thank you for your answer. Thank you for being here. Thank you, Mr. Chair.
Thank you. Seeing no other questions, I want to thank you for testifying and thank you for being here. We appreciate you.
Okay, thank you.
All right. Thank you for waiting all day, or part of a day. That brings us to the next person on our list online, Laura Pryor. Welcome.
Good afternoon. Can you hear me okay?
Very well.
Okay, one second. Thank you so much for having me today. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Stitra, and distinguished members of the Public Health Committee. On behalf of the Connecticut Advanced Practice Registered Nurse Society, thank you for the opportunity to provide testimony on House Bill 5514. My name is Laura Pryor. I'm an advanced practice registered nurse here in Connecticut, working in radiology, and currently serve as chair for health policy for the Connecticut APRN Society. As you well know, our state faces persistent healthcare workforce shortages, particularly in primary care, behavioral health, and in rural communities. APRNs are a rapidly growing and essential segment of the healthcare workforce. I want to talk about two barriers that APRNs experience and would urge that you consider adding this to the revisions bill. First, I wanted to talk about APRN reciprocity. The current statute does not offer reciprocity to APRNs coming from other states unless they have collaborated with a physician for 3 years. This means that APRNs with potentially decades of experience, again, not having collaborated with a physician for 3 years, cannot come to work in Connecticut independently. This is definitely a barrier, and we do believe it's going to cause downstream issues and potentially issues with faculty shortages and shortages in primary care. The second thing I wanted to discuss was, as we know, there are many regulations that are outdated, and those create practice barriers as well. In particular, I wanted to discuss one that talks about only having a physician as medical director for an industrial health facility. So you may not know, but APRNs are sometimes providing care in these industrial facilities, and they are the only one there. But as the regulation is written, they have to have physician oversight. We believe this causes a necessary barrier to access and administrative redundancy, and that these clinics can be run by NPs. Their OSHA guidelines already acknowledge that APRNs are qualified and are included in the best practice guidelines to lead occupational health programs like this. I would respectfully urge that you add this language to the revisions bill, and I'm happy to take any questions.
Thank you for your testimony. Can I clarify something? Were you able to see the recent publication in the Family Practice Journal about what's happening with APRNs in Florida?
Not specifically.
Okay, it was just a recent publication, and it's a cross-sectional study which basically showed that unfortunately majority of the, or significant part of the APRNs were working outside their legal scope in Florida, and a large number of them were working, and even though the law was passed for primary care, majority of them were working for cosmetic and non-standard medical practices such as anti-aging, IV hydration, vitamin infusions, and supplements. So it was interesting because they are also seeing a shortage of APRNs, but the choice that was made in the cross-sectional study, what we saw was that they were not going into primary care where the need was, and they were going into some of the other areas that they were not even trained for cosmetic and other treatments. So, but it's worthy of a conversation, and I appreciate your testimony, and want to thank you for testifying today and raising some of your concerns. Seeing no other questions or concerns, we will move to the next person on our list, which is Thomas Burr. Welcome.
Yes, good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Thomas Burr. I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I'm also a member of the Connecticut Department of Mental Health and Addiction Services State Board. NAMI Connecticut is here today in support of House Bill 5515 and 5517. In regards to 5515, NAMI Connecticut agrees with Demas that since opioid overdose reversal medications are now available over the counter to laypersons, it is time to update some of the state statute language in regards to 1, who can administer the medications on school grounds, 2, expand immunity from lawsuits to those persons who do administer these medications, 3, add Demas to the list of state agencies who provide guidance on the safe storage and handling of these medications, and 4, only require training for the people who may administer these types of medications which are not available over the counter. In regards to House Bill 5517, NAMI Connecticut believes and agrees with the Demas in updating the Connecticut statutes related to mental health and addiction as proposed. In sections 1 through 110, updates to the text reflect and promote person-centered, recovery-friendly language. NAMI Connecticut agrees that by using recovery-friendly language, it will create a more inclusive and supportive environment that encourages healing and growth for individuals facing substance use challenges, as well as reducing the stigma often associated with this use. In Section 111, adding Demas to the list of agencies that the Department of Emergency Services and Public Protection coordinates with for the deployment of behavioral health professionals in certain emergency situations. Traumatic events require a response from people educated in the effects and treatment of trauma, so NAMI Connecticut believes that this change will result in better outcomes for those people involved. In sections 112 through 115, updates to the text in regard to the membership of Demas advisory councils to reflect current practice, make the relevant changes, and remove outdated references. NAMI Connecticut acknowledges and appreciates that this new language reflects prioritization of lived experience. As we say in the mental health advocacy community, nothing about us without us. And lastly, in Section 116, updates to the state statutes that provide a feedback mechanism from the community into Demas. It should be noted that historically, the statewide catchment area councils performed a critical role at grassroots level in providing local input into Demas via the former regional mental health boards. Times have changed, and now that role has since been transitioned into the current Regional Behavioral Health Action Organization framework. NAMI Connecticut appreciates and values that the RBHAOs continue to incorporate robust local participation and routinely utilizes community opinion. Again, nothing about us without us. So in conclusion, we support both House Bill 5515 and House Bill 5517. Thank you.
Thank you so much for your testimony. And we're not seeing any questions, but you've been very thorough, and we appreciate you, Mr. Burr, and NAMI as well.
All right. Well, I appreciate that. Thank you.
Thank you. The next person on our list is number 33, Elisa Lobeter-Stone. Welcome.
Thank you for having me. Good afternoon. My name is Lissa Lovetri-Stone. I'm a licensed funeral director and embalmer, and I served currently as a vice president of the Connecticut Funeral Directors Association. The CFDA represents more than 220 funeral service establishments across the state of Connecticut. We respectfully offer testimony today to support both HB 5518 and 5513 with some targeted recommendations to improve the clarity and the implications of them. With respect to 5518, both sections 17 and 18 propose important technical corrections to previously adapted statutory language designed for flame-based crematories that was inadvertently applied to the alkaline hydrolysis facilities. The statute requires that the alkaline hydrolysis facilities only be performed on the grounds of licensed funeral homes. These revisions removed conflicting requirements for placement of facilities within a cemetery. Further updates to provide the Commission of the Department of Public Health with clear authority to establish these technical standards for alkaline hydrolysis. And the CFDA welcomes the opportunity to share our professional expertise in any of these policies or regulations to help you promote public health and environmental issues, and of course, consumer confidence. We also support HB 5513, requests several critical amendments that will help also to ensure this bill's functions as intended. First of all, we appreciate your recognition of the unfortunate circumstances that sometimes require the care and disposition of abandoned human remains or abandoned cremated remains. While we hope this situation remains rare, we funeral directors and embalmers who are entrusted with this responsibility must have clear guidelines and appropriate protections when we fulfill this requirement for the commissioner. With respect to Section 1, we recommend language authorizing the commissioner to permit an individual who has custody and control of the disposition under Section 45A 318 to contract with a licensed funeral director or a licensed embalmer. This ensures that the legally authorized person responsible for the disposition can continue to direct the final arrangements and work with the funeral service establishment of their choosing. It also helps clarify financial responsibilities for the funeral arrangements. Regarding Section 2, we believe that the licensed funeral director should also be included among the authorized agents permitted to be able to obtain an individual's social security number when necessary. In some circumstances of abandoned funeral service contracts, the information might be needed to confirm the identity of someone, verify a death, or determine which establishment ultimately performed the services when the person had passed. So we suggest these. Go ahead, hon.
Excuse me, but you've reached your 3 minutes. Thank you.
Okay, we're good.
Did you have if you want to complete, because you're very useful words that you're telling us, so go ahead, and if you have any other suggestions.
The last suggestion, sir, was just that we appreciate your attention and we want to continue to work with you all to develop the best language so that we can both achieve our goals.
Thank you. And you will have a written testimony as well?
Yes, we will.
Okay, perfect. I have two of my colleagues have questions for you. We'll start with my co-chair, Representative Kristen McCarthy-Vahey, and then Reddington Hughes.
Thank you very much, Mr. Chair. And Lisa, thank you so much for being here with us.
Sure.
I was, during your testimony, texting with the Department of Public Health to see if they have been aware, and I believe there's testimony also from John Green. Are the two of you, are you working together?
Yes, he's the president of the Connecticut Funeral Directors, and I'm the vice president.
Okay, so wonderful. We just wanted to make sure that we had written access to the testimony and that the department
Absolutely.
was able to review that. Have you been in direct communication with the department, the two of you?
Jonathan has, I think, almost on a daily basis, yes.
I assumed, and I thought it would be important for the committee to know that as well.
Mhm, yeah.
We're very grateful for your partnership on this issue. It's always most helpful whenever
I
you
think-
guys working together.
Thank you. I think we're all just doing the best we can for the situation.
Thank you so much. Thank you, Mr. Chair.
Representative Reddington Hughes.
Hi, through you, Mr. Chair. Lisa, thank you so much for all the hard work that you do in such
Thank
a
you.
lovely, mindful way. You really are a gift.
Oh, thank you.
I just wanted to see if perhaps you could shed some light on the nemesis of the bill 5513 and just how this will be helpful for the funeral homes in the future.
I think when we get put into the awkward situation of like taking over where someone else has dropped the ball or walked away from the situation, us being able to have direct counsel from the commissioner as to who needs to be taken care of, and the chain of authority going from the next of kin to the funeral home so that we can all clearly see what the end goal is to take these people who are either abandoned or, the other situation that recently happened, to get the end goal so that the next of kin has closure and that we can take care of them in a I don't want to say quickly, but the Social Security end of it, a lot of times you can't process paperwork without having all the vital statistics on a person. And when we're in a situation where we can't obtain something with a Social Security number, it's really hard to be able to say to a family, we cannot service you or we can't help you with your loved one until you can get certain information. So it sort of goes in hand with being able to get people to their end goal or to the results of what they're all looking for in hopefully a stress-free way.
Well, thank you for all of the thoughtful work that you do.
Thanks, Ms. Hughes.
Thank you. Seeing no other questions or comments, thank you again for being here.
Thank
That
you.
brings us to the next person on the list. I want to make sure David Potts, who's not here, and he's certainly not online, so we'll move to the next person, which is Amanda Gunthell. Welcome.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. It is nice to see you. My name is Amanda Gumpel. I currently serve as president of the Connecticut Association of Ambulatory Surgery Centers and our patient safety organization as well. I've been an active part of our ASC community since 2005. Thank you for the opportunity to testify today on several bills before the committee. House Bill 5510, HB 5511, HB 5512, and HB 5514. Ambulatory surgery centers are proud to provide high-quality, lower-cost, same-day surgical care for patients across Connecticut. We save patients millions of dollars each year through lower co-payments and co-insurance responsibilities while maintaining rigorous safety and quality standards. Our centers are highly regulated through state, through state licensure, federal CMS certification, and national accreditation. Every ASC in Connecticut participates in the Patient Safety Organization and in required national quality reporting programs. We have submitted more lengthy comments, but we'll use this time to briefly touch on the four aforementioned bills. Regarding HB 5510, which addresses unlicensed institutions and practices, we support strengthening enforcement against entities operating without proper licensure, facilities that bypass licensure requirements, undermine patient safety, and create an uneven playing field for licensed providers who invest heavily in compliance and quality standards. Strengthening the Department of Health's ability to enforce penalties and quickly stop unsafe operations will help protect our patients and uphold the integrity of our regulatory system. With respect to HB 5511 concerning consent orders, we have concerns about the broad authority granted to the commissioner to impose any conditions deemed necessary through agreed settlements or consent orders that may not be subject to appeal. Expanding this authority without clear statutory guardrails could create uncertainty for providers and raise concerns about transparency, consistency, and due process. We encourage the legislature to carefully define the scope of this authority to ensure regulatory actions remain fair, predictable, and grounded in statute. Regarding HB 5512, which addresses real property ownership changes, many ASCs operate in leased medical office space owned by third-party landlords. In these situations, the ASC maintains licensure and operates the clinical facility, while the real estate is owned and managed independently. Requiring disclosure and approval of real estate ownership changes, often involving large national property companies, burdens facilities with matters entirely outside of their control and irrelevant to operations. We respectfully request that the bill be amended to exempt lease arrangements where the property owner has no operational role in the licensed facility. And finally, regarding Section 7 of HB 5514, which addresses the Department of Public Health's Quality of Care Advisory Committee. We urge the committee to expand membership to include 2 representatives from the Connecticut Association of Ambulatory Surgery Centers. ASCs represent the fastest growing site of surgical care in the country. We are already deeply embedded in the healthcare quality infrastructure through our patient safety organization and participation in national quality reporting programs. Including ASC representation will ensure that the committee benefits from the perspective of this important sector of care. Thank you again for the opportunity to speak today. I am happy to answer any questions.
Thank you. Representative Kristen McCarthy-Vahey has a question.
Thank you. Amanda, thanks for being here with us today. And just a clarifying question, in 5512 about the real property, you're asking for an amendment or a change to the language that exempts lease arrangements. Is that what you said?
That is correct.
Okay, great. Thank you. And thank you for your specific ideas. I don't remember if we have the written testimony or not, but I know you said that you were submitting it, so I appreciate that.
Yep, we'll make sure it's there. Thank you.
Seeing no other questions or comments, thank you so much for being here with us today.
Thanks.
All right, that brings us to next person on the list. I want to make sure, Catherine Bonner. Welcome.
Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Catherine Bonner. I am from West Hartford, and I am a second-year medical student. Thank you for accepting this testimony in support of HB 5516, an act concerning reproductive rights. This bill would protect healthcare providers who offer medically accurate information and counseling to their patients with regard to reproductive healthcare services and gender-affirming healthcare, in line with the accepted standard of care for their patients. I volunteer my time to serve as an abortion doula at Planned Parenthood. For those who are unfamiliar with that phrase, I'll tell you what I tell all my patients when I walk in the room. I'm not a doctor, I'm not a nurse. I'm here as emotional support, a handhold, or just someone to keep you company. Patients aren't allowed to bring any support people into the appointment with them due to safety and privacy concerns, so I'm there to make sure they're not alone. In that role, I meet patients before the doctor comes in, make small talk, I coach them in breathing through the pain of the procedure, and once the doctor and nurses leave, I stay in the room. More than once in that moment when it's just the patient and I in the room after the abortion, a patient has turned to me and asked, "Will I be forgiven?" Or has begun crying, saying that they hate themselves because this is the second or third abortion that they've gotten. This is what shame and stigma can look like. There are numerous reasons why patients may choose to receive and doctors may choose to offer care at institutions which are against certain reproductive and gender-affirming care services. This bill would in no way impede that choice. In others' testimony, there have been arguments raised that the government is interfering in the relationship between an employer and an employee. It is a far graver infringement for an employer to interfere in the relationship between a patient and their doctor. As a current medical student, we are taught to embrace individualized health care and recognize that our patients exist in the broader context of their lives. There are no one-size-fits-all solutions in healthcare, especially reproductive and gender-affirming healthcare. In a few years, I will be a resident doctor with little control over where I practice. It is hard to put into words the moral injury that I would feel if I was sat across from a patient asking for help and I was unable to even discuss with them all of the options for their care. To force providers to treat certain services as morally unspeakable grossly increases the shame and stigma imposed on patients. HB 5516 would ensure that all of our state's providers, regardless of their employer or hospital affiliation, are able to provide medically accurate information, counseling, or referrals for patients to an alternate provider without fear of facing reprisal or disciplinary action for doing so. I respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably for HB 5516. Thank you for your time and consideration of this important bill.
Thank you so much for your testimony. And so you're here more in the role of doula experience, but you're obviously a medical student as well.
Yeah, exactly. I can speak to part of my perspective as a medical student is that I will be a doctor one day, and that, especially as a resident doctor, there's only 6 residency programs in the state of Connecticut, so when you're trying to stay with your family and end up close to your loved ones, there's limited options on where you can actually apply and work.
Yeah, that's another conversation we'll need to have in this building. I want to thank you for your testimony. You have kindness and empathy. You would be a great doctor. My co-chair has a question for you, and others have questions for you.
Thank you, Senator Anwar. Just a quick comment. I just want to thank you for highlighting something for us that I came up a little bit earlier but didn't really sink in for me, that as a resident with the match, which we talked about earlier, it's not unlike the military. You're assigned and you go where you are assigned. So you may be sent to a hospital with a religious affiliation in order to be able to accept that match and move forward with your training. So I appreciate you just highlighting that for us. Thank you, Senator.
Rep. Mara, followed by Rep. Kitt.
Thank you, Mr. Chair. I really wanted to thank you for the work that you do. I think it sounds like how you approach your job is very loving and caring, and I think that the women that are going through this obviously have a benefit having you by their side. And I hear you with the shame and the stigma, but I guess I see that no matter what, I see that a decision like that is hard for anybody, right? And especially with all the hormones that are in your body, but anybody that comes to that with any sort of, not even necessarily religious background, but even just pregnancy and understanding life, it's a tough decision anyway. So thank you for that. And I kind of misunderstood where you were when I was going to ask for the questions, because you were saying if I were working in a situation, and so I understand it's the residency program that you're more concerned about, because as a physician, I would hope that you would be able to say, these are the places I want to work and these are the places I don't want to work. But I understand that you're limited with the residency program. But also I would hope that I would understand that in a residency program that you would fall under a physician. So I guess we need to look at this to see if you would be held liable. Not that anybody I've necessarily heard is liable as a resident. So I think that's something maybe we should look more deeply into this law. Thank you, appreciate it. And if you've heard about anything, I'm happy for you to comment.
Yeah, just one small comment. I can't speak directly to the intricacies of how residents would be protected versus liable under the physician they're working with, though residents are physicians themselves once they graduate. What I would say is that even as a physician, I think there is not total, complete freedom and choice. Obviously, if it's someone who doesn't want to apply to an institution, they won't. But also, people who are one way or the other maybe a little bit more willing to work at a religiously affiliated institution, institutions that have certain restrictions, they might end up working there because it's the only job near family, or they can't get a job at another facility. I mean, in terms of general job market, physicians won't have complete control to say, oh, I won't work at this facility because of this restriction. And so therefore I'm gonna make my whole family move, travel over an hour to get to work. I know that one of the earlier speakers, Claire, spoke about how 1 in 6 hospitals in Connecticut are religiously affiliated, and the studies that she was referring to also mentioned that rural places, sometimes that's the only option for care. So I wouldn't say that there's total freedom, even as a physician, to be able to choose, and that the situations we're talking about aren't just what you would expect. There are unexpected circumstances that come up. A physician might agree with a hospital's policy and agree with restrictions and be happy to not recommend them to patients, to not include them in discussion of full options, whatever that may be, but they might meet a patient who needs that and who they believe needs that, and that physician should be protected. You know, that's someone who would have started working at this hospital thinking that they were totally on board with the restrictions, and then meets a patient who actually needs that help and who they want to offer that to. They shouldn't be penalized for doing that.
I don't disagree. I agree with you on certainly on that point. You know, I think that many jobs have to move for jobs, so I'm not sure I totally agree with you. If there's a place you don't want to work, I think that, and you're the physician, you're most likely the breadwinner of the family. Maybe it's dual income, but in any case, like, families have to deal with that all the time. I've certainly moved around with jobs for me as well, so I'm not sure I buy into that as much. I mean, definitely there's pros and cons of where to work. However, I believe that physicians should have autonomy of care of patients. And I'll leave it at that. Thank you so much. Thank you, Mr. Chair.
Thank you. Representative Kitt.
Thank you so much, Mr. Chair. I just want to thank you for being here. Earlier today, I met with a group of internal medicine residents from Yale who are up here learning on how to be a part of the legislative process. So I want to applaud you at this early stage of your medical career for coming here and making your voice heard. And I hope you continue with that type of engagement as you grow in your career. The grace and compassion you've shown for the women who have been in your care is commendable and laudable, and I hope you can instill that type of care, that ethic into your fellow med students as you move forward. And I just want to comment that I hope that we can preserve physicians' autonomies to make the best clinical recommendations to their patients, regardless of what institutes they are working with. Because I think that is the essence of quality health care, is being able to provide and receive the best scientifically appropriate, medically appropriate information. So I just want to say again, thank you so much for being here and sharing your voice and for the care that you give.
Thank you.
Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, thank you for your testimony.
Thank you.
That brings us to the next person on our list, which is Diane Loricella. If I pronounce that inaccurately, please correct me. You're welcome. Please go ahead.
I know we've all been here the entire day, and I thank you for continuing to allow us to speak virtually at the hearings that this legislature holds. Good afternoon, Co-Chair Senator Anwar and Representative McCarthy-Vahey, Vice Chairs, ranking members, and members of this august body. My name is Diane Loricella. I live in Norwalk. I'm a former regulator with the Department of Environmental Protection in the Hazardous Waste Division way back in the 80s. And since then, I've become an environmental consultant. So I'm here today, first of all, to support House Bill 5516 and the previous speaker. Just terrific discussion that took place afterwards. But I'm mainly here to discuss House Bill 5518. I support any efforts to enhance quality control and credibility in the world of environmental laboratories, environmental training, and environmental quality control because of the fact that so many people in our towns, 169 towns, are not aware of drinking water contaminants, both regulated, such as mentioned with the bottled water industry, and unregulated contaminants. I did want to state, though, that in line 128, where it states that the commissioner will update a schedule, not less, it had to do with collection of, asking the bottling companies to collect not less than once annually representative samples from a batch of their bottled beverage. I just find that might be a very low number. I don't know if the lobbyists insisted that this would be too burdensome, but as a former regulator where we would take samples unannounced of various types of materials, I think it would be good to take a look at that line and see if that could be enhanced and tighten it up a bit. Also, I very much support line 171, where owners of residences and commercial facilities will notify tenants when there's an exceedance of PFAS for the PFAS or the forever chemicals. I think that's terrific. And I very much think that the labs must demonstrate compliance. For a little while, I was also a certified asbestos abatement certified. I had a license and I also taught asbestos abatement practice, having taken many OSHA classes and the like. So I'm so happy that there are going to be some new requirements of contractors and training practitioners, because I had found that it's very tough to find quality and qualified folks. I do want to caution you not to increase fees any further because we need more practitioners in these areas. And then lastly, I wanted to state in my few seconds allowed, if I could just finish up. One thing I am very pleased that you are asking. It looks like here that the main reason for these changes in 5518 is to ask of the bottling, drinking water statutes of the bottlers of our state and those that import in our state. But I want to tell you that the public is still not aware. They don't have awareness for PFAS contamination in their both public drinking water supply they get through their tap or in their private drinking water wells. And I urge you to consider a working group between now and the next long session. And I would be very happy to participate in public awareness, not to frighten people, but to make them aware. And I urge you, because unfortunately, I do not think the Department of Health nor DEEP have adequately and properly warned people and given them choices where and how to get tested for PFAS in their drinking water. So thank you for listening, and I hope you take some of my work to heart. Thank you.
Thank you so much for your testimony. And I don't know which part of the state you're in, but you have excellent coverage, because we heard you so clear and loud. We saw your video and you're on your cell phone. So somebody's doing a good thing over there, because your message was very powerful and helpful. My co-chair has a question or comment.
Yes, that's related to water and treatment. I'm having questions, lots of them today. This is a slightly different topic than the early one, but Diane, thank you so much for being here with us today and for all your expertise and work. And I just want to note that last piece in terms of the awareness of PFAS. PFAS is an issue that this committee, I believe, will be spending time on in the future, and certainly the other, our sister or brother committee, the energy or the environment committee, excuse me, this is something they've talked about as well. And I think the question, it's probably more of a comment, but just the issue of notifying people. My understanding is there are a lot of questions still at the federal level related to some standards with how to address some of these issues. And I can use a specific example in Rep. Kitt and I in our community of Fairfield. they are doing some work on the sewer lines, and they had to dig down deep and found, unsurprisingly, levels of PFAS in that water. And there's been a pause in that project because the state DEEP is unable to give guidance because they're waiting for EPA guidance. And there's much more to the story, in fairness to DEEP, but is it your understanding too that there are many questions out there in terms of how we proceed from some of those standards aspects? I mean, is that a fair statement from your experience?
One thing, as a former regulator, I refuse to say I was a bureaucrat, but I guess if you were, some people equate the two. I find that there is enough science to give people information within ranges. For instance, the Union of Concerned Scientists, we have the Environmental Working Group. There are many organizations, EHI right here in New Haven area, and even our state DPH have a lot of science under their belt. And we saw as soon as Lee Zeldin came on board at EPA, where he seems to be in favor of certain aspects of PFAS regulation, they slow walk those final numbers. And the problem with that is I did attend, this was right before COVID, so 5-6 years ago, the initial collaboration between the Department of Public Health and DEEP on what to do about PFAS. And so 6 years later, I used to be part of the PFAS coalition that Ann Hulick was running before she retired. Everyone's waiting. And I do believe there's enough science for your committee and the regulatory agencies to give we the people some guidance, because I find it really unfair. For instance, in my own city, we have 2 different water companies. One of them has a PFAS issue, and in a drinking water public well field, they haven't told anyone about it. And I just believe it is not fair. We know that maybe 0 is not the right number, but 70 or 100 could cause, and it has been proven to cause, biologic problems in humans and wildlife. So for us to keep waiting and waiting for the federal government, I think would be unfair to the people of Connecticut. I don't think we need the government in the federal to make that final. I do think we have enough science under our belt to at least begin giving people information so that they can then get their water tested. We don't have a good clue in our private drinking water wells, let alone which public drinking water companies are being totally honest. Maybe I'm sticking my neck out here, but they're not telling their people of the exact level of the source, let alone what comes out of the tap. And I just think 6 years is long enough to wait. So I'm happy to help with this. It can be clearly specified, I do believe. And
Thank you. Thank you for your answer, and with thanks to my good co-chair and the committee members, because I know this is not something that's directly in the bill, but I feel like this is a little bit like that chance for the sequel, because as we're nearing the end of our public hearings this year, perhaps this is a preview of some of the issues we may be able to discuss going forward. Thank you very much, Mr. Chair.
Thank you, Ms. Loricella, for your testimony. You may be hearing from us later after the session about
Sounds good. And Mr. Chair, I wanted to tell you that the reason my transmission was so clear is I'm on consumer cellular, which are for seniors and gives you half the price of other companies.
All right. And you approve this message.
They didn't pay me. Okay, thank you.
Thank you. Yeah. The next person on the list is in person, Ben Shaken, followed by Miss Griffith, sorry. Welcome.
Good afternoon, Mr. Chair, members of the committee. My name is Ben Shakin. I'm the Director of Public Policy and Advocacy at the Connecticut Community Nonprofit Alliance. We're the statewide association of nonprofits. They serve 500,000 people across Connecticut every year and employ 118,000 people. Included in that are tens of thousands of people working in nonprofit organizations serving people with disabilities and people with behavioral health challenges, funded by the Department of Developmental Services and the Department of Mental Health and Addiction Services. I'm here today to testify in support of Section 12 of House Bill 5514, which is your various revisions bill. That is just a repealer section, but what it repeals is important to our organization and our members, and that is statutory caps in the salaries for executives of organizations funded by DDS and by DMIS. There's two different statutes, one for DDS and one for DMIS, which is why it's here in your committee. You are the Committee of Cognizance over that part of the book, the Connecticut General Statutes. The state has long set salary caps for executives of those agencies. For many, many years, they were stuck at $100,000. About 3 years ago, you raised them in a bill put forward by the Department of Developmental Services to $125,000, with an increase that was supposed to happen every year, but unfortunately, as the legislation has been implemented, has not really. And so we are here to say that the cleanest thing to do is to just repeal these statutes. They're antiquated, they're out of date. The state doesn't regulate the salaries of any of the other contracted organizations that work with any other state agencies. Our members exist in the free market and need to attract talent based on what the market pays for that talent, and these numbers are woefully short. We do a survey every few years, a comprehensive salary survey for the entire nonprofit sector. According to our most recent survey a couple years ago, the average salary for executive directors in nonprofits in Connecticut with budgets between $5 and $10 million was $204,000, and the average salary for organizations with budgets in excess of $10 million was $232,000. Almost all of the state's nonprofit providers with DMIS and DDS have annual budgets in excess of $5 million, and the current statutory salary cap is $128,188. So what that means is when a leader retires and an organization needs to go to the market to hire their successor, and they're hiring someone to run a complicated healthcare organization, managing hundreds or thousands of employees, millions of dollars, that need good stewardship and management, electronic health records, privacy, complicated systems. They're faced with a market that is paying more for chief information officers and chief financial officers, chief human resource officers than they are able to pay for executive directors. They're facing a market where our neighboring states, places where you might want to attract talent, people who are looking to move up in their careers and move to a new state, are being paid substantially higher. And it's becoming very difficult, frankly, for those organizations, particularly those that really specialize in services for DDS and DMIS clients, and don't have a broader funder array where they can pull other resources into that salary pool to make those hires.
Excuse me, Mr. Shakin, but you've reached your 3 minutes.
Thank you. I was just going to wrap up by saying thank you very much for raising this. And we understand that there may be other solutions to this. Obviously, the department proposed one a few years ago. I'll just note in that solution that increase was supposed to happen every time the legislature provided a cost of living adjustment to nonprofits. The legislature, since that statute passed, has done somewhere between 10 and 15% cost of living adjustments cumulatively over those years, depending on which year you start counting. The salary has only gone up 2.5% based on some technicalities about how the statute is worded. So we think repeal is the best way to handle it, and we thank you for raising the issue. Happy to take questions.
Thank you. I think you make a very strong argument. Makes perfect sense. In the current environment, getting a person with the best expertise, they will have so many other options rather than doing the work that's going to keep our state better. So, Representative Kristen McCarthy.
Mr. Shakin, thank you. Thanks for coming back and for waiting till the end. We appreciate that. Just to clarify, the current cap is 125,000 or 128 and change?
The current statute set the cap in 2022 at 125. It raised it from 100 after many years, and then it said it will go up by the same amount of the cost of living adjustment that the legislature provides, if the legislature provides a cost of living adjustment for those services in the state budget. And so the issue has been, and so it is now, if you look on the DDS website, 128,000, because it has gone up because there have been some cost of living adjustments that have been provided. The challenge is that most of the funding that the legislature's provided has not technically been considered a cost of living adjustment initially. So if you're a student of the state budget, one year the DDS providers received a line item called provider bonus in the DDS budget. It was for $50 million. It was equivalent to somewhere about 5%. That amount of money's now been annualized into regular and normal DDS provider funding, but it was not considered a cost of living adjustment, and so it was not allowed to be considered an increase, or to be considered applicable to the statutory increase that is provided for executive salaries, which is, I think, part of the reason why they've only gone up a certain amount.
Gotcha. So when you gave us the 125, the 2.5% that's where we are now. That's the 128.
Correct.
Right, that's that math. Okay, and then the other question I have is, do you have any sense of how many executive directors or chiefs would be impacted by this?
I don't know exactly. There is a little bit of nuance in how this works. You're required to only pay for to only use DDS money for up to $125,000, basically. And so for agencies that contract with multiple different state agencies and have other revenue streams, I think they are able to find other revenue streams to aid in the compensation of their executives. So that's why I said this affects primarily the really specialized organizations that are only or primarily funded by one of the two state agencies, which tend to be some of the smaller organizations or some of the organizations that have a really particular specialty. So I don't know exactly offhand. I know that there are, across the entire state system, several hundred nonprofit organizations that are qualified providers, around 200 in both DDS and DMIS.
Thank you, that's helpful, and that's an important distinction, that this is about the funds that may be used, that it comes specifically from the agencies. So that's helpful. Thank you very much, Mr. Shakin, and thank you, Mr. Chair.
Thank you. Representative Dauphine.
Thank you, Mr. Chair, and through you, isn't it true that the nonprofits run on a far smaller budget than the state agencies as a whole?
Yes. So in the Department of Developmental Services, I don't know the total DDS budget totally, but they have about 120 qualified providers that they work with. Almost all of them are nonprofit organizations. I think the largest one in the DDS system has an annual budget in the $100 million range with about 1,500 employees, and that goes down to organizations operating on budgets of $1 million to $5 million and everywhere in between.
I guess I was looking at it as, I mean, if this were to happen, it seems to me like it would be very top-heavy with administration versus really helping the clients that need it. So that's all I would say about that. That's concerning. That's where a good part of the budget would be going and not serving the clients. Thank you.
Thanks. I appreciate the concern. I think it's certainly a concern that we've heard before. What I would say is that the data that we have around how executive compensation works clearly shows that smaller organizations pay executive directors at a much lower rate than larger organizations. I will admit it is certainly one of the inefficiencies that you might have as a really small organization, where a higher proportion of your budget would have to go to an executive salary as a small organization than as a large organization. We aren't like hospitals. We don't have executives making many millions of dollars in any scenario. And so I think the issue here is more of one of our member organizations needing to exist within the market, and being unable to to compete in that market because of an artificial cap that is placed in statute. We don't cap the salaries of companies that we contract with to build bridges or pave roads in Connecticut. We would never say to one of those companies who wins a bridge building contract in a competitive bidding process, just like a DDS provider wins a group home contract in a competitive bidding process with the state, hey, looks like your administration, you're paying your CEO too much money and your administrative costs are way through the roof. They might have an uncompetitive bid and not win the bid if that were the case, but nevertheless. Nor do we have these caps in the rest of the Health and Human Services system. There's 7 or 8 other state agencies that contract for Health and Human Services outside of DDS and DEMIS, and those statutory caps don't exist for them either.
Yes, thank you for that answer. But, you know, for the taxpayers foot a large amount of the bills across the board, and we do weigh in all the time on whether it's state workers or whoever, we weigh in all the time on salaries. I'm just pointing out that proportionately it would be very top heavy if you were going to increase it like that. But thank you for your testimony today.
Thank you, Rep. Mara.
Thank you so much, Mr. Chair. Okay, so I'm just getting this correctly, that you are in support of repealing the caps, and that makes a lot of sense to me. Curious, because you say that that the nonprofits don't have to receive funding from the state if the state doesn't think that the nonprofit is running the way it should, if it's too top heavy.
Yeah, that's correct. I mean, as a provider in these systems, you're contracting with either DDS or DEMIS in either case, or both, to deliver services to people who are eligible for DDS and DEMIS services. You have gotten that contract because you responded to a state request for services, an RFP or an RFQ or one of those things. There was a competitive bidding process. Other providers probably bid on that contract, and the state chose a provider based on all different factors: cost, quality of care, their need, et cetera. And so it's very similar to how the state contracts with any other business for any other service.
Okay, so this is particularly for the groups that have contracts with the state. This is
Correct.
not, okay, so you're not speaking of, because sometimes we go through kind of line items and say, oh, you get 4 million, you're not talking about that.
Yes, that's correct. So this is very different and distinct from the process of legislatively directed funding. I've had this conversation with the Government Oversight Committee this session. This is the portion of the budget that pays for the state's health and human services infrastructure. It's managed under the Office of Policy and Management in a purchasing system called the Purchase of Services System, which is one of the state's different procurement systems, and that's the one that manages the state's health and human services system.
Okay, so are your books kind of open to the state anyway?
Very much so. Yeah, our members receive multiple overlapping levels of fiscal and programmatic oversight from the state, very much including financial review from their contracting state agency throughout the fiscal year, and then audited financial review at the close of the fiscal year.
I wish we could do that with all our nonprofits we give money out to. But thank you. I appreciate that, and I agree.
Thank you. Seeing no other questions or comments, thank you for your patience with us today, and
thank you for your patience with me. I appreciate you taking me out of order at the end.
Of course. Well, last but not the least, we have Karen Griffiths, who's here, respiratory therapist, who chose to save lives instead of talking to us. So now, after saving a few lives, she's here. Welcome.
And I appreciate you letting me bump my time till later this afternoon. So good afternoon, co-chairs, Senator Anwar, Representative McCarthy-Vahey, as well as Senator Summers, Representative Clarides D. Tria, and members of the Public Health Care Committee. My name's Karen Griffiths. I'm a respiratory care practitioner, chair of the Educators Committee for the Connecticut State Society for Respiratory Care, program director for respiratory at the University of Hartford, and I also served on the General Assembly's task force on the shortage for respiratory therapists, radiology technologists, and nuclear medicine technologists. I'm here today on behalf of the Connecticut Society for Respiratory Care to respectfully ask that you add a provision to House Bill 5513. Respiratory therapists, also known as respiratory care practitioners, assess and treat patients with breathing and heart and lung disorders. They manage ventilators, deliver oxygen and aerosol therapies, and provide emergency support. Respiratory care practitioners are essential across every level of care in our hospitals. Yet, we continue to face severe ongoing workforce shortages that can lead to higher patient to therapist ratios, increased risk of errors, and poorer patient outcomes. During the COVID-19 emergency, Governor Lamont's executive order allowed students in accredited respiratory programs to work in hospitals under direct supervision of licensed therapists. Those students were extremely valuable and performed safely. Now that the emergency is over, that option is gone. We are asking to build on that proven success by creating a student respiratory care practitioner limited licensure. This would allow qualified students in accredited programs to provide supervised care while they finish their education, helping to relieve staffing pressures without compromising safety. This is not a shortcut to full licensure. Students would remain strictly limited in scope, always under direct supervision, and would still be required to complete the program and pass national board exams before practicing independently. This model already exists in other states and is supported by the American Association for Respiratory Care. If adding the student license feels too large a step right now, we would respectfully ask in the alternative that a bill direct the Department of Public Health to study this issue as part of this year's scope of practice review. Thank you for your time, and I'm happy to answer any questions or provide any additional data.
Thank you so much for your testimony. Have you submitted a written testimony as well?
I did, a little more detailed written testimony I submitted.
Okay. So we will have to do a little more homework. We are looking at a number of things, but we value your thoughts and we value you coming here. We will read and be able to get to a point that we can have more conversation.
Okay.
My co-chair also has a comment and question.
Just a quick comment. Karen, thank you for your work on our, I'm going to say working group. That's been a theme today, but it was an important conversation, and I appreciate you coming and sharing this today.
Thank you.
Thank you so much. Seeing no other questions, thank you for being here.
I appreciate your time.
Thank you. And Madam Chair, this is our last public hearing? Unless we have another bill? No. Okay, all right. So we just wanted to thank everyone who's here today, but everyone who's been part of the public hearings, the people who came to speak, and our CTN who's been covering, because we forgot to thank you a few times, and all the staff for all the teamwork that we have played, Madam Administrator and everyone else. So thank you, Madam Co-Chair.
We will be back, I believe, Wednesday is the next time we are together, but I don't have notes in front of me, so I'm not going to quote anything right now, but that's, I believe, our next committee meeting. Thank you.
And we stand adjourned. Thank you.